jointly with the Committee on Hospitals. Will all council members and council staff please turn their video on at this time? Please place all cell phones and electronic devices to vibrate. You may submit your testimonies to testimony@council.nyc.gov. I repeat, that's testimony@council.nyc.gov. Thank you.
Chairman, you're on mute.
There we go. Take two. Good morning, everyone. We're going to gavel in. And I want to thank you all for joining us at this virtual joint hearing. Thank you all for being here. I want to first thank my co-chair, Councilmember Carlina Rivera, as well as Speaker Corey Johnson, who's joining us today. And I'd like to turn it over to our speaker for opening remarks.
Thanks, Mark. Good morning, everyone. I'm Councilmember Corey Johnson, the Speaker of the New York City Council, and I'd like to start off by thanking my colleagues, Council Members Levine and Rivera, for holding this joint hearing. Today, we'll discuss the city's plan for COVID-19 testing and contact tracing. We expect to hear from New York City Health and Hospitals, the Department of Health and Mental Hygiene, and members of the public. I am glad the administration is here today, and I want to thank them for their work during these immensely challenging times for our city. Since the novel coronavirus first emerged in late 2019, it has spread rapidly around the world. Extreme preventative measures such as social distancing put in place in early March may have helped stem infections. Hospital capacity has stabilized, but the city has taken a beating. And on May 4th, Governor Cuomo announced a phased, regionally based reopening plan for the state set to begin today. Contact tracing plays a very big role in this plan. There are numerous considerations and steps needed to ensure our contact tracing program is successful. For example, there needs to be support provided to those who will need to isolate, including resources and wraparound services as needed. There needs to be wide-scale and accessible testing, a robust and culturally representative and inclusive test and trace staff, and clear communication with the public, including those who do not speak English as their primary language. The communities hit the hardest by this pandemic, which data indicates as Black and Latinx New Yorkers must be involved in the test and trace efforts. We also know that individuals who are undocumented, disabled, experiencing homelessness, and incarcerated, and those who are incarcerated have been greatly impacted, as has the Orthodox Jewish community. This program, the program should help to continue to examine and address equity concerns related to the pandemic. Going into this, we know that a test and trace program is complex, multifaceted, and crucial to the reopening of the city. We also know that for many, many years, contact tracing has been performed successfully by experts within the Department of Health and Mental Hygiene. But last week, Mayor de Blasio announced the formation of New York City Test and Trace Corps, which is to be housed and run under Health and Hospitals. While DOHMH will be involved in the Corps, it is unclear why it was decided that Health and Hospitals should lead such an immense effort. What is clear is the serious dysfunction playing out behind the scenes at a time when New Yorkers desperately need to have confidence in their city government. That confidence has been eroded daily by leaks and agency versus agency infighting. The future of our city is literally hanging in the balance. Enough is enough. New Yorkers deserve better. Today, we will seek a more thorough public explanation as to why the Department of Health and Mental Hygiene is no longer the lead on work they have done for individuals diagnosed with HIV, Ebola, and other infections for decades. Contact tracing has always been a core function of the health department, an agency the city council has oversight over, and it regularly oversees similar efforts to contain outbreaks of sexually transmitted diseases, tuberculosis, and other communicable diseases. Although Health and Hospitals has been a major leader in the fight against COVID-19, and we're grateful for that, contact tracing is simply something that they have not previously been responsible for. We need to know if they are up for this task and how they will accomplish it. Now is not the time to gamble with people's lives. Now is not the time to potentially delay a massive undertaking, which requires onboarding thousands of people and being able to test tens of thousands of people per day. The health and economic impacts of the pandemic are enormous. Our city is strong and resilient, and we are all eager to return to a way of life more closely resembling the past. In order to reopen quickly, efficiently, and safely, our track and trace program must be strong. I am proud of the work that we have done so far, and I look forward to discussing the city's preparedness in greater detail today. I want to thank you all for attending, and I will now turn it back over to Councilmember Levine, the chair of the Council's Committee on Health.
Thank you so much, Mr. Speaker. Good morning again, everyone. I am Councilmember Mark Levine, Chair of the City Council's Health Committee. And in addition to thanking you, Mr. Speaker, and of course our co-chair, Councilmember Carolina Rivera. I've experienced 8/11 many times over. I know how painful this is for everyone who's part of this hearing today. And so as we move forward, nothing matters more than minimizing further loss of life. That's what's at stake with the contact tracing program we're discussing today, as our city undertakes what is arguably the biggest and most complicated effort so far in our battle against this horrible pandemic. It's not an exaggeration to say that if we don't get this right, if we don't get testing, tracing, and isolating right, there is no reopening of our economy safely, period. So all of us need to be obsessed with getting this right. The good news is that we have the greatest health department in the nation, a department with vast experience in exactly this kind of work. When graduate programs in public health around the nation study contact tracing, they study the exemplary work of the New York City Health Department. Our health department did successful and pioneering work with contact tracing as a tool to battle HIV. Our health department built a large and successful system for contact tracing in the TB outbreaks of the 90s and beyond, et cetera, et cetera. And contrary to what you might think, these tracing programs were not small. In the 2014 Ebola outbreak, we had to trace thousands of travelers from affected areas of Africa. These successful contact tracing systems are still in place in our health department. Some of the same innovative leaders who built these programs are still in our health department. So you might think that as we confront the coronavirus pandemic, contact tracing would be led by the agency whose core mission, as defined in the New York City Charter, is, quote, the control of communicable and chronic diseases and conditions hazardous to life and health, unquote. You might think that we would do what every other jurisdiction in America is doing, that we would have our health department run contact tracing for COVID-19. As you all know, this is not the case. We are, in fact, rebuilding these systems in another agency. And to anyone who says that we had to take this vital program out of the health department so the contact tracers could be union jobs, that's not true. These could have and should have been union jobs at the health department. To anyone who says we needed to take this program out of the health department for ease of contracting, well, we're under a state of emergency declaration now, which greatly eases contracting at DOHMH and all agencies. Now, please don't mistake my comments as a critique of H&H. I hold our public hospitals in enormously high esteem. I know well and have worked closely with both Dr. Mitch Katz and Dr. Ted Long and have enormous respect for their abilities and accomplishments. My concern rather arises out of our failure to capitalize on the strengths of DOHMH. One such strength is their ability to gather and publicize data in a way that serves the public while respecting privacy. To ensure we get that right, we'll be hearing today an important bill, a pre-considered introduction by Councilmember Richie Torres, which will require daily reporting on details of the contact tracing program, including the number of employees of such program and language spoken, as well as the number of individuals identified and interviewed for the purposes of the program, disaggregated by the race, gender, and age of the individual. Such information is critical in our fight against a pandemic that has been defined by profound racial inequality. That's why one of the key questions we need to address today is the extent to which community organizations on the ground in the most impacted communities have been given a formal role in this program. Contact tracing will be complicated to explain to New Yorkers. There will be enormous concern about privacy, about the challenges of quarantining, about enforcement. We need to have public trust and confidence in our contact tracing program. We need there to be full transparency. That's why we're holding this hearing today. And I very much look forward to a robust discussion with the administration and to including the voices of advocates, experts, and members of the public. Thank you all for being part of this. And now I'd like to pass it off to Councilmember Rivera for opening statements.
Good morning, everyone. I am Councilmember Carlina Rivera, Chair of the Committee on Hospitals. I'd like to start off by thanking my colleagues, Speaker Johnson and Councilmember Levine, for chairing this hearing with me today. As the Speaker and Councilmember Levine discussed, we will be examining the city's plan for COVID-19 testing and contact tracing. As the Speaker and Councilmember Levine mentioned, our public hospital system, H&H, will be leading this massive and crucial effort. H&H hospitals bore the brunt of the COVID-19 onslaught during one of the bleakest periods in our city's history, and the efforts of H&H staff, doctors, nurses, technicians, custodial staff, administrative staff, all staff, were nothing short of heroic. Thank you. In my nearly 2.5 years as a chair of the Council's Committee on Hospitals, I've seen the many challenges that our public hospital system faces, some of which they've overcome and some that they are still working to address. But I've always been proud and confident of everyone working at H&H, where no one seeking care is ever turned away, regardless of their insurance status or ability to pay for medical services. And during the pandemic, I've gotten to know many of the team members at DOHMH, and while I've certainly had questions and concerns with some of their decisions, I never questioned their belief in working to address this crisis as best they can. Today, though, I'm disappointed. I'm disappointed that our two health-related agencies have had their infighting exposed in the New York Times, Politico, and other media outlets. I'm disappointed that the de Blasio administration decided that the middle of a pandemic was the best time to institute a bureaucratic reshuffling that potentially creates new and unnecessary obstacles for the critical, complicated, and sensitive work of contact tracing. I know Dr. Barbeau, who is not here today, and Dr. Katz would rather focus on the mission at hand, curbing the COVID-19 pandemic. So while we must address these concerns today, I also hope we can focus on today's hearing topic, contact tracing. Let's focus on the policy. It's precisely because providing quality medical care is at the core of H&H's mission that I have such concerns about H&H leading the city's massive, complex, and crucial contact tracing program. I have great faith in Dr. Long, who has been essential in helping H&H navigate this crisis. But how will this added responsibility impact our hospital system, which was nearly strained to the breaking point just weeks ago? Who will take over the work Dr. Long and others at H&H have been focusing on to ensure H&H remains ready to provide the vital health care that so many New Yorkers depend on? And how will H&H, for the first time, handle running a program that for over a century has been in the hands of DOHMH? Numerous public health experts have raised these concerns in the past few weeks, and New Yorkers deserve assurances that their hospitals will continue to be there for them as we begin reopening the economy, and especially if, God forbid, another wave of infections is unleashed on the city. I hope we'll hear these answers and more today, and I hope that if after these policies are seriously examined, the de Blasio administration will commit to making the right decision about who leads the contact tracing program, regardless of the political consequences. Thank you all for attending today. I would like to now acknowledge our colleagues who have joined us today. Council members Powers, Holden, Reynoso, Cohen, Maisel, Eugene, Ampry Samuel, Lander, Moya, Rosenthal, Barron, and Yeager. Before we begin hearing testimony, our committee council will go over some procedural items.
Thank you, Chair Rivera. I am Sarah Liss, Committee Counsel in the Legislative Division of the New York City Council. Before we begin testimony, I want to remind everyone that you will be on mute until you are called on to testify. After you are called on, you will be unmuted by the host. If at any time you place yourself back on mute, you will need to be unmuted again by the host. Please listen for your name to be called. I will also be periodically announcing who the next panelists will be. We will first hear from members of the administration. Dr. Mitch Katz, President and CEO of New York City Health and Hospitals, Dr. Ted Long, Executive Director of the Test and Trace Corps, Jackie Bray, Deputy Executive Director of the Corps, Dr. Andrew Wallach, Chief Medical Officer of the Corps, Dr. Jay Varma, Senior Advisor for Public Health to the Mayor, and Dr. Dimitri Daskalakis, Advisor, DOHMH Deputy Commissioner for Disease Control. I will first administer the oath, and after, I will call on each panelist separately from the administration to respond to the oath. Chair Levine will then cue you when it is your turn to testify. I would like to remind everyone that unlike our typical council hearings, we will be calling individuals one by one to testify. Council members who have questions for a particular panelist should use the raise hand function in Zoom. You will be called on after the panelists have completed their testimony. We will be limiting council member questions to 5 minutes, and this includes both questions and answers. Please note that for the purposes of this virtual hearing, we will not be allowing a second round of questioning. Thank you. After I administer the oath to all members of the administration that will be testifying or answering questions, Chair Levine will cue Dr. Mitch Katz to testify. I will now administer the oath. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions? Dr. Katz?
Yes.
Dr. Long?
Yes.
Deputy Executive Director Bray?
Yes.
Dr. Wallach?
Yes.
Dr. Varma?
Yes, I do.
And Dr. Daskalakis?
Yes, I do.
Thank you all. I will now turn it back to Chair Levine.
Thank you very much, Sarah. And now, Dr. Katz, you can begin your testimony as soon as you're ready.
Thank you so much. And I want to say good morning to the speaker and to Chairwoman Rivera and to Chairperson Levine. And thank you for holding this hearing. Thank you for inviting us. I'm Dr. Mitch Katz. I'm the President and CEO of New York City Health and Hospitals. I want to introduce you to our great team that are doing the testing and contact tracing core. With me today is Dr. Ted Long, who's the Executive Director of Testing and Tracing, Jackie Bray, the Deputy Executive Director, Dr. Andrew Wallach, the Chief Medical Officer. Dr. Jay Varma is the Mayor's Senior Advisor for Public Health, but also was previously the Deputy Commissioner of DOHMH, and Dr. Dimitri Daskalakis, who is currently the Deputy Commissioner for Disease Control at DOHMH. Also part of our team is Dr. Neil Vora, who is from the Department of Health and Mental Hygiene. He's going to be the Director of Tracing, and Dr. Amanda Johnson, the Director of Isolation. So I hope that you can see that the team that's going to be doing this function for the city is an integrated team of both health and hospitals and DOH-MH and the mayor's office working together with our common goal, which has been stated well by the chairs, that we want to get New York City reopened in a way that is safe, and we want to do it in a culturally competent way. When the mayor announced the creation of the Test and Tracing Corps, the vision that underlies it, and I think this is so important about understanding where we are, is that there are three pillars. Contact tracing will not work. In fact, it cannot even be begun without testing. And once we have done contact tracing and people need to be isolated or quarantined, it will only work if there is a safe place for people to go. Many people in our city cannot quarantine or isolate in their homes. They're living in cramped multi-generational family homes where there is a risk to other people. So I think that the vision of having this as an organized project, collaboratively done by health and hospitals and DOH-MH, makes much more sense when you think about it as three pillars. I think there would be tremendous harm to think that contact tracing done in isolation from the ability to do the testing and the ability to isolate people could be nearly as effective. In terms of those functions, I'm very proud of how well Health and Hospitals has done on testing. We have currently stood up 23 different testing sites in our most affected neighborhoods. We are currently doing 14,000 tests per day. That is not me misreading the 14,000 tests per day, and our aim is to get up to 50,000 tests per day. We've also already organized hotels where people can be isolated or quarantined. And from our experience earlier on in COVID, and just as my experience as a primary care doctor, one of the important lessons is that the reason you may be isolating or quarantining someone is because of COVID. That doesn't change the fact that they have diabetes or hypertension or severe asthma. You can't actually isolate and quarantine people without their medicines, without the ability to be able to quickly hospitalize them if they require hospitalization. So our vision, and the vision that underlies this program, is the idea that these three pillars would happen smoothly in an integrated fashion. It in no way takes away from the tremendous expertise, experience of DOH-MH doing contact tracing. Dr. Dimitri Daskalakis has already identified 40 supervisors who work for DOH-MH who will be not only involved in the training, but in assignments in doing the difficult work that is required when people are not following orders or don't understand orders or need additional help to know what is the right way to handle someone. We've dealt with many difficult situations together in the past few months. There have been so many unknowns about this virus. I do think that the fact that Health and Hospitals is able to hire people rapidly makes a difference. I certainly understand what you're saying, Chair Levine, about appreciating the idea that they would be hired by DOH-MH. I would say that that was not a prior plan, that the prior plan would have had them be hired by a non-governmental entity. I make no apologies for being a public sector person and believing in the public sector and believing that critical government roles should be done by government employees. Others can differ and feel that, well, in order to have the speed and have it not be in Health and Hospitals, it would have been better to go with a non-governmental, non-profit entity, but that would never be what I would say. I do believe in the public sector, and I think that the experience of Health and Hospitals doing this work very successfully around COVID shows the sense that this council showed in always supporting health and hospitals and making sure that we are around to care for people. Also, I want to note that when people are in isolation and quarantine, we also have to not only meet their medical needs, but we have to meet their needs for food. We have to meet their needs for social services. Having Jackie Bray, who used to be the deputy director for the Department of Social Services, is a great gain for us. And I think, again, these are services that we are used to providing for our patients, along with the kind of remote medical care that they're going to need. I think I don't want to take up more of our time. I know that the council has important questions and important recommendations and guidance you want to give us. My recommendation would be that the comments that I did were reviewed by all of our team members, and that would serve as our initial statement. I'm sure that you will have questions, and I will answer those that I can. I will send those that pertain to other areas to one of the other panelists, or if obviously if members of your council have a specific question, you'll tell me that you'd like somebody to answer a specific question, and so they will. Thank you so much for the opportunity to testify before this council.
Thank you, Dr. Katz. I just want to hop right in, and you may have addressed some of this in your opening statement, but again, I think it's important to get these answers on the record to some of the questions that the council has today. Why was Health and Hospitals the entity that treats infectious disease rather than DOH-MH, the entity that monitors and contains infectious disease, chosen as the lead agency for this massive initiative? Why was that decision made?
Because two of the three pillars necessary for success were already in Health and Hospitals. The testing piece was already Health and Hospitals, and the hotel program that would isolate and quarantine people in their rooms was in Health and Hospitals. And so then the third part, which we would, of course, recognize the tremendous expertise, ability, skill of DOH-MH, we have. We don't have to lose that. I don't see the loss. I see, as part of our team, Dr. Daskalakis. I see Dr. Varma, who used to be part of DOH-MH. I see Dr. Vera, who's not here with us today, from DOH-MH. I see the 40 supervisors from DOH-MH. The computer systems and the data systems remain those of DOH-MH. What I feel we have to offer is the ability to rapidly hire 1,000 tracers in a very short period of time and still have them be a government employees. And I think that those things together are what are the strongest factors to me.
So it was only an operational decision?
Yes.
And H&H is not, of course, all hospitals in New York City. They only have, they don't have all of those two pillars. How will you coordinate with the private hospitals?
So you're absolutely right, Speaker. We are 11 hospitals, but all of the testing sites are now being run by, the community testing sites are being run by Health and Hospitals. Hospitals are, of course, doing testing themselves of their own patients, but the community sites, which are in all of the ethnically diverse neighborhoods of New York City and NYCHA sites, those are Health and Hospital testing sites. Of course, go ahead.
No, go ahead, Dr. Katz.
Of course, when hospitals have cases, they will get reported through the DOH-MH system. They will get assigned to tracers, and the tracers will identify those people. If some of them need to be quarantined or isolated, they will be quarantined and isolated in a DOH-MH, a Health and Hospital hotel. If that person then needs to be hospitalized at a different hospital because that's where they get care, that would not be a problem.
At what point was this decision made, and who was ultimately responsible for making this decision?
Mayor announced the decision last Friday. Mayor is the one who's responsible for organizing the work and responding to this awful pandemic.
What does H&H usually do contact tracing?
Well, again, my view is that what I am doing is hiring 1,000 people rapidly. I am doing the work that it takes to have 1,000 city employees. Everybody has to have a desk or a computer, or they have to be paid. They have to be logged into the system. There is a tremendous effort to do that. The ultimate supervision, the part that is what you most worry about and care about and should care about, we still have all of our partners at DOH-MH. I know Dr. Barbeau is not here, but she has expressed to me on multiple occasions that to her, the most important thing is getting the job done. And I think we have a structure where we are not losing anything. We are maintaining all of the same expertise, but we are getting the ability to hire faster, and we're connecting it more closely with the other two pillars.
I agree with the city council. I can speak for myself. We just want to see an effective program. We want a program that works, that gives confidence to New Yorkers, and that gets the job done, given how important this is. From the press reports I've read, though, it doesn't seem like this was the health department's first choice, that they wanted to keep contact tracing in-house. I don't know, again, how that decision was made with all the pieces that you just talked about. But I would hope that, of course, Dr. Barbeau and anyone wants to ensure that this gets done quickly and appropriately. How do we ensure a seamless partnership between H&H and DOH-MH, who have experienced contact tracers already on staff?
Well, again, I think it starts by close collaboration between me and Dr. Barbeau, which exists. There is close collaboration between Dr. Ted Long and Dr. Daskalakis. They have worked together, and maybe this would be a good time to talk to ask Dr. Daskalakis to talk about how, in the terms of the complications of contact tracing, how the collaboration is going to make sure that people are appropriately contacted, given the correct advice.
Thank you, Dr. Katz. So I think you've captured really one of the main features of this pandemic response, which is it is a multi-agency response, and many of the tasks that were traditionally thought of to be Department of Health tasks have been expanded to other agencies throughout the city. And this is an example of one of those tasks that will be at H&H with heavy assist from Department of Health. So as Dr. Katz said, we are working feverishly with Dr. Long and the rest of the team to really establish protocols as well as guidance to make sure that this goes off seamlessly, but also beyond providing protocols, we are providing 40 of our best staff to make sure that that for the city, we work together very closely in an integrated way to execute contact tracing appropriately and with a very close eye toward equity and community and the community's needs. I think one really important feature of this is that it seems as if we discuss it a lot as a public health intervention. So this is a public health emergency, and this is an intervention, but I think that one of the prime ways that DOH-MH and health and hospitals will collaborate is to really look at this as more of a service to the population who may need specific assistance to make sure that they can stay safe if they are living with COVID-19 or if they are potentially exposed.
Why couldn't the Department of Health and Mental Hygiene do this just as quickly and add in the technical support on testing and follow-up?
Well, I'll start and then let other people talk. I think, again, that as an agency, our ability to hire is much more rapid. I think, as you've referred to, Speaker, in the accounts that you saw, that the alternative way to get around the challenges in hiring within a city department was to use a non-governmental entity. that was the proposed solution for the fact that it, to no detriment of DOHMH, it is challenging even under emergency orders to rapidly hire people. The emergency orders affect contracting. They do not waive employment issues. They do not waive the city's rules about hiring. And as an agency, we have the ability to hire more rapidly. And I think that the alternative vision was not a vision that the 1,000 tracers would be government employees under DOHMH. I understand why people might have preferred that, but that was not the choice. The choice was that they were going to be government workers for health and hospitals, or they were going to be hired by a non-governmental entity.
The way in which this was rolled out, I think, has given many New Yorkers serious concern about the ability of these agencies to be able to collaborate and work together and do this well. What assurance can you give us in the public that the sniping that we have seen, the back and forth and the criticism won't undermine this process? How do we know that decisions made won't change if there are some other internal disagreements?
Well, Speaker, I think it's great that you're holding this hearing, right? I think that it's always a cathartic to, see everybody, even if sadly in times of COVID, we're seeing each other on computer screens, but we're all here, including members of DOHMH and members who were previously part of DOHMH, and we are committed to the success. I would also say that I have not read any attacks on me that were by Dr. Barbeau or Dr. Daskalakis, nor have I made any attacks on DOHMH that have been on anyone in DOHMH. So I can't ignore the thing. I've read the same things you've read. I've seen the same things that you said. I think we can all agree that not everybody is happy about this particular structure. There's no reason to pretend that everybody is happy with it. But I do think that at the end, one of the great things about your having the hearing is what I keep hearing is the most important thing is that this project succeed. The most important thing is that we go forward, we get New York City safely out of lockup, we handle this in a culturally appropriate way. We are already hiring, we are already training, and we have a method of collaboration that is working.
I agree. We want it to succeed. And as I will always say, it's our charter mandated responsibility to do rigorous oversight of city agencies as the city council. And on a program as important as this, that's why we're having this hearing today to ask those questions that the public may have and that we may have to understand how this is going to work and is this being done effectively and appropriately. If someone, Dr. Katz, you can do it, or if someone from DOHMH or Dr. Varma, whoever wants to answer this, just so, again, the public understands, what are the core functions of the Department of Health and Mental Hygiene? You were a public health commissioner in San Francisco and in Los Angeles.
I was, well, in San Francisco, I was the public health director for 13 years. In Los Angeles, I was part of the health agency that integrated public health along with health, but as separate departments. I think Dr. Daskalakis, most appropriate for you to answer, because New York City is very lucky to have and to continue to have a great public health department.
Thank you. So I think we have a lot of core functions. I think the most important and the central tenet is to protect and promote the health of over 8 million New Yorkers. And so that is really our mission and our really go-to, our home-based core function. Our work is actually pretty diverse in terms of what we do. It involves both messaging as well as interventions that touch multiple conditions. So in my piece of the world, which is in disease control, most of the focus is on infectious diseases, but also very heavily on equity issues as it relates to healthcare access, as well as populations who are overrepresented by certain diseases and conditions. So our work ranges from HIV, heart disease, all the way to bioterrorism. I mean, we have a very broad range and a broad portfolio of what we do.
Just tell me quickly, which infectious diseases does the Department of Health work on a regular basis?
Well, we have about 90 that are reportable, but I'll focus on the ones that are at least the ones that are that have bureaus in effect. So as you're familiar with, we focus on vaccine preventable diseases, given our work during the measles outbreak. We work in HIV, and that specifically is both measuring as well as interventions like partner notification and also returning people to care, like I said, along with other prevention measures. Tuberculosis, so we do have our own tuberculosis clinics. And along with that, we also manage through directly observed therapy around 50% we actually take care of 50% of the tuberculosis patients and then monitor most of the others through directly observed therapy, and also are involved with case investigations there. Viral hepatitis, as well as many other communicable diseases we cover. I think you're familiar with our work, given your great support on both HIV and STI, in sexually transmitted infections. Some of the most amazing sexual health clinics in the world are under the Department of Health, and have launched many, many innovative programs along with measuring, also work to both identify and treat these diseases, prevent them, and also in a very sort of new strategy in the last few years under ending the epidemic, really create these to be spaces that do HIV prevention. So we do investigate diseases. We also work very diligently on policy development around that. We also do assurance of what the care horizon and prevention horizon looks like in New York City. And really, we interact with all levels of government and all agencies around these critical issues.
Thank you. I have a lot of questions, but I'm not going to have a chance to ask all of them because my co-chairs need to get to their questions, and we have a bunch of other council members that want to ask questions. But I do want to ask my colleagues just to give me a couple more minutes so that I can sort of provide some sort of top line questions that I think are important to get at the outset of this hearing. At the oversight hearing on New York City's preparedness for coronavirus COVID-19 that was held on March 5th of this year, the Department of Health laid out the activation of the incident command system, which transitioned DOH-MH employees in various roles to position that directly responded to the pandemic. One of these positions filled was disease detectives. Will these positions and other yearly positions in DOH-MH continue to provide services to fight COVID-19?
I'll let Dr. Daskalakis answer. But
great. So I think we are absolutely going to be using those disease detectives to work in the COVID-19 space. I feel like, as you've heard, and I think maybe you'll hear more, the sort of trace function of the program that will be housed at H&H is only a part of it, a very important and big part. But we will continue to do our work and go deeper into that work in congregate settings and other environments where our disease detectives will be pivotal in controlling higher risk outbreaks across the city. So as test and trace becomes more of a dominant force in New York City, we will also then have the opportunity to focus deeper into areas where morbidity and mortality are higher.
How will H&H and DOH-MH ensure that there isn't duplication in the work?
I think the most important are the people that appear in the little squares over our head on the screen, that we've put together a team that includes both H&H and DOH-MH people. And frankly, we are all working too hard, too busy, and have too much to do to possibly duplicate each other's work. I think the chance of duplication is much greater if we're trying to do things separately. And one group is trying to trace people and a different group is trying to figure out where they're going to live. I think that by being together and putting the three pillars that are interdependent together, we will decrease duplication.
Will the incident command system continue to exist?
Yes.
Will it still be housed in the Department of Health and Mental Hygiene?
Yes.
Can you describe the reporting structure of this contact tracing program? What will be the different components and divisions of the program? For example, is there a division of contact tracers, a division of supply accrual, a division of testing, a division of wraparound services? Who will be in charge of each one of those components and divisions? Who will report to who? If you could explain that, and will the results of the contact tracing be published with other indicators on a daily and weekly basis?
All right. Thank you, Speaker. I'm going to ask Dr. Ted Long, since he's the executive director of the Corps, to explain the different who's doing what. And then maybe he or Dr. Daskalakis wants to answer the question about data.
Great. Mr. Speaker, thank you for the opportunity to speak here today. For those that don't know me, my name is Ted Long. I'm a public hospital primary care doctor, and throughout the coronavirus crisis, I've continued to see my patients to get them through this. Concurrent with that, I spent a lot of time in our front lines, and when we were nearing our darkest hour, when we were nearing the coronavirus peak, we were tripling the sizes of our ICUs, quadrupling them in some hospitals. We didn't have enough doctors. We didn't have enough nurses. We acted fast. And I'm proud to be here today with you all, knowing that we got through. We brought, through an effort that I led, thousands of clinicians from across the country to health and hospitals with lightning speed to get our frontline staff through. And our frontline staff now feel that this is one of the most critical things that we did to not only survive, but continue to provide the highest quality care with no exception to every New Yorker throughout the crisis. And we're very proud of that. And we want to apply the same principles here. So I'll talk about the three different pillars, and I'll highlight how we're applying that principle of bringing people with rapid speed on the trace pillar. So the first pillar is testing. Testing is something that we, before this program was created, have been doing since the beginning of coronavirus. It's always been important to test people as it changes what we do with them. We've been doing testing at our site since FEMA deployed in March, and we guided that deployment. Since then, I'm proud to say we've opened 23 testing sites in some of the most vulnerable communities in New York City. We've provided tens of thousands of tests to those communities through those sites within health and hospitals alone, and we're coordinating with other systems.
Dr. Long, I don't say this in any way to be rude or to cut you off. There's just so many questions that I have. The questions that I asked, I really just want to, there's so much I want to get through. The questions I asked on the structure, on the reporting structure, on the management structure, on the divisions and components. If you could just walk us through that, that would be extraordinarily helpful.
Yes, absolutely. 3 divisions. First, testing, led by our Chief Medical Officer, Dr. Andrew Wallach. Second, division, trace, led by Neil Vora from the Department of Health, with the 40 experts that Dr. Daskalakis described coming along with him to be our supervisors, leaders, and leaders. Third, take care, if you will, or how can we make people successful isolating when they're either at home or in hotels? And that's led by a primary care doctor on my team, Dr. Amanda Johnson. The underpinnings of each of those 3 divisions, because there's so many things that cut across, IT cuts across, staffing, facilities, supply chain. We're leveraging to the greatest extent possible everything that we're really good at here at Health and Hospitals in terms of building things at scale and doing them fast. The same thing that we've done at every step of the way through coronavirus. And if I can give you one fact just to highlight this, the trace operation with the reporting structure leading up to Neil Vora from the Department of Health, Dr. Daskalakis and I talk 10 times a day. We're in very close contact about all of this. We are a true team in this. I can't do it without him. I hope he feels the same. Because I'm going to tell you that as of today, we're currently training 1,000 tracers as we speak, and we have 500 that are being onboarded today. That's really fast paced and mirrors how we brought thousands of doctors into our system almost overnight that really got our hospitals through this for New York.
And who reports to who? Ultimately, you're at the top of the organizational chart on this, and then the 3 heads of the divisions report to you?
Correct.
And where do Dr. Varma, Dr. Katz, and Dr. Daskalakis fit into this? What is their role on a daily basis to understand how the expertise that these folks have in this process?
I'll take the start of it because ultimately, the responsibility does rest with me with making sure that all the parts get done. So Dr. Long reports to me, and part of what I bring is the ability to hire legal, IT, supply chain, all the things that Health and Hospitals has so that they bear fruit in this project. Dr. Daskalakis, of course, reports to Dr. Barbeau. Dr. Barbeau is my colleague, and we are, involved daily in talking about these issues, making
and
sure
Dr. Varma?
Dr. Varma, as you know, it used to be at DOHMH, now working with the mayor's office, connects us to the mayor's office, which has had a huge role in a lot of the operational issues underlying COVID, such as making sure we have enough reagents, making sure we have enough PPE, making sure that we have the right partners to contract with.
And is there an organizational chart that exists on paper that could be shared with the city council so that we understand? Okay, great. So we look forward to getting that. I want to move on. I didn't get an answer, Dr. Katz or Dr. Long, on will the results of contact tracing be published with other indicators on a daily or weekly basis?
Dr. Long, Dr. Daskalakis, do you tell me what you have imagined in your planning together?
I'll start and then I'll turn to Dr. Daskalakis. Mr. Speaker, we are all for transparency. So whatever is within operational reason, we're very happy to provide on whatever basis will be most helpful to you. Some things that we track closely to in case they're helpful also to you are as we're able to hire people and as we're able to build up that workforce. And then not yet because we don't have the workforce yet, but soon as we're actually conducting the contact tracing and the testing itself, those will be key indicators for us.
But it's not really about giving information to me. I mean information for the public, for New Yorkers. How are we going to figure out how to communicate these numbers in a transparent way so New Yorkers understand what's going on? Will you all have the ability to do that on a daily or weekly basis? What is reasonable? What can New Yorkers and the press expect who are going to be reporting on this?
I think certainly on a weekly basis, absolutely. I think we are actually do, for example, report on a daily basis how many tests we have.
And how can we ensure timely and accurate reporting from both public and private laboratories, as well as medical providers, that they are reporting these things in a timely and accurate way to the health staff at the track and trace core that we're talking about?
Well, COVID is a reportable disease. Dr. Daskalakis and DOHMH receives the reports through the state system. We're also report on the percentage of positive tests every day. I believe, Dr. Daskalakis, there is a 2-day delay on when you have accurate information. Is that correct?
Thank you. It's actually not a delay of all of the testing, but the tests become more complete. So the majority of lab results do come in a very timely way, but there are some places that lag a bit behind. And I think, as Dr. Katz said, these cases will come in through lab reporting, and then they will be assigned to tracers based on the information that's found from lab reporting.
And what will be the status of the DOHMH staff assigned to this program day to day? Will that DOHMH staff that's assigned to this program still report to DOHMH, or will they report to H&H?
For the sake of the project and getting the work done, their work product will be H&H collaborative project, but their supervisor does not change. Their employment status does not change.
What is the status of the city's ability to use hotel rooms for persons who cannot safely isolate at home?
So we have stood up several hotels. We have our community care staff with on each floor with monitoring kits, ability to provide nursing services, ability to provide food services. We will grow the hotel rooms as large as it needs to be to meet the need.
How many current hotel rooms do we have on this?
Dr. Long, do you know the number?
Yes. So we currently have access to over 1,000 hotel rooms today, but we're ramping up to be able to give New Yorkers 1,200 rooms as they need for isolation on June 1st. And if I could add just one point here, from day one, we've been at the front of building out the hotel rooms, not because we've had to, but because we've always felt like this is the right thing to do. So we have an advanced model that we're proud of. We take good care of people in our hotels.
But 1,200 seems very low. I mean, with a city that has 110,000 hotel rooms, that seems like an incredibly low number at this point to project towards June. I would think you were going to tell me that, you know, we're going to have by June 10 or 15,000 hotel rooms available for people that need to isolate outside of their homes.
Speaker, I think what we're imagining is that, I mean, June is 15 days away, that we wouldn't exceed 1,200 people needing to be isolated and quarantined then. We do, as you say, there is a huge ability to acquire additional hotel rooms as we need it. They are, sadly, because of the loss of tourism, those rooms are available. We will scale to whatever size we need. Some proportion of people will want to isolate or quarantine in their home. And assuming that that can be done because they have a separate space, that will be a good thing. Some people obviously will not be able to do that, and they will need room. Let me ask Jackie Bray, who is leading this pillar, if she has additional things she can tell us.
Yeah, sure, of course. So I would just add that as of today, any doctor across the city can refer someone to our hotels. And so we will have sufficient hotel space to isolate anyone whose doctor believes they need to isolate outside the home, and that starts today. And so if we need more than 1,200 by June 1, we will have more than 1,200 by June 1. Really, we think about the hotels as unlimited, and it's just about how many people need it and honestly take us up on the offer. We're not at the point where we're going to force someone into a hotel. They're going to opt in for themselves.
Okay, so thank you. So look, Mitch, I want to just talk just for a second about the totally appalling and unacceptable racial disparities that we have seen on the number of people that have died, but how it relates to testing. There was a delay in setting up appropriate testing in those communities across New York City. And how do we ensure that the tracking and tracing won't fall victim to the racial disparities that we've seen? So we want communities of color to get the appropriate testing that have seen a disproportionate impact. And we want them to be confident that this contact tracing initiative is not going to leave them behind in any way, as many of them feel like they've been left behind at many other points in this crisis. Can you talk about the racial disparities and how you're thinking about that as it relates to this program?
Well, Speaker, you've pointed it out so well. I mean, it's horrifying, both in terms of who got COVID and who did poorly medically when they had COVID. I think that it's a tragedy for all of us. In terms of how to use the testing and tracing function to try to prevent that, we have put the testing centers in the places that we believe are most accessible to Black and brown people, to low-income people. They exist at NYCHA housing centers. They exist at health and hospital community clinics and hospitals, which are typically the places people know they can go without being charged, where they know they can go without people hassling them about their immigration status, right? The trusted places. We'd be happy to share the list of the 23 testing sites. We are hoping to open more testing sites. We're prepared to put it, if anyone looks at the map and feels that we have missed areas, we want to do more. We deliberately have a large number also for the public health reasons that we don't want people traveling long distances in order to get testing, because we see that as a potential exposure. So we will share the exact map of the 23 places and any proposed places. And if members of your council have other ideas about where they think it should be done, we will do it. I do think health and hospitals, in terms of cultural competency, as well as the Department of Health and Mental Health, has great mental hygiene, has great background in cultural competency and being sure that when we're reaching out to people, We are doing so in a culturally competent way with the appropriate linguistic support, which will be provided by our translation lines.
One of the concerns I have is under the rules of the City of New York, data provided to the Department of Health and Mental Hygiene, and I believe only data provided to the Department of Mental Hygiene as part of a contact tracing program, have extraordinarily strong privacy protections. Is H&H, if H&H is administering a contact tracing program instead of DOHMH, what law or laws protect the privacy of personal health information given by New Yorkers to a contact tracer? How can people trust that their personal health information is actually going to be protected by health and hospitals or by this new structure that was set up?
Mr. Speaker, we've talked to the city lawyers, we've talked to the health and hospital lawyers to be sure that we can offer the same high level security through this program that would be true if the tracing function were housed in DOHMH. So
people will have the same privacy.
Same issues. Remember that we as health and hospitals are used to holding the most confidential information about people's lives. Confidentiality is part of the DNA of both of these departments.
My final question, I have a lot of questions that I can't get to. I'm going to come back for a second round. We are going to allow second rounds if council members need them. My final question is, does this organization that we're talking about, does H&H plan on issuing mandatory quarantine orders or asking the Department of Health to issue mandatory quarantine orders, as I believe H&H has no legal authority to issue mandatory quarantine orders for people who in some way are not complying with isolation requests or are not complying with contact tracing efforts made to them. If that's the case, how are we going to keep people from not being discouraged from getting tested?
Well, those are great questions and great points. I'll start and ask Dr. Daskalakis to add on. The focus of the program is going to be to encourage people to do the right thing. We believe that carrots are much better than sticks. The whole point of this program is to keep people safe and to have them keep safe the people they love. Right. The core mission here is a mission that will positively reverberate with people. We're not doing anything to hurt people. We're doing everything possible to try to help them and to support them. And part of why the hotel program needs to be integrated is so that we can bring people food, we can bring them their medicines, we can bring them their medical care, do all of the things to make it as positive as it can be. We have dealt, and certainly I dealt in San Francisco. There always are a few people who do not comply when asked nicely. This is not a new issue. It happens with diseases like multi-drug resistant tuberculosis. What do you do if you have somebody with multi-drug resistant tuberculosis and they will not isolate themselves, even though you've asked them nicely and provided all of the incentives? There's not a simple answer, but we have not ruled out using any of the powers of DOHMH. Of course, they would be issued by DOHMH as a commissioner order. It would not be by H&H. Dr. Daskalakis, what have I missed?
I just want to, before Dimitri weighs in, I just want to say, I, of course, want to be ensure that New Yorkers are safe and that we're doing everything we can to protect them, which is why we're doing this program to begin with. It's a core part of making sure people are safe. But I have concerns about how we handle this, where it doesn't land in a disproportionate way on poor people, on people that may have addiction issues, on folks that already are, extraordinarily vulnerable. We've seen the over-policing of communities and arrests and summonses already over the last, month in this. My concern is how do we make sure that something along those lines does not happen in this way? And I understand it's a balancing act because we do not want people that do have COVID-19 to be out there not abiding by public health orders. But but I just want to understand how we're handling this in a nuanced way. So as you said, Dr. Katz, we're not starting with a stick. We're starting with carrots, and we're figuring out how to how we approach people that may have other underlying health conditions like drug addiction, like mental illness, people that may be undocumented. How are we handling the unique situations that many New Yorkers have to make sure we're not going to be, overly punitive, while at the same time balancing the needs that we're all talking about?
Well said. Dr. Daskalakis?
So I think just to restate some of what Dr. Katz said, I think that this program is really being designed as a service, not only an intervention, which I think is critical, and really, again, and Dr. Long should jump into, they're really sort of focusing on creating an environment where almost everybody will be interested in doing this, as opposed to creating an environment where it's more sort of a enforcement issue, I think is a critical piece of this. And I think a couple of the important things that are ingredients to this to make sure that it's done in a way that's appropriate for the community is very soon after the announcement of T2 of the test and trace program moving over completely to H&H with our collaboration. We worked really hard with H&H to develop a community advisory body to make sure that there was direct feedback into sort of what the strategies were from the perspective of carrot and stick. And so I think that that's a really critical piece of what's happening with this project, and is, again, very collaborative, since, again, we pulled it together at DOHMH and then started this great collaboration with Amanda and the other team over at H&H to make sure that that these voices were a part of the planning dynamics. Additionally, I think another really important thing, and I think maybe Ted would like to talk about it more, is even before the hiring moved over to H&H, there was an important effort to make sure that zip codes overrepresented by the pandemic were also overrepresented into hires. And so I think that we've been providing data and information to the sort of hiring to make sure that the individuals who are working on this project are actually individuals connected directly to the communities that are affected. So I'm not sure, Ted, if you have anything else to add.
Yeah. No, thanks, Dimitri. You hit all the key points. I'll just emphasize three things. We're creating a new role that we're bringing into this program, a new role called resource navigators. Well, my patients tell me when I diagnose them with coronavirus and I explain to them what isolation is, they say, but how do I get food? How do I support my family at home? And we're creating a one-stop shop for them to be able to reach out at home and get all the wraparound services that the city has to offer brought to bear with one single person. The other thing you mentioned, Mr. Speaker, which is crucial, is behavioral health. So in our hotels program, our model, which we started and built out, includes comprehensive behavioral health, including social work, peers, and psychiatrists that consult into the hotels themselves. Because that's a very critical thing to really truly take good care of patients in hotels. And the third thing, which Dimitri was saying, is that we are currently working with CBOs across the board. We've been in touch with hundreds of CBOs as we sit here today, asking them which of your clients would want to be either a resource navigator or a tracer. Because who better to know the community and to be able to really communicate with people from their community than somebody that lives in that community? They're the perfect tracer. So that's been a high priority for us. And again, we've been in touch with hundreds to date.
So just to be clear, you are saying, Dr. Katz and Dr. Daskalakis, that quarantine orders are on the table?
Yes, I think they have to be. But I think the goal is that our hope is not to have to use them.
But I would just say, as you start to think about that, I would be very clear and nuanced about what that means to New Yorkers so that we do not scare people away from actually being tested or from wanting to participate with our contact tracing program.
Agree.
Okay, I have a lot more questions. I'm not going to ask them now. I'm going to turn it over to one of the chairs of running today's committee hearing. I believe we're starting with Chair Rivera, the chair of our hospitals committee. I want to thank you all for participating, and I will come back for a second round of questions after all of the council members have a chance to ask their questions. Chair Rivera.
Thank you so much, Mr. Speaker, for your questions. I'll just dive right in. So Dr. Katz, you said the mayor made this decision. Can you describe, in your opinion, what the mayor's decision-making philosophy is when it comes to COVID-19 related decisions?
Sure. I think his feeling, and I've been pretty transparent that I agree with it, is that this is a huge undertaking and that the three pillars are better all together than they are separate, and that whoever is doing the whole umbrella of services needs to be able to very rapidly hire. And I would add in my own belief that it's appropriate work for government employees.
So, and I just want to quickly acknowledge Council Members Ayala and Traeger. Does he have particular experts that he relies on? How did he, for example, make decisions to close down schools and businesses when he did?
I think the mayor's been very open about the fact that all of the decisions, and I certainly witnessed this, were he would ask the advice of Dr. Barbeau, Dr. Daskalakis, myself, and Deputy Mayor Perehense. And I think we can all be clear, we didn't always agree. Sometimes the four of us all had the same opinion. Sometimes there was a disagreement. Facts have shown that sometimes some of us were right, some of us were wrong. We weren't same person wasn't right all of the time. But that at each time the mayor asked the four of us whenever there was a medical question. I would add, in more recent times, Dr. Varma has joined as well for medical questions, health questions, public health questions. And then based on that and the operational issues, he's made the decision as our mayor.
Can you elaborate on any moments in particular where you or other health experts initially agreed with the mayor and how you as a team resolved those differences?
I think, and Dr. Daskalakis was part of it, and he can say his view. I would say that 85%, the 4 or 5 people agreed. I think maybe 10 to 15% of the time, we didn't agree. I think that if anything, coronavirus should teach us all a great deal of humility. I mean, I think it has to be said that much of what public health experts said, including myself and other experts in New York City, was not correct. I think some of the obvious things that were not correct, sorry, my computer, if I don't touch it, the screen changes. I think among the things that we can now all acknowledge were not correct is that at first we thought that the pandemic was propelled by people, only those who were symptomatic. It's now clear that people who are asymptomatic can transmit and maybe are some of the most transmissible people who can most easily transmit. In January, there was concern about flights coming from Asia. Turns out that the concern should have been about flights coming from Europe. We earlier on, all of us agreed that the risk of the virus being transmissible from surfaces was close to non-existent. We weren't right about any of those things. So I think humility is a really key feature that all of us should take from this pandemic.
I appreciate that lesson always. How will you lift up the voices of all the experts in the room, particularly given the stories in the press that have reported that the mayor is particularly influenced by your opinion on health decisions?
Well, since you've given me the opportunity, the article that appeared, which was from leaked emails, 2 days later, the mayor made the decision to close the mass event. So obviously he didn't listen to that email. So I'm not really sure. I mean, I go back and say that if anyone thinks that the biggest mistake that experts made was my worrying about the impact of closing mass events, we should have been sheltering in place in January, long before anybody said anything, right? So to suggest that the mistake was that if only we had the mayor had announced the closure of mass events 2 days earlier, totally misses the humility point. The humility point is we were all wrong. We should have done something way earlier, but that wasn't anybody's fault. All of us were operating on the information that we had. And I think the fact that the mayor did end mass events shows that the mayor was not, in fact, unduly influenced. And isn't it a good thing that people should ask a variety of opinions and we should all give our opinions? Again, I feel like that story is meant to sow bad feelings between people, which is not helpful to us getting our work done.
Well, you said earlier that this move was made primarily because of operational concerns, but at the end of the day, the mayor is going to look to you as the head of H&H to guide the implementation of this program. So outside of New York, what has your experience been with contact tracing?
Well, during the 13 years I was director of public health in San Francisco during the worst years of the epidemic, I have supervised contact tracing for all of the diseases that existed up until that time. Obviously not COVID-19, which did not exist. But I have a long background. I started most of my career, still the majority of my career was spent on the public health side, not on the hospital delivery side. But again, I would just try to emphasize, we're not losing the amazing expertise of DOHMH. A hospital analogy, as you're the chair, is I can still provide the resources my anesthesiologists need, even if I can't intubate a patient. I don't tell my anesthesiologist how to intubate patients. I don't do the vent settings. That doesn't mean I can't be sure that they don't have the best ventilator. In fact, I spent a lot of time working on obtaining ventilators that I myself don't know how to use. So I think it's entirely possible for someone to be helpful on operations, that I could have a ability through health and hospitals to hire 1,000 government workers faster and get their IT done and get them paid. And I don't see that takes anything away from the tremendous expertise that DOHMH has.
And I thank you for all of your expertise and talent that you brought to this role and coming back home to New York City. You know, without Dr. Barbeau here, I'm very interested in knowing her perspective of this transition. And the mayor said in a press conference, I guess just a few minutes ago, that he spoke to her 2 days ago, maybe, or a couple days ago. When was the last time you spoke to Dr. Barbeau, and what are her thoughts on the transition?
Yeah, I talked to her 3 days ago, and what I said was, I really want to work with you. And she said, Mitch, we're on the same team, the same uniform, and we're going to make this work. And I know that what she cares about at the end of the day is us getting out of lockup in a safe way and saving lives. And I know that she cares more about that than anything else. And I think that's what we all need to focus on.
Agreed. And it's just, I have a concern, and maybe it's a little personal. And again, not all on this team, but many of the people on this team are men, particularly white men, in the leadership of this group. And as one of only 12 women in the council, and one of even a smaller group, we just have a lot of concerns in terms of being women of color. I know the consequences of not having those voices in the room when big decisions are made regarding this city. It's a disservice to New Yorkers. I've highlighted this issue when it comes to maternal mortality, and Dr. Barbeau is one of the few Latinas in the mayor's leadership team. And since she is not here today, can you tell me who will be leading efforts to do outreach to the communities of color, specifically those that have been disproportionately affected? You mentioned community-based organizations, but can you talk about who will be leading those efforts specifically?
Sure.
In administration?
I'd like Dr. Long, he's had the more direct contact with those groups, to answer.
Yes, absolutely. And Chairwoman Rivera, I very much appreciate the question. It is critical that we get as much community input as we can, as possible, to be successful here. Otherwise, we won't be able to reach into the communities to really connect with the people we need to connect with to get them tested. Specifically, we're partnering with the Department of Health to create the advisory committee that Dr. Daskalakis had talked about. That's under the leadership of Dr. Taurine Easterling. And again, we've been in touch with hundreds of CBOs to get both their input, but also to actually have them physically help us to hire people that will be doing the actual work. The input through the advisory committee is ongoing. It's been very, very helpful so far, and we have an open door for being able to pose questions and issues to the committee, and we have every intention to continue that throughout the process.
Okay, I heard most of what you said. We can come back to this. I want to just make sure, I don't want to take too much time because we have a long list of people waiting. So we want to just get a sense of kind of the bureaucratic navigation that you all have embarked on and the transition that is occurring. Can you explain the differences? Because we heard about the Fund for Public Health and being a public benefits corporation. Can you explain the differences between the processes by which the Department of Health and Mental Hygiene versus H&H procure contracts, particularly as it relates to the operation of the Fund for Public Health?
So on Chair Rivera, on the contracts, I would agree, and I think it's already been said that while we're under the emergency order, contracting is relatively easy compared to usual. But in this case, health and hospitals already had the contracts in place. So for testing and for the hotel program and the supportive services. So for us, it's not even a question of contracting. It's already done. It's already in place. The emergency rules do not change the employment law, do not change the things that are necessary. The rules that govern the hiring of civil servants, government employees, are not waived under an emergency. And I believe that that is the reason why originally when DOH-MH was planning to hire, they were planning to hire through a non-governmental entity, recognizing that as a city department, it would be very difficult for them to do the logistics. This is nothing about the expertise of contact tracing. This is the sheer logistics of putting 1,000 people on payroll correctly. And that was why they were, planning to use a non-governmental entity. I again, as an unapologetically public sector person, feel that government work should be done by government employees. And as an agency, I can hire more rapidly than people in a department. The same would be true if it were EDC. It's not about H&H versus DOH-MH. It's about being the speed with which an agency can hire. We can create positions. We can hire more rapidly than a city department. I don't see that as a negative on anybody. I just see that as the differences in organization.
Understood. So let me just move on. Many medical experts have impressed to us the concern that even a 1 to 2 day delay in getting test results will limit the success of this program. How do you respond to those concerns, and when can we get those delays eliminated?
Yeah, that's a great issue. Right now, just to speak about the realities on the ground, in its hospital, both H&H hospitals as well as the private hospitals, we have sufficient reagents to test people and get the response in 3 to 4 hours. But the reagents for those tests are fairly limited, and that's why we and the other hospitals are using that for clinical decision-making when we have to know right away that somebody is positive. I would love for the ability to have 3 to 4 hour turnaround times, or even immediate turnaround times with rapid testing the way we have for HIV or other illnesses. I'm sure they are coming, but they're not technologically here yet. And we still have shortages of the reagents for 3 to 4 hours. So I'm hoping the situation improves, but that's beyond us, DOH-MH, or health and hospitals.
So what will the involvement of FQHCs and community health centers be in the track and trace program? For example, are they able to provide testing to patients? And how can the contact tracing program also work to provide care directly to individuals who may test positive with milder asymptomatic cases?
So the first half is, can they do the testing? Yes, absolutely. Dr. Long, do you want to talk about the greater involvement?
Yes, absolutely. So while FQHCs can do testing now, we actually want to, as part of this program, reach out to all FQHCs in every community that wants to be a part of this to support them and figure out what their needs are. So we've already started to have those conversations But I very much agree with you that FQHCs serve a critical role in all of this, and we are here through the program to support them to be able to offer testing to every community.
So have you worked with CBOs and labor to hire culturally competent, aware contact tracers that reflect communities in the city?
Great question.
Yes, go ahead, Dr. Long.
We are doing that now. So we've been in touch with hundreds of CBOs, and we've asked them to send us clients that would serve as tracers in the communities that they come from. And then in addition, just to make sure that it's a good process for them and for us, is we prioritize clients from high risk or high vulnerability zip codes, and we bring them to the front of the line for interviews, front of the line for hires. So it's a very high priority for us.
I'd say so. I'd say it's probably one of the most important things.
Understood.
That we have a diverse team going into our communities that have been devastated. So there are many ethical and privacy. I just have about two more questions and then we can move on. There are many ethical and privacy concerns regarding contact tracing. How do you envision New York City navigating these issues? Will any H&H employees be limited in participating in this program based on HIPAA rules?
No, we've consulted with our lawyers. We think that because the tracing is being done as a public health function under the auspices of DOHMH, that we don't have an issue around HIPAA. Both departments, again, have in their DNA the importance of keeping information confidential. And we will continue to work with the city lawyers as well as the H&H lawyers to make sure that everything is done properly.
How does the implementation and the public release of the data from this program, such as the notification to the individuals that they have been in contact with an infected individual, work within the context of HIPAA and other privacy concerns?
Well, so again, because this is a public health function, HIPAA will not be the relevant law, although, and when we're taking care of people in a hotel program, obviously their medical information is protected under HIPAA. So, but when we're doing the public health functions, we will use the stringent public health confidentiality rules, which frankly, again, these are not new to us. When you tell somebody that they've been exposed to a sexually transmitted disease and they say, tell me who told you that, right? We don't say, who the name is, right? I mean, that is part of it. And we don't tell other people that the person we're calling is a contact. So we will make sure.
Well, my last question, just to follow up, is also on the tech concerns. We held a hearing on technology along with my colleague, Councilmember Holden, who you're going to hear from right after. Project Nightingale is was involved in an EHR program that was run by Ascension. That's the second largest healthcare system in the country. Project Nightingale made headlines because it was revealed that Google was provided with 50 million health records from this program last fall. Health data harvesting and general mistrust has many Americans doubtful in government leadership. And in a recent poll, 2/3 of Americans would not use a contact tracing program established by the federal government, with roughly half saying they wouldn't use a program established by local public health officials. So what EHR or other medical platform will be used to run this program?
Let's start with Dr. Long, and we may need Dr. Daskalakis as well on the IT. Ted?
Yeah, so I very much hear you, Chairwoman Rivera. 2 points I'll make, and then I'll turn to Dr. Daskalakis. First is that we're not running the program through an EHR. We're running it through a platform that is really specialized to do this sort of thing. And the tracers themselves are trained and required to keep information highly confidential based on state and city health codes, not on HIPAA. So we have the opportunity to offer people every reassurance. And I think it also helps to have people from the community that are trusted be the tracers themselves. But Dr. Daskalakis, do you want to add on?
Dr. Long, I think you covered it.
Who's going to own the data gathered from the testing and tracing, and has the city considered using a contact tracing app?
Dr. Long?
That's a great question. We have considered using apps. We have not gone down that path yet. What we have done is people like to be communicated in different ways. So we have a multimodal strategy of calls and text messages that we're going to be leveraging. But the use of an app is an interesting one. It's something we're looking into, and we're going to continue to look into that. I'd be happy to share more later.
Please do. All right, with that, I want to turn it over to my colleague, co-chair Mark Levine. Thank you very much for answering, and I'll see you in the second round.
Well, thank you, Chair Rivera and Speaker Johnson, for those questions, and hello again to the administration. You know, an unfortunate result of this pandemic is we are likely to see a resurgence of some of the infectious diseases we've been battling for some time: HIV, tuberculosis, viral hepatitis. All of those require contact tracers to contain, but we've now taken the contact tracers out of the health department. So how are we going to protect the city against the resurgence of those contagious diseases?
I'll start and then I'll turn to Dr. Daskalakis. So I think that's a good point, and it has a corollary with healthcare in the sense that when the healthcare system is all focused on COVID, then we worry, are children getting their immunizations, are people getting their hypertension medicines? So I think the challenge for the city, all of us broadly, is to deal with COVID, which is an emergency, but as you say, Chair Levine, not forget about the other things. Dr. Daskalakis has identified a group of staff that can focus on the COVID tracing, but all of his staff are not focused on that because he has to continue to focus on the other infectious diseases, just like Health and Hospital has to focus on people who are having trauma or other diseases. Dr. Daskalakis, can you explain how you're doing that?
Thank you. So again, we will have staff that will be focusing on COVID-19 since we are in the middle of a public health emergency. And so that's critical. I think as healthcare opens up again, which I think it has, we will see most likely new HIV infections, hepatitis, STIs, et cetera, since people have potentially not been coming to care as frequently because of the COVID-19 emergency. With that said, I think that we routinely at the Department of Health, as exemplified by our Incident Command System, or ICS, that Speaker Johnson referred to before, are used to really moving staff around to various areas. So we will, again, use the current staff and also repurpose our internal staff to be able to meet the needs as they emerge.
I appreciate that. As bad as this pandemic is, we cannot take our eye off these long-term battles against the diseases I mentioned and others. We know that requires contact tracing, so we're going to want to be really vigilant on that. You had a very nuanced discussion about the possible use of mandated quarantines, and I appreciate your frankness in talking about the possibility that it could be used in some cases. One thing that we learned in our battle against the HIV epidemic with the use of contact tracing is that mandated quarantines or mandated activities can impact people's willingness to seek a test because they might feel like there could be consequences if they get a positive. I wonder if you have thought of pre-test counseling of any sort to explain people what the implications of a positive test would be, potentially even having someone sign a waiver or commit in some way to quarantine if a positive test comes back.
I know I'll start and then turn to Dr. Long. So yes, we do provide information at the time of testing, and I think it's very important that people know at the time that they're getting the test what the possible results of the test are. You know, my overall hope is that most people see us as trying to be helpful, and I think they will. We were talking, Dr. Daskalakis and I, about the fact that early on, when the DOHMH in March was able still to do contact tracing because the number was a feasible number, that we had widespread cooperation with the isolation and quarantine orders, including Dr. Daskalakis's doing random checks both by phone and by door, and people were following it. So, you know, again, my hope is that the vast majority of people see us as trying to help them, trying to keep their neighbors and their families safe, and that if we're able to offer enough positive things food, the ability to bring your medicines, that we will be able to do it. Dr. Long, or do you want to start, and maybe Dr. Daskalakis wants to add?
Yeah, that would be great. Mr. Chairman, in a short phrase, I completely agree with you. We provide patient education material to every patient we test that explains what a positive or negative result means. And we have clinicians that speak to patients as well. So I fully agree with you. It's critical. Dr. Daskalakis, do you want to add anything?
No, I think you both covered it.
Thank you. So what level of participation is your benchmark to make this work? Is it 70%, 80%, 90%?
You mean participation by the individual?
Yes.
I assume, and again, I'll look to Dr. Daskalakis based on his early experience, I'm assuming 99% that people, in terms of compliance, is that what you mean? Like if we say you have to stay at home, do you actually stay at home?
Yeah.
Right.
So, and in the earlier stage, if someone tests positive, that they share their contacts with you.
That's a very good question. I know we've always, and I'd be interested, I've never had that discussion with Dr. Daskalakis. I've had it in other counties. The question of, how many, if you're say following up someone with a positive syphilis serology, how many contacts do you get? And sometimes the number you get doesn't seem correct. So do you want to offer an estimate in this circumstance, Dr. Daskalakis, of what you think we'll get?
Sure. So first I'll say that one of the sort of important pieces of the training that contact tracers and case investigators are going to get in this program, really on the back of the experience of the Department of Health, is how to really coach people to share information. So I think very often what you'll find in contact tracing experiences is the question, do you have any contacts, really doesn't get you very far, as opposed to, could you open your phone and take a look at who you've been texting and who you've been seeing and all of that. Think about your appointments if you had appointments, really sort of to coach out good numbers. I think realistically speaking, though, there are people who just will not give contacts. And I think probably a fair guess is that about 20 to 25% of folks will either not know or not actually share contacts. It's pretty common. I think this disease is a little bit different than HIV and STI. I think that at least currently in this sort of phase of this infection, I don't think that we have like the same, although we do have a stigma level, like quite the same sort of topical stigma level that we do with those two. So I think my hope is that we'll see something closer to 20% who don't share. With also to remember is that the data are always imperfect. And so I guess if I would ask anyone on this illustrious panel, if they know the phone number of everyone they've been in contact with, the chances are they may not. But part of the training that will happen with the tracers is ways to figure that out. And I think that the hope is, ideally, I agree with Dr. Katz that if we could get 99 or 100% compliance, that would be ideal. But really, in the real world, if we get something closer to 75%, we will be doing pretty great. I'm not sure maybe if either Ted or Dr. Varma have anything else to add.
You definitely covered it from my perspective.
Yeah, this is Jay. I would just say that there are some indicators that we will eventually be monitoring that are even more specific. So, for example, as disease transmission declines, in an ideal setting, the proportion of new cases should ideally start to increase as those that come from quarantine. That is, of all the cases that you detect, let's say you have 100 cases, if the majority of those cases are people that you already knew about because they were already listed as contacts, then that would demonstrate success of your program. But we're quite a way from getting to there until we get to a point where there's a lower level of transmission.
Okay, but there are challenges in every step of the tracing process, from the moment you get a positive test result to the time when every contact finishes their 14 days in quarantine, where we got to get a working phone number for everyone who tests positive. Not everyone has a cell phone in New York City, especially in a time of economic crisis like this. You need people to answer the phone. Not everyone answers phones from numbers that they don't recognize. We talked about the need for them to share contacts. And some of these can be sensitive. What if someone was at a mental health counseling session? Someone was at an AA meeting. Someone was engaged in pastoral care. There are challenges at that stage. And then I want to emphasize what a big deal it's going to be to ask New Yorkers who are otherwise healthy to stay home for 14 days. They need to do that. It's an imperative. This is the new stay home, stay safe. This is the way we can stop the spread. And the way I explain it to people is you need to make sure you're the last person who the virus ever touches in your circle. But, it's a lot to ask someone who feels healthy to stay home for 14 days. And I'll ask some questions in a bit about what it's going to take to make that realistic. But any comments on some of the other challenges that we're going to confront in the early stages of the tracing process?
Dr. Long, anything you want to add?
Yeah. To be brief, I agree with everything you said. Those are all really important points. And it brings up the issue of phones only get you so far. So we are building out a field ops unit within the tracing operation to be able to do more than just on the phone. Just to agree with your point of we need to use every strategy we can to get through to people.
Okay, look, at this point, contact trace. Oh, sorry, please.
That's okay. This is Jackie.
Okay.
Yeah, I was going to add that part of what we're pairing with this is, all of the clinical stuff is important. All the expertise is important, but just the communications with New Yorkers is also critical. And one thing we've learned from what Massachusetts has been doing for the last 6 weeks is what messaging works the best and what methods of delivering that message. So Massachusetts has a great program running that we are, stealing is the greatest form of flattery, right? That we are working to build out for ourselves. It is literally about, hey, the way you take care of your family is you answer our call, like pick up your phone when we're calling. And so we'll be investing heavily in communications in all languages that are culturally competent and informed by how people best receive information, both channels and language and visuals. And I think that that's like an incredibly important part of what we're doing. And what we know already from the research we've done is that what people most want is to keep their family safe, right? And so the more that we talk about this as a program that is going to help you keep your family safe, the higher success we're all going to have in confronting those very real operational challenges.
Understood. In past contact tracing efforts in New York City, when we've needed to find people who perhaps the person who's sick just didn't know, we've used methods like checking credit card purchase data. Why would this be necessary? Well, maybe someone went to a restaurant and a member of the wait staff was sick, for example, and so we have to find people who were served. Look, at this moment, most of the contacts are going to be people who either we live with or maybe as essential workers we work with, so we'll know most people. But that's going to change as we start opening up. We've seen in other countries in the current pandemic, they've used closed circuit television to identify people, again, outside of the home and the work where it's harder. Some have taken to social media to track people down. Tell us about your plan for these kinds of methods in this current tracing project.
Dr. Long, do you want to start?
Yeah, actually, this is a great opportunity to make the point that as we plan things like this, it is done hand in hand with the Department of Health. So Dr. Daskalakis and I and others will talk about this. We'll figure out what will make sense. They'll help to guide us, and then we'll implement the plan on the ground. We're thinking about everything that you just said, Mr. Chairman. On day one, the program will work, and then we're going to be building on enhanced layers like that. And these will be things that we'll do together hand in hand with the Department of Health. So, Dimitri, I don't know if you want to add anything.
I don't have anything to add. I think you covered it.
Okay. I do want to acknowledge we've been joined by one of our colleagues, Councilmember Steve Levin. We've talked about the need for people to quarantine, and I think we all agree so far, everyone who's spoken on this call, better to do this by encouragement and also by making it easier for people. So that actually means a lot, because we're telling people to not leave their home for 14 days, except for a medical necessity, a doctor's appointment or an emergency that can't be delayed. And this isn't like sheltering in place now, where you can put on a mask and go to the grocery store if you need to, or you can go for a run in the park. That's not what quarantining is. This is really stay home for 14 days. So obviously we need to make sure people's food needs are met. We need to make sure that their pharmacy needs are met. They shouldn't go out to walk their dog, right? Because that's potential exposure. I mean, they probably shouldn't go out to take the recycling if they're in, a large building with common areas. What are the provisions that we're going to make for that? And actually, let me add one more thing, which is the question of income. Some people are actually going to lose income when they quarantine, and have we talked about income replacement? So those are some of the considerations to make it reasonable for people to stay home for 14 days. Tell me your thoughts.
I know Jackie Bray is going to do the detail. I just want to start by saying, to me, this is why it's so important that the pillars be together, because I don't see how you can do successful tracing unless you have the ability to provide people both the location and the services they're going to need to stay at home. I'll just say early on, some of the most challenging issues we had where people would be discharged from a hospital because they had been in the hospital because of COVID, but they have no medicines, right? So they have no medicines for their diabetes. They have no hypertensive medicines. What are they supposed to do? And my hope is that by all of us together working with Jackie's experience on some of the important social services as well, we'll be able to meet those needs. Jackie?
Sure, thanks. Yeah, so the first thing is that anyone who is isolating at home, so anyone who's isolating at the hotels, obviously less of a challenge there. There will be services at the hotels to provide for all of their needs. Anyone that's isolating at home will be connected to a resource navigator. That will really be a case management function that walks through with that person what are the things that they need in order to stay home. It's our expectation that something like 25% of our cases and our contacts are going to need some type of government assistance and government service to provide it for them in order to safely isolate at home. So meals, we'll have that set up from day one. The ability to connect to pharmacy delivery, we'll have that set up. We're literally figuring out how to add minutes and data availability to people's cell phones so that they can text with us, they can pick up their phone calls from us, but also from friends and family, checking in on them. We're going to have services, ways to connect people to all of the existing city services. So any existing HRA service, existing legal services. We learned at the beginning of this outbreak that some people in quarantine and isolation need some legal services in case they've got legal issues going on that they then can't attend to. There are certain ways in which we can provide some financial services, and I take the point completely. Have we thought about income replacement? We're not there yet, but understand that other people are talking about that, and we're talking to the right folks about that. And so, pet walking and laundry, we have not won't launch on day one, but they're definitely on our list as we move forward over the summer.
Forgive me, did you mention childcare and elder care? This is relevant.
Yes, of course. Yep,
Let me just
absolutely
explain why this is so important. Because for those who can't stay safely at home and they need to isolate in the hotel, well, what if they're the primary caregiver?
Right. Right.
So how do you deal with that situation?
So if, one of the things that we have decided is that if you're the primary caregiver to either children or to an adult in the home that needs round-the-clock care, that we would make it safe for you to isolate at home. At that point, what we would do is give you what you need. It might be lots of PPE that shows up at your door. It might be a different types of infection control protocol. But our first goal would be to help you isolate at home. If that was impossible, then we could also look to bring the people in your care to the hotel. That's another option, right? So that you and your kids could come to the hotels, or you or the person that you're caring for could come to the hotels. And again, if those are also not options, and we really need to separate caregiver, we're working hand in glove with our partners in the healthcare space, in the sort of home health aid space and visiting nurse service space in an effort to set up appropriate care. So we are anticipating those problems and putting systems in place.
how many resource navigators are you going to hire? And is that part of your 2,500 tracers?
It's different. We're working out the numbers, and it's going to be hard to know exactly how many we need until we start, so that we're certain about what percentage of cases, what percentage of contacts, but somewhere between 200 and 300. And we will work really closely in partnership with communities to make sure that those resource navigators have real experience already doing this for vulnerable New Yorkers.
An incredibly sensitive and important job for sure.
Yeah.
We've talked about fears about the trust that we need New Yorkers to have in this program. And boy, am I worried about how undocumented New Yorkers will respond in the era of presidential administration, which is targeting them directly day after day. What kind of provisions are we making to ensure every person in the city, whatever their immigration status, that they can safely participate, that information they share will be secure, and that under no circumstances will we share data with federal authorities?
We will under no circumstances share data with federal authorities. Absolutely. I think that's something that your team believes in very deeply. And we have made those points to our lawyers who support that, both at the Health and Hospital and city law, and we will make sure that that never happens.
Okay. Look, the speaker and Chair Rivera and I have all asked about hotels. Why is this so critical? This is an equity priority. The disease has spread because of people living in crowded apartments where it's gone from one family member to another. This is borne out in the data. It's not fair. People in big houses don't have this problem. Offering a hotel gives an answer. But boy, the numbers you're citing seem low to me. We don't know exactly how many people are contracting the virus every day because we're not testing everybody, which is another problem. But let's just say we have 2,000 new infections a day as a guess. And let's say a quarter of those people are living in unsafe housing. I think that's low, but I'm working on conservative numbers here. But that would mean that on any given night, because it's a 14-day period, you're talking 7,000 people in hotels. But you say we have 1,000 rooms that we can expand to 1,200. You didn't clarify how many people are in those rooms. So could you clarify the number in the rooms and speak to the kind of capacity requirements that I just mentioned?
Well, let me start, Chair, and just say that we as a team are committed to as many hotel rooms as are necessary. And that at this moment, because of the collapse of the tourism industry, there's no shortage of supply for rooms. And we have the ability to rapidly hire additional people, again, because it's not just the tracers, right? It's the who's going to check on them if they're feeling short of breath, who's going to get them their medicines, who's going to get them the PPE that Jackie spoke about. And we are committed to hiring as many people as need. You're right. I mean, it's still early on. We don't know what percent of people will turn out to be able to isolate in their home versus needing a hotel. People will come on and off. We don't know how many people will get tested who will ultimately be positive. But I just say we don't see the hotel supply as a limiting, and we don't see the staffing of those beds as a limitation of us. Jackie, do you want to add on the supply? You're on mute, Jackie.
Oh, thank you, Mitch. We're not worried about the hotel supply. I am completely confident that we will, as we need, have enough hotel rooms. If we need tens of thousands, we'll have tens of thousands. Many of you know me from having run day-to-day operations of the Department of Homeless Services. If there is something I know, it is how to create capacity. So that is not our concern here. In truth, we now have some experience encouraging folks to go to hotels, and it is the vast majority of people's preference for us to help them isolate at home and stay home safely. And so we will quickly ramp hotels. H&H has got a great model. We've got good services in place for laundry and food and security and entertainment even. we will pull triggers as we need to make sure we have appropriate capacity.
People have asked a lot about cases where someone's already had COVID-19. They got maybe even a test to confirm it. They got an antibody test later. And they're asking, am I still going to be required to quarantine for 14 days if I've been in contact with someone who's sick? What's the answer to that?
That's a very thoughtful question. Obviously, we can all agree that there remains a lot that is not known. I mean, on the positive side for their health, one of the things I would be able to reassure them is that there are no documented cases of people who had COVID-19, got well, and then separately got sick. And while we don't have perfect surveillance systems, I think by this time we would know there would be at least one case, and we don't know it. But what you're asking is a more complicated question. Could they transmit during that time, right? Is it possible that you, even though you can't get sick, or at least we believe you can't get sick again, can you transmit during that time? I mean, in general, people who are who've had a disease before in certain models, like measles, can't transmit. But this is a novel coronavirus that keeps surprising all of us. So I don't know. Let me ask Dr. Daskalakis, in your planning, were you thinking that people would still have the same quarantine requirements?
So I think we're still discussing the issue of antibody and immunity, because again, it's pretty unclear whether a positive antibody test actually means that someone is immune. So we'll have to get back to you once we actually have sorted through some of those issues. Again, that's a really good question, a really deep one that will be important in this program.
Okay. So Governor Cuomo and the state are also building a contact tracing program. He cited the number of 17,000 staff. How is this going to interact with New York City? What happens if a sick person in the Bronx has come into contact with someone in Westchester or vice versa? Explain the way we work with New York State on all this.
Sure. Well, I'm happy to say I spoke to Dr. Howard Zucker, the state health officer, last night at an hour too late to mention. He and I we're both committed to, sharing the same kind of data. And again, Dr. Daskalakis can talk about his experience at the beginning of this pandemic, where in fact, you'll remember that Westchester and New York City cases had a great deal of overlap. There is an existing system to work well together for public health people to share the necessary data. So if they have a case and that person has New York City needs New York City tracing, we'll be able to help them out and vice versa. Dr. Daskalakis, can you say more based on your successful early experience?
No, I think it's pretty clear that we have great communication with the state health department, specifically when it comes to cases that are outside of jurisdiction. I think that maybe Dr. Long has more detail about how specifically in TRACE the plan is to continue that communication, but I'm pretty sure, given our track record, that will continue. Ted, I'm not sure if you have other detail.
No, you covered it. Nothing more from me.
Okay, finally, I just want to understand where we are with bringing on the staff, et cetera. So it sounds like 500 are now on payroll as of today. Could you explain whether they have been trained yet on anything? I know they probably got the Bloomberg Online training, which is a couple of hours, but have they been trained on the actual system they'll be using here in New York? Do they have equipment yet? I assume they're all going to need laptops and maybe hotspots, headsets, et cetera. I guess what it really comes down to is, when are they going to start calling people who have tested positive? How soon is that going to be in action?
Dr. Long?
Yes. So the more than 500 people that I referenced are being onboarded now, meaning they've taken the training, they've passed it, and now they're in the process, they're in the hiring stage. We're going to, of course, get them all the equipment that they need, and we're going to train them on the new platform as soon as it's ready. We have a time frame for all of this. All of these things will come online with them having been hired and having all their equipment June 1, and then that will be the move forward date for when we'll start to make phone calls with that cohort. In the meantime, we're continuing to work with Dr. Daskalakis and the Department of Health to do everything that we've been doing.
So 1,000 actually on the job, on the phones, June 1st. What's the timeline for the next 1,500 that you've promised will come in short order after that?
Well, Dr. Long, I just want to make sure that everybody understands we're calling people now who have positive tests. I don't want anyone to think that if you test positive at one of our centers, you're not immediately being called, right? We don't have the tracing, the whole tracing component in yet. And that was part of because, as you've explained I've heard you explain to others, Chair Levine, right? New York City sadly has had such intense community transmission going on that we haven't yet been at the point where we can really do this kind of tracing. But we are very much hoping we're now entering that stage where we can do it and where it's meaningful. But I just want to make sure everyone listening knows that if you get a test now at one of our centers, we call you, Health and Hospitals, to give you the result and explain to you what it means and what you should do. Go ahead, Ted.
Only thing I would add is to answer the second part of your question. So the additional incremental 1,500 tracers will be hired and online in early June. Okay,
thank you. I'm going to stop now. I'll come back for round two. I want to pass it off to Committee Counsel Sarah Liss, who can queue up council member questions. Thank you all very much.
Thank you, Chair Levine. I will now turn to council members for questions and call on them in the order that they will be asking those questions. I want to remind everyone that if you mute yourself at any time, you can only be unmuted by the host. If this happens, please use the raise hand function and the host will unmute you. Council members, please keep your questions to 5 minutes. The Sergeant of Arms will keep a timer and will let you know when your time is up. As the speaker mentioned, we will be adding a second round of questions afterward for 2 minutes each. I will announce the entire order now, and then after each council member asks questions, I will remind everyone of who the next council member will be to ask questions. The order is Council Member Holden, Powers, Lander, Ayala, Barron, Ampry Samuel, Moya, Yeager, Eugene, Reynoso, Maisel, and Levin. Chair Levine, please call on Councilmember Holden as soon as you are ready. And Councilmember Holden, you can begin after the sergeant cues you.
Thank you, Sarah. And yes, Councilmember Holden, please begin.
Your time will begin now.
Can you hear me? I don't.
Yes.
Sergeant Bradley, please reset the timer. If someone could please unmute Councilmember Holden, please.
Can someone mute Councilmember Levin? And we cannot hear Councilmember Holden.
Do you hear
Mr.
me now?
Speaker, he's back on.
Yeah, now we can hear you, Councilmember Holden. Go ahead.
Thank you all again. And I don't know if you heard before, but it's a great hearing. It's very interesting. And the chairs came up with some great questions. I need to ask this one, which is not related to tracing, contact tracing. However, we are hearing a number of complaints from frontline workers, including DOE employees and firefighters, who claim that when their fellow workers who they had contact with test positive for COVID-19, the workers are transferred to other units they keep working and are not quarantined. What's the rule on that? Because how do you contact trace when you're spreading it at the same time?
Council member, you're absolutely correct. Those people should not be at work. Those people should be for 14 days isolated.
So what are we going to do about it? It's still happening. Every day I get a call on this.
I'd be happy myself to track if there were a specific case to call. I mean, those are all department heads I work well with. I'd be happy to contact them. I can separately contact them and tell them that people are that this is happening because it's clearly wrong.
Yeah, and another thing, just with contact tracing, it's clear we still don't know, and you alluded to this a little bit, of how many ways that this virus can be transmitted. For instance, we hear 6 feet is a safe distance. There's been studies, Wuhan study, I think, indicated it can go up to 13 feet. So even, tracing this, if you really came in contact with a person, for instance, we're seeing a new, the emergence of the Kawasaki-like disease, which nobody saw. So we're getting smacked with different waves of this. So, and even today I spoke to a doctor because my mom is still in the hospital, is still in nursing home, and she was tested, and the doctors were telling me there's a 20% error rate on the tests. So they really can't even trust the test. So this almost seems like, we're getting hit with wave after wave.
Well, Council Member, I agree with what you said. Besides, just on the first part, so that I do my job, besides the Department of Education, what was the other department where you're hearing people not being allowed to quarantine?
FDNY.
Okay. On the science, I think the very best people have often been wrong, not to any fault of their own, that this virus does keep surprising people. And again, that's why I think humility is the most important lesson all of us can learn. I think that the advice does change. I personally recognize that the test is not perfect. There is definitely 20% is a little higher than I would have said, but absolutely the point is still true. And I'll tell you, in clinical settings, when we believe that the person has COVID-19, we act as if they have COVID-19, even if the test is negative, because we recognize that there is false negatives. So I just support you, sir, in saying this has been really hard for everybody, and I wish your mother the very best.
Thank you, Doctor. I appreciate that. Just on the mobile application, can I ask a few questions?
Sure.
You may have touched upon it. I had to step in and out. Would the mobile application have the ability to access other data or features on the mobile phone, like control Bluetooth, access to the phone information, contacts, numbers, emails, access to microphone, access to cameras, or access to pictures, or even access to social media accounts? Does it have that ability?
Right now we're still designing it, and I think there are relevant issues about confidentiality and legal issues. Our hope is that we're going to ask people and they're going to answer honestly in order to be able to protect the people they love. I think whether or not it would require a broader discussion, including your council, if we were doing things that people would have to, I guess, agree to that loss of confidentiality and security. So we're not currently proposing that.
Okay, I see my time is up. Thank you, Doctor, so much.
Thank you.
Thank you very much, Councilmember Holden. We'll next hear from Councilmember Powers, and then Lander, and then Ayala. As a reminder to everyone, you may have to wait a few moments to be unmuted by the host when it's your turn. Chair Levine, please cue Councilmember Powers when you're ready, and Councilmember Powers, you'll go after the sergeant cues you.
Thank you, Sarah, and please, Councilmember Powers.
Your time will begin now.
Great, thank you. I just want to clarify, because I did miss, I think Councilmember Rivera asked this earlier, but am I hearing clearly that the city is developing an app that would go in tandem with the human contact portion of contract tracing?
Let me ask Dr. Long and Dr. Varma to respond.
Well, let me touch on something really quickly, and then Ted can go through what we have right now, just because Councilmember Holden's question touched on this too. We have had calls with the various companies that are developing these contact tracing apps. Commissioner Jesse Tisch from DO-IT has been the lead on evaluating those with us. At the moment, we are not confident that the apps that are the app that most people have been talking about, the Apple Google one, would be the right solution for New York City. That said, we've been consistently surprised by this disease here and everywhere else, and how people respond and uptake. And it may very well be that if a large number of New Yorkers proactively choose themselves to download these apps, that we would want to be able to use that information. So it's really a part of an ongoing discussion about, that includes both the acceptance of New Yorkers voluntarily on their own without any of us asking them to do it, participating in these, and then us making sure that we have an information system that could integrate with that. And so just to touch on that last point, that is one of the considerations that we're doing, is making sure that we have what are called the application programming interfaces that would allow us to integrate if it turns.
Got it. Just for time purposes here, just very quickly, does that mean that the city is going to develop it or contract out for something like that?
Ted, do you want to go through what we're doing for right now, independent of Apple and Google?
Yeah, well, actually, not much more to add. I think, as Dr. Varma said, we're considering all options about what would make sense in the context of the program rolling out in June 1. These would all be enhancements on top of it, but would welcome continued input, and we are thinking about all options.
Okay, thank you. And so just to the entirety of the contract tracing program, I think yesterday, maybe I'm wrong, but I think yesterday was day 75, maybe it's day 76 now, somewhere in the 70 to 80 range, depending on how you measured it. Why not have started a contract tracing program in March when we had first indications that there was a epidemic on our hands? I understand why it's difficult. So I just want to be clear. I understand why it's difficult to do at the highest moment, but why not start this version of the process that we're doing now back then when we had clear signs we were going into a pandemic, the numbers were rising. We could have put this entire program in place of hiring people, figuring out the organizational structure, and doing most of the measures that we're doing today, hotel space, things like that. Why do this on May 15th and not do this on, perhaps March 15th?
Well, Councilmember, I'll start, and then turn to others. Boy, there are a lot of things I'd like to redo if we could start again. The issue at the very beginning, we were doing contact tracing. DOHMH was doing a great job of it. But when it turned out that there was evidence of widespread community transmission and you couldn't actually track where it came from, it went much more to a community mitigation strategy. I think that in terms of the last couple of months, I know the city has been totally consumed by making sure we had enough supplies. I give the mayor tremendous credit for, being on the phone late at night with the federal authorities, the state authorities, trying to make sure we have enough PPE, trying to make sure we didn't run out of hospital space, trying to make sure we didn't run out of ventilators. I mean, it was nightmarish to try to make sure that we had everything. And it was after, the peak turned that we were able to envision another world. But let me ask Dr. Daskalakis about the issue of tracing earlier, and did we miss something there?
So I think you covered most of it. I think, again, this speaks toward one of the really important sort of observations in public health, which is that preparedness is really important. And we were prepared, but when an epidemic becomes a pandemic, we have to shift our resources into more community-wide strategies that work to flatten the curve. And sort of the movement into that phase happened very quickly in this pandemic. And I think part of it is on the back of some of the really significant fumbles made by the federal government around testing and our inability to actually detect these infections beyond using indirect strategies like our syndromic surveillance. So I think that afforded with the opportunity that other countries had of really amazing testing from the very get-go, I think we could have been in a very different place. I am skeptical as to whether containment of such a infection is feasible. But I think we would have at least had a better shot if we weren't working in the dark because of, again, those sort of CDC fumbles in terms of getting us testing in an expeditious way.
Well, I'm not gonna use much more time here because I'm going to be respectful of my colleagues, but I hear all of you on that. I understand we were in the middle of a pandemic. All I'm saying is I think we could have started this process a month ago in terms of hiring people up. So as we lowered the infection rate, we had the systems in place to then move into the tracking and tracing program that we're capable of. I think we've lost about a week with this fight that we've had, this public sort of debate that we had. I'm not saying it's everybody here's fault, but I think we've lost even just a week in that role, in that process. And we could have started this a long time ago. I just want to ask one more question. Is what is the role here, of just continued social distancing in the tracking and tracing program, and particularly, if I'm working from home, am I treated differently than somebody who's like an essential worker? Do they get priority? How does that work in terms of the track and trace program?
Well, I'll start and then others can fill in. So social distancing will remain a critical aspect of this. And I think even as things open up, the open up when it happens, I think is all going to be at least 6 feet apart with all of us wearing facial coverings, even as things open up. I think that even if you're an essential worker, even if you're a healthcare worker, if you're infected, you need to be isolated. And in that sense, the rules don't change. It may be easier for somebody who can work from home to be isolated at home, right? It may be less stressful for them, and they may not need economic support the way an essential worker may need it, but the rules are the same.
Okay. All right. Thank you.
Thank you, Council Member.
Thank you to both chairs, and thank you for everybody. Thanks.
Thank you, Councilmember Powers. We'll next hear from Councilmember Lander, followed by Councilmembers Ayala and Barron. Councilmember Lander, after the chair cues you, you can begin after the sergeant tells you it's your time.
Thank you, Sarah. And over to you, Councilmember Lander.
Your time will begin now.
Thanks so much. This has been a very useful hearing, and I appreciate the chairs and the administration reps and the spirit of both honesty and looking forward. And personally, as someone who has not been as close to the public health system, I'm especially happy to see Jackie Bray's involvement, as I've found her to be one of the most effective people in New York City government just at getting shit done. And her position in the operations here helped give me some confidence. I have an operational question for her in a moment, but I do want to drill down on just 2 questions about the past that really have been addressed, but I just want to make sure we're clear on them. So first, Dr. Katz, I really appreciate your point about humility. I have gotten so many things wrong myself this year, but I just want to make sure I understood what you said earlier, because it's a little different from what we've heard from the mayor, the governor, and certainly from the president. With the benefit of hindsight and without any intention of assigning blame, do you now agree that we should have moved to shelter in place earlier?
Oh, of course. I can't believe any sensible person looking at those facts wouldn't say that.
I appreciate you saying that, and I think it's useful to be clear. There are quite a few people even looking at the facts that have not been as clear about it. So let's leave it there. I appreciate your saying it. Thank you. And then Dr. Daskalakis, this really goes to the conversation that you just had with Councilmember Powers. But one thing City Hall has said on the record is that DOHMH should have been doing contact tracing earlier. And this was even cited as one of the reasons that the tracing would not continue to be housed there. Even though it's my sense, I really agree both actually with what Dr. Katz and you just said, that once it becomes so widespread, the tracing is not meaningful in that period. It sounds like you wish we had been able to rise to it earlier, but that you disagree that it was a fault of DOHMH not to have continued doing it.
So I think I couldn't really say it better myself. Thank you. So I think the answer from my perspective is that given the fact that we were working in sort of a black box of not being able to see really the spread of the pandemic through testing eyes, when it became clear through our sort of strategy to not follow guidance from the CDC to actually test people who were not just returning from China, but also from other places and with severe disease. By the time we were able to detect that as cases, because as you remember, case investigations mean that you have to find cases. And the only way to do that is testing. And And so I think that this amazing upscale of testing that you've heard about by so many people will be critical sort of in this next chapter. And I guess one of the important lessons, I think, in general is that public health needs to remain a priority from the perspective of capacity. And so I think that the lesson walking away from this is that capacity matters during peacetime and during wartime. And so it's really critical to maintain it. So again, I agree with what you said.
All right. And I want to thank both of you because I do feel like, I came into this hearing, I'll be honest, very upset about like the sniping and what's in the press. And I feel like the spirit of like being open to self-criticism and being honest and it really helps us move forward in a much better way. I'd love to see that more from some of the people, higher up. I'll just say it. I'd like to see the mayor and the governor. I'm not like the president is beyond hope, but I'd love to see the mayor and the governor bring some of the kind of like data-driven, okay, you can self-reflect and say we didn't get everything right. And that gives us more confidence that we can move forward actually in the right way. So I'm going to move to my operational question, which is about the database, because like, as you're trying to stand things up, like you got to worry about the hiring and you got to worry about that contracting and you got to worry about the tracking and the reporting. One thing I have found to be really hard is getting a good database system in place. So when I test positive, I guess I go into a database. Is it an is it an H&H database? When I give my contacts to the contact tracer, do they go in that one or a different one? If I need a hotel room then, or one of my contacts does, who has the database with the hotel room that matches me? When, as Mark said, I need someone to walk my dog, is that in the same database? And are the people that are going to be doing the walking? I've read that you're contracting with Salesforce, which I think surely makes sense, but I also thought I heard Dr. Katz say there was a pre-existing DOHMH contact tracing system. Is any of that integrated with New York State or New Jersey or Connecticut? Help give me confidence that like you're working all those issues out and this thing on June 1st when those other issues are ready is going to be ready to stand up.
I'll start and then others will follow. I want to first say how great Jackie Bray is, since you gave us that opportunity, because we're thrilled to have her, and she did an amazing job. I mean, she and I were on the phone about ventilators, about PPE, 11 o'clock at night, midnight at night. She was phenomenal for us. I think the first part of your question, though, relates to data systems. So I'll let Ted talk about that, and then Jackie talk about how those other services get provided.
I'll be very brief and I'll turn it to Jackie. So the information about positive tests is shared from our healthcare providers to a state database under a HIPAA public health exemption. Then the state database is combined with other public health data and made available to our tracers. And I'll let Jackie explain programmatically how that works.
Yeah, absolutely. So as Ted said, the first thing that happens is all lab results statewide go into a system called eClares. That is the state system. That's shared with all local public health authorities. Our public health authority is DOHMH. That goes into a database called Maven. And Maven appends to the eClares data a bunch of other information, vital statistics, some RIO information, information from the city administrative data, which is really what helps us get a hold of people, right? And so what we're doing is we're building Salesforce in a way that talks to Maven so that Maven can push all the data to Salesforce. Once that data is in Salesforce, Salesforce is an intensely powerful software and really first in class on case record management and customer service management. That was important to us, that it wasn't only a good case record management system, but it really had a customer service interface to it. So once that data is in Salesforce, then all of what we're doing, unless you get moved to a hospital, is in Salesforce. And so whether or not we need to walk your dog when that's up and running, we can't walk your dog yet, but when that's up and running, but certainly if you need meals delivered, that's in there. Did we call you yesterday and check on your symptoms and what were those symptoms and how were you doing? That's in there. Who are your contacts? You're the index case. Who are your contacts? And then when your contacts become cases themselves and how we see that interrelation is in there. The way that we push out messaging to our cases and our contacts or the people that are in our care is in there. If you end up needing to go from your house to the hotel, whether or not you showed up at your hotel is in there. So that's the Salesforce is a really powerful tool for us. The data starts at the state, gets pushed in real time to Maven, pushed in real time to Salesforce. In terms of your question about how we talk to the state, obviously we understand that contacts and cases are going to cross county lines. So the state is using an application called CommCare. CommCare, we are building with the state the ability for CommCare and Salesforce to talk to each other so that we'll know I'm sick, but my father lives in Westchester, and yeah, I saw my father 5 days ago that he's now a contact. That's now for Westchester's tracers to pick up to trace him.
And that's ready now. That will be ready
That's
by
ready.
June 1st.
So our build out for our system will be ready June 1. The build out to make sure that we're talking to the state, we can get back to you on an update on that. But the goal is to do that as fast as we can. But I'd want to check with the tech teams to give you a date.
Thank you very much.
Yeah, of course. And thank you for embarrassing me there.
You're welcome.
But I appreciate it.
Thank you very much, Councilmember Lander. We'll next hear from Councilmember Ayala, followed by Councilmember Barron and Ambry Samuel. Councilmember Ayala, you can begin after Chair Levine, and then the sergeant cues you.
Thank you, Sarah, and take it away, Councilmember Ayala.
Thank you all so much. I
Time will begin.
have to say that I'm really happy that you guys put this together. I feel like I've learned so much, but I also feel like I have a gazillion other questions that I now need to ask. But my first question, and I'll ask the questions first, I guess, and then if I have to go back and repeat them. What is the anticipated cost of pulling something like this off? Is that in the projected budget? 2, is tracing happening citywide initially, or are we going to be targeting the hardest hit communities first? I have serious concerns about the cultural competency part of this whole process and what your plan is for ensuring that you're communicating as effectively as possible with communities of color, specifically communities where we have lots of non-English speaking constituents. And last but not least, what is your plan for dealing with the mental health issues that come with the social isolation? And I'm happy to repeat.
I apologize. Dr. Katz has been put on mute because he re-logged back in. If somebody could unmute him.
Thank you so much for unmuting. These are a great set of questions that you raise. We want to make sure that we're doing this right. And I'll ask on the budget. I will say that this pandemic has taken us to places we never imagined, and our attitude is that money can't be our number one consideration. That everything has to be about saving lives. Not to mention that the economic destruction from the closure of New York City has been devastating. I know you know this, council member, the high unemployment rate, the way it's affecting low-income people, that in a sense, there's almost no price that's too high to pay to get the New York City economy back into place, because it in and of itself will generate the money that will pay for these services. We are trying in every case to make sure that it's billable to FEMA. We have people who are FEMA experts. New York City had to deal with Superstorm Sandy, which I know you were involved with the response of. We have a lot of experts on how to make sure that the claims to FEMA are such that FEMA will be able to pay for it. So we are going on to the assumption that we will have to spend whatever money we have to. We're not being reckless. We look to get things at the best price, but we're not using money as a limitation. Can you, Dr. Long, talk about your efforts around cultural competency that are so important to this effort?
Yes, absolutely. So there's 3 things that we're doing that are very important to address the points you're bringing up. The first is that we're working with CBOs to prioritize hundreds of CBOs, hiring tracers from the communities that they'll be doing the tracing in. Second is that we're hiring the resource navigators from the communities that they know well, where they'll be providing those services. And as my patients tell me, I need to be able to help them to get what they need at home to be able to successfully isolate. And third is we have formed the Community Advisory Board under Dr. Torian Easterling at the Department of Health. And we're already getting some great feedback about how we need to structure the program in order to be culturally sensitive and to involve the communities. The second point you were asking about was mental health. And just to say a word about that, in our hotels, we have a robust mental health program that we've created. And for those isolating at home, we've built out telehealth to allow them to connect with us as well. And I'm proud to say on the primary care and ambulance and outpatient side, we've done more than 120,000 telehealth visits, which is giving 120,000 people the care that they need from their home, which includes mental health. And I think that's so important.
And the question on tracing, is that happening citywide at first, or are you going to be focusing on specific communities first?
We plan to focus on the communities that have been hit hardest so that we can help them as soon as possible.
And that's my concern. So then, has the conversation with the community-based organizations already begun? Have those hires already, have people already been hired to do these jobs?
Yeah, great question. We now have more than 500 people, many of which are clients from community-based organizations that are being onboarded today. So very much in the works.
And what is the qualification for a tracer?
The tracer needs to go through a training and pass a test. And then otherwise we review any application we receive. In particular, I will say that the way that we review applications, we're prioritizing the applications that are flagged by community-based organizations.
Time's up.
To bring them to the front of the line.
Thank you.
Of course.
Thank you very much, Councilmember Ayala. We'll next hear from Councilmember Barron, and then Ampry Samuel, and then Moya. Councilmember Barron, you can begin as soon as Chair Levine and then the sergeant cues you. And as a reminder to everyone, if at any point you accidentally mute yourself, or if you mute yourself and need to be unmuted, you can also use the raise hand function in Zoom. Thank you. Chair Levine, you can cue Councilmember Barron.
Thank you, Sarah, and Councilmember Barron. We look forward to hearing from you.
Your time will begin.
Councilmember Barron, you're unmuted.
Thank you very much. Thank you to the chairs for having.
Hold on, if you could just restart her clock for her. Thank you.
We will do that now, sir. Thank you.
You may begin.
Go ahead, Inez. I think we may have lost Councilmember Barron.
We can come back to Councilmember Barron. Next, we'll hear from Councilmember Ampry Samuel. Chair Levine, please cue her.
Okay, thank you, Sarah. And you're up next, Councilmember Ampry Samuel.
You may begin.
Hi, everyone. Good afternoon. Thanks, chairs, for this very important hearing. My colleagues already addressed a lot of the disparity concerns that I wanted to touch on. So I just want to lend my voice on a lot of the points that were already made. I have my own personal experiences with testing since March 11th, and the level of frustration that it caused my family. My colleagues know, and I know the administration already know, but it was a lot. And the other experiences as a result of representing a district that the city and state did not prioritize was just another level of frustration. So when we talk about the numbers of people who tested positive and were hospitalized, I and my colleagues in certain communities were left to guess or assume how many of our constituents were dying in their homes without a diagnosis. So data in this city can mean many things. Although data should tell an accurate story and give a factual picture, when you manipulate certain data, it can say what you want it to say. And so data can be manipulated and interpreted in so many different ways. So I just want to make sure that when we're talking about data, we're accurately reflecting what's happening on a community level, because we saw what data did not show or what it wanted to show in the past, just in the first 8 weeks of the pandemic. So the rollout of testing and contact tracing of thousands of people in Brownsville and Ocean Hill and Crown Heights and East Flatbush and Bed-Stuy is different from a rollout on the Upper East Side. And Dr. Katz, you mentioned culturally, to make sure that we do this in a culturally competent way. And then Dr. Ted Long mentioned hundreds of CBOs are working to help with hiring, and you mentioned Dr. Easterling's role. But it's not enough to be culturally competent, because you have cultures within side of cultures in certain communities. And so in my community, you would need to make sure that we have people at the table that can talk about the Tuskegee study, that can talk about what happened with Willowbrook, that can talk about what happened at the Jewish hospital right here in New York City, because these are things that took place during a time where people are still alive. And our seniors remember that and know that and talked about that to their grandchildren, their children. And so culturally competent is making sure that there are people that can go into the homes and educate and do outreach in a competent way that talks to the Tuskegee study. And so I want to make sure that when we're doing that, we're not just talking about, yeah, we have CBOs that, that have people of color in them. That's not appropriate. And the fact that we have to ask questions about, who's been hired and what CBOs are you working with is ridiculous to me, because, we should know this. The elected officials, the local elected officials should know this information. The fact that I don't know any community-based organization within my district that has been part of these calls over the past few days, I think is a little, I'm glad we're having this hearing, but I just wish that, or I ask that we be included in the conversations moving forward so that we can put some other thoughtful or added value information and input to the conversation to make sure that the rollout is appropriate in all communities. So again, my colleagues already touched on a lot of the points, but I wanted to add my voice and just put that out there to make sure that the local elected officials are included.
Thank you, and we'll make sure of that in both directions. We're open to your suggestions on who you want to be involved, and we will provide the information to you on who from your district has already been involved. Thank you.
Thank you.
Thank you very much, Councilmember Ampry Samuel. It appears that Councilmember Barron is back, so we'll next turn to her, followed by Councilmembers Moya and then Yeager. Councilmember Barron, please begin after Chair Levine cues you, and then after the Sergeant calls you.
Thank you, Sarah. Welcome back, Councilmember Barron, and we look forward to hearing from you.
Barron, you may begin.
Thank you. Thank you much. I want to thank the chairs for having this hearing and the panel for coming and sharing their information. I'm following in the vein of what my colleague Alika Ampry Samuel has talked about. She's mentioned some of the historical instances where Black and Brown communities have not been treated equitably. And it has happened even with this pandemic. As she had said, we were not in that chain of, let's say, making sure that we get what we needed, even though our community had many of the underlying conditions caused by the historical racism that we've been subjected to, that we had those conditions, and knowing that we would have large numbers, we did not receive those resources. So in terms of the ethics and privacy, I'm concerned. I'm hearing now that you want to develop an app, and that this app may be able to have access to people's phones and be able to track where they may have been. And this information, as you're saying, is going to be stored securely, and it's not going to be accessible. That does not mean that this information will not, in fact, be able to be subpoenaed by other agencies, such as the NYPD, to be able to gather information that they may try to get in advancing any kind of cases that they may be looking into. And so Black and Brown people have the historical knowledge of Henrietta Lacks, of Dr. Sims, of the Tuskegee Institute, and the immediacy of knowing that provisions were not made for us in this beginning pandemic to be able to get the resources that we need. So I don't know that we can expect the data that we say we're going to get from this will be able to be helpful when people are going to be justifiably suspect as to how this information might ultimately be used.
I understand and I agree with all of the points that you've raised. I want to clarify just more for our listeners that any app would only be if people voluntarily wanted it. We're not going to have any apps that people have not agreed to, but it makes me uncomfortable, I have to say. We will continue to work with our lawyers to make sure that all information is held to the highest degree. But I fully understand and support your points.
And then in terms of this legislation that's before us, is this mandatory? Because we've seen video of mandatory laws being implemented in Asia, where people are dragged out of their houses, where they are forced into being restrained in areas that they may not want to be in. So is this mandatory? And what would be the implications for those people who resist and who don't want to leave or who don't want to go to a hotel for whatever their reasons are, and that they see this as an invasion of their privacy? There are people who are concerned that this is really a violation of the Constitution. Yes, we have concerns, legitimate concerns about preventing the spread, and we have to do all that we can, but is it a violation to force someone to take those actions that we feel would be beneficial for the larger community?
Absolutely, we understand. We want to try to create an environment where people want to be able to isolate. The first start of that will be, can you isolate in your home, right? Hotels are not the first choice, right? If somebody has, and even if they live with other people, it is possible to isolate if there's a room where that person can stay and someone can bring the food and leave it out there. But we will want to make the case to the person that if that isn't possible, that they don't want to put the other people in their household at risk. People don't want to infect their grandmothers, their aunts, their children. People understand, I think, how serious this is, but I totally agree with you. It has to be done really sensitively and well.
And for those who decide that they can isolate in their homes, will they be able to get the same kinds of support services that you talked about? If they're the caregiver for the persons that are in their home and they have to be there to make that provision?
Yes, we will, regardless of where the location, the same services will be available to them.
Okay, I'll be back for the second round of questions. Thank you so much.
Thank you so much.
Thank you, Councilmember Barron. We will next hear from Councilmember Moya, followed by Councilmember Yeager, and then Eugene. Councilmember Moya, you can begin after Chair Levine and the Sergeant cues you.
Thank you, Sarah. And I also want to acknowledge we've been joined by our colleague, Councilmember Carlos Menchaca. And now, Councilmember Moya, please take it away.
Thank you.
Moya,
Thank
you may
you to
begin.
the speaker, and thank you to both the chairs for hosting this great hearing. In particular, I want to thank Chairwoman Rivera, who was instrumental in helping get some much needed PPEs to Elmhurst Hospital, the hospital that I represent, which really is the epicenter of where this has all been happening. So thank you, Chairwoman, for your kindness in thinking of us here in this district. My question really goes to the heart of what's happening in my area. As I said, I represent Elmhurst Hospital, ground zero here, but it's also a large immigrant community. And when we start talking about the technologies that are coming in here, and I'm sorry if someone's asked this before, but I stepped out for a second, but what will there be clear and enforceable prohibitions against the use of individual or aggregate data for profit or any other purposes beyond protecting the public health? If there is, can you please explain those prohibitions? Will any of the data also be shared with any other entities? For example, the NYPD, law enforcement agencies, including ICE? And what, if any, will the NYPD play in monitoring the spread of COVID? And what's going to be done to ensure that that data is not shared with federal agencies, including ICE?
Thank you, Council Member. Let me start by thanking you for always supporting Elmhurst. And I think the recent events show why public hospitals matter, right? That in that wide central Queens, Elmhurst was the one that people went to because it was there, because it's trusted, because people know that they're not going to be discriminated against because of their immigration history, or if they're homeless, or if they're poor, that nobody is going to look down on them and that they can rely on that. And if it weren't for people like you to support hospitals like Elmhurst, it would not have existed. Public hospitals have gone away in other places. We are absolutely committed that none of the data that is collected will be shared. We're working with both City Hall law and the lawyers for H&H to be sure that that data has the fullest protection of the law. We will not share that data, and we certainly will not sell that data. And DOH-MH, which will hold the data on people who are positive, has a long, proud tradition of protecting the confidentiality of that data, of not selling it, not using it against people. You have 100% of our, effort will be meant to protect that data.
Great. And just lastly, since going back to tracing, because this spreads so quickly, what are the modifications, or what modifications are being made for how you're going to monitor this tracing, right? Because it's like nothing else, right? You could be standing next to somebody and you can get this, as opposed to other viruses that we've seen before. So what are the modifications that are being made to deal with something like that?
I'm going to let Dr. Long and then Dr. Daskalakis talk about their models, but I just agree with you. Wow, boy, it's difficult, right? Such an infectious organism, still not even 100% clear, right? And one of your colleagues referred to this, Councilmember Holden, right? First it's 6 feet, then someone says, well, maybe it should be 10 feet. Someone says, it's 10 minutes of intense, contact. Someone else says it's 20 minutes of intense contact. Really, we're continuing to learn about this. So what are you, Dr. Long, Dr. Daskalakis, what are you thinking?
Yeah, I'll start and then I'll turn to Dr. Daskalakis. So the first part, we're continuing social distancing to prevent people from getting infected. But in concert with that, how we're doing the tracing is we're identifying people that they have been in close contact with, and we're doing that together, bringing together all of the recent evidence about who exactly close contacts should be, and that's a cornerstone of the operation. I'll turn to Dr. Daskalakis if you want to add more onto that.
Yeah, I think just briefly, I guess more echoing than anything is that contact tracing isn't, it does not exist in isolation. And so the sort of notion that all of the sort of mitigation efforts that have already happened will need to be maintained. Now, that doesn't mean that closures have to be maintained, because that would not really be feasible. I think really it's about the sort of new society that we've created in the setting of this pandemic, where folks will have to maintain physical distance, so not social distance per se, because we want them to interact. And then also, face coverings, hand hygiene, and all of the other pieces that need to fall in place. So I think that, really we're going to be looking at a very different way that we're going to live, but a way that will allow us to open. And so I think that is sort of where contact tracing becomes really critical, that along with the sort of evolution of what mitigation looks like, contact tracing really gives us the opportunity to really hanker down in areas to try to even further reduce transmission. So I think your point is really, really important. And this is not like a virus that we really take lightly. We know that it is pretty infectious, and that really the every tool in the toolkit is going to have to be used. And I hope, and not to sort of be too optimistic, but I really hope that one of the tools in the toolkit will eventually be a vaccine, when these interventions will be able to take over these other non-pharmacological interventions that have become such a fabric of our existence around the pandemic. So really, again, an important string, another important piece of that fabric now is going to be contact tracing, along with all of the other things that will scale back and scale forward depending on what the pandemic shows us.
Great, thank you.
Thank you very much, Councilmember Moya. Next will be Councilmember Richie Torres, followed by Councilmember Yeager, and then Councilmember Eugene.
Got it, okay.
Councilmember Torres,
Oh.
please wait until Chair Levine cues you, and then the Sergeant cues you next.
Thank you, Sarah. And I'm pleased that we have the lead sponsor of the legislation that we are considering today that would mandate important reporting about contact tracing, Councilmember Torres, and we'll cue you for your questions and comments, please.
Thank you, Mr. Chair.
Torres, you may begin.
Thank you. I just have a few questions just for the administration in general. When did the administration learn about the outbreak of SARS-CoV-2? When?
It's funny how the last few months are just like some crazy blur where every day is the same. The first case in New York City was in January, was March 1. I remember in January receiving a call for Howard Zucker about the pandemic in Wuhan and New York City. Both the health and hospitals and DOHMH stood up their emergency operations mid-January.
So by mid-January, you were aware of the outbreak of a novel coronavirus, correct?
Yes.
And at what point did you realize that this was a virus that could spread via respiratory droplets, person to person, that it was highly infectious?
I'm going to ask Dr. Daskalakis, and I'll come back. You want to? Can you say a little bit more about, the earliest parts? I think in the earlier parts, it was less a healthcare issue, and I was less involved in some of it.
Sure. I'll take us back a bit in January when we first heard about the first 41 cases that were reported in Wuhan. One of the sort of clear observations that were made at that point were that all of the cases, at least based on what was released from China, that all of them were tightly associated with exposure to a wet market in Wuhan. Soon after that, we started hearing about potentially person-to-person transmission and then exportation. So first it was, this is likely something that's called a zoonosis, which means something that potentially goes from animal to human. The thought was, at least the early observations were that that this was really not something that was spreading person to person. That was probably mid-January that the conversation was still around this exposure. The next phase was that we heard about exportations. So I remember well, I can't remember the date, but I remember hearing about exportations to Japan and other parts of Asia. And then soon thereafter, we started to hear about local transmission. And that is sort of brings us back to the times when I want to say it was mid-February, I have to look again, I don't remember, but when the first case in the US was reported in Seattle, it was also an exportation and that was related to travel in China. And so I think that, as Dr. Katz said, part of this really is around humility. And I think the entire world was learning more about this as it was happening. And so really, I remember really getting sort of the word from.
I'm sorry, am I on a clock? I don't see the timer.
I'm sorry. I think I made my point.
Am I on a clock or?
Yes, council member, you have about a minute and a half left.
Okay, that I didn't realize I was on a clock. I apologize. It just seems to me that if we've known since January that there's a new virus that is highly infectious that spreads through respiratory droplets, if we had that knowledge since January and we've undertaken mitigation since March, why are we only beginning the process of building a contact tracing capacity in May? Like, I don't, like, if we knew that there was a highly infectious virus that A, spreads widely and rapidly and has the potential to strike New York City with catastrophic consequences, if we knew that back in January, February, or even March, why are we beginning the process of building a contact tracing team right now? We've always known that after mitigation, we would have to revert back to containment. So I just don't understand why we're having this conversation in mid-May. That's my frustration with the administration's response.
I think, but DOHMH was doing excellent contact tracing in February, March, and onward.
How many contact tracers do we have back in March?
Dr. Daskalakis?
Yeah. So we had about 100 contact tracers who are working on this, and that's the number that we have at the Department of Health. And there has been since an increase.
Look, I'm not an epidemiologist, but it seems clear to me that 100 disease detectives or epidemiological investigators were never going to be enough for post-mitigation contact tracing, it seems to me. So I'm just frustrated by the slow nature of the administration's response. I know I ran out of time, but
Councilmember Torres, I just want to just follow up just very quickly on the point that you made. You know, Dr. Katz, I know that at least Councilmember Levin, and there may have been others, were saying at the beginning of March, along what Councilmember Torres is saying, hire up more contact tracers, we're going to need it. So why wasn't that done, I think, is basically what Councilmember Torres is asking. Why didn't we continue to build capacity over the last 2 months?
I'll again ask Dr. Daskalakis. My understanding is that we have hired additional disease detectives during that time, and that now we're trying to gear up for a whole new size effort. But Dr. Daskalakis, can you talk about what you were able to hire?
Yeah, so we were able to, we now have on board 200 disease detectives, some of whom will be going over to Health and Hospitals, seconded over there to do this effort. So I think, again, it speaks to a really important notion that that investment in public health is a very important investment, and that during peacetime, what happens very often with public health is that that it sort of gets right-sized. And so I think that it's really important in this conversation to remember that making sure that public health is appropriately resourced is critical to be able to achieve the goals. And so I think this is a pandemic of we have not experienced anything like this really since 1918. And one of the really sort of significant issues that hampered this really was the fact that we did not have early detection. And it goes back to the fact that, again, we had lots of fumbles from the perspective of the federal government rolling out testing, a lot different than places that use containment efforts early on, like Korea. So I think that really looking at the history, unfortunately, I think a lot of the story of the pandemic in the United States can be told really from the perspective of missteps on testing and rollout across the country.
We're going to have another round of questions. Richie, if you want to hang on, we'll come back for a second round. Committee Counsel, who's next? I believe it's Councilmember Yeager or Councilmember Eugene.
Yes, thank you, Mr. Speaker. Next, we have Councilmember Yeager, followed by Council Members Eugene and Reynoso. Councilmember Yeager, you can begin after Chair Levine and the Sergeant cue you.
Thank you, Sarah. And now we'll be hearing from Councilmember Yeager.
Starting time. Thank you, Mr. Chair. Thank you, Madam Chair, and Dr. Katz, and ladies and gentlemen, thank you very much for being here. Good afternoon. First of all, I do want to thank the two chairs, and actually, it frequently happens that when Chair Torres asks questions, you can elicit more information in the 5 minutes that he's allotted than you get in the 2 hours before he got here. But before he spoke, and I really appreciate that. We really hadn't heard about some of the challenges and the delays and why we're starting, but I'm going to focus on where we are now and where we move forward. And we've heard a lot and we've read a lot over the last couple of days in particular. I just want to say at the beginning, I couldn't agree more with, I think Madam Chair mentioned this, I think Mr. Speaker mentioned this, that it is sad and unfortunate that the last few days we've seen things in the press, and I'm going to reflect on what I've seen. I think it's unfortunate that DOH spent its time planting misleading information in the press about HHC's operations. That hasn't been said as openly as I'm saying it, and I'm saying it because I think that's what happened. If one were to arrive here today from a different place and a different time, you would be able to forgive them from believing that perhaps the mayor has chosen, say, the Department of Transportation or the Environmental Control Board to manage the tracing program in this city. What he actually chose is the Health and Hospitals Corporation. I just want to ask a few quick questions, Dr. Katz. You hold a medical degree?
Yes, sir.
Okay. You licensed to practice medicine in the state of New York?
Yes, and I do practice at Gouverneur.
Okay. Is the Health and Hospitals Corporation the largest municipal hospital corporation in the United States?
Yes.
How many people do you employ there?
About 35,000.
How many people do you know are employed by the Department of Health, if you know?
I would have to ask them, sir. I don't know that number.
I'm told it's 6,000, but
that sounds correct, in the ballpark.
I also understand you have a budget of approximately $8 billion. Is that correct?
That is correct.
The Department of Health, I understand, has a budget of about $1.5 billion. You operate dozens of hospitals and community health facilities in nearly every neighborhood in the city. Is that correct?
Yes.
Okay. So I think that some of the conversation has been lost because we're choosing to focus on some kind of political thing of perhaps the mayor did this, that, and the other thing versus the fact that the largest hospital corporation in the United States, possibly the world, Municipal Hospital Corporation, has been tasked with this monumental task of, and some of what I've been hearing about the concerns that members have, for example, food. You have dozens of cafeterias around the city. Laundry. You own dozens of laundromats in the city. There is, I don't think, a single city agency that owns as many cafeterias and laundromats as you do. You own your own pharmacies. So the notion that perhaps you are the wrong entity to be managing this Herculean task, I think, is misplaced. And I don't think most members are saying that, but I do think that somewhere in the reporting, it's been indicated that this is something other than what we're seeing, which is simply that the mayor looked at the task and said, HHC is the right place for this. And that's the choice that he's going to make because he's the chief executive of the city. Do you feel comfortable that the HHC can do this job?
Yes, in collaboration with DOH-MH, absolutely.
Okay. And that's an important point that you're bringing out, Doctor, because DOH is not shutting down and going away. They're being part of your operation. In fact, they're being integrated into your operation, as you've testified earlier today. Is that correct?
Correct.
Okay. And you're bringing over some people to actually manage from within your corporation the work that they're doing to kind of really seamlessly integrate it together.
Yes.
Okay. I appreciate that, I wanted to make sure that this information is really out there in as clear and unquestionable fashion as possible so that this conversation of the wrong choice really dissipates, and so that you can get on with the work that you have to do, because it is a Herculean task, and there are going to be thousands and thousands of lives affected by your work. And I would very much like to get out of your way so you can do your job, and I intend to do so. I have a quick question in the last couple of seconds. You can take as long as you need to, but I just want to make sure Councilman Torres has a bill that's being heard today, pre-considered introduction. And I haven't really heard you reflect on it too much, and I just want to make sure that you get a chance to do so. But it requires the daily reporting of the stats as you come up with it. I like that. I just want to hear if you are comfortable that daily is something that you can do well and without hindering the work that you're doing, or is it something different, or do you have any thoughts or ideas on it?
Yes, and I appreciate all of your comments. I'd like a little bit more time on the daily, and there may be a modification of daily. Even some of the data we provide now daily is a day or two lagged because you don't actually have the data always in real time for the number of infections. So I'm positive we can do it weekly. I think we may be able to do it daily if we're allowed some lag. I just don't want people to think that this is as simple as a scoreboard and somebody, hits a home run and you add a little 1 on the scoreboard.
All right, Doctor, my time is up. So again, I just want to thank you and your team for what you're doing and for being here today, and to thank Mr. Chair and Madam Chair for their work leading this important inquiry today. Thank you very much, Mr. Chair.
Thank you.
Chair.
Thank you very much, Councilmember Yeager. We'll next hear from Councilmember Eugene, followed by Councilmember Reynoso, and then Maisel. Councilmember Eugene, please wait to be called on by Chair Levine and then by the Sergeant. Thank you.
Thank you, Sarah. And I'm pleased we'll now hear from Dr. Matthew Eugene.
Thank you very much, Mr. Thank you very much, Mr. Chair. Can you hear me?
Yes, please.
Okay. Thank you very much, Mr. Chair, and thank you to both of you chairs, and thank you also to the speaker and all the participants. Dr. Katz, I remember in the last public hearing we had, I raised my concern about the ability of our health system in the city of New York to handle the crisis, the coronavirus crisis, COVID-19 crisis, because I mentioned, if you do remember, that I believe we didn't know enough about this new virus. And this crisis that we are facing now is a horrible crisis, and our ability to overcome it depend on many factors. Among them is our knowledge of the behavior or the pathophysiology of the virus. My question is, what has been put in place for the city of New York to continue, for the doctors, the researchers, the scientists in New York City, continue to do research, to learn about the virus, to discover the mystery of this virus, in order for us to really be able to handle the situation?
Well, Council Member, you're so right that we've learned so much. There's still, I'm sure, a lot we don't know. We are lucky as New Yorkers that we live in a city full of brilliant researchers, amazing universities, amazing health systems, both public and private, who have in fact taught us quite a lot about this virus. I'll give one example, is that the practice of proning, which is putting somebody face down to improve their oxygenation, was something that was discovered in a New York City hospital. So, you know, I think we do, as you had so presciently said, when you said it, it was so true. And circumstances have proven how right you were, Council Member, that there's a lot that we didn't know. I do think that health and hospitals did well, and that you should be proud of your public system, and you should be proud of DOH-MH for what we've done in the absence of knowing everything that I wish we had known.
Thank you very much, Dr. Katz. And I know I'm very proud of the health system, and I'm very proud of all the doctors and nurses, the wonderful skilled practitioners and doctors that we have. We are fortunate to have a system like this. But my other question is that we know that this crisis is a horrible crisis, unprecedented crisis that requires all of us to work together to overcome it, to use everything that we have to make sure that we overcome this crisis. But the thing is, the majority of the hospitals were transformed in COVID hospital. And before the crisis, there are many other patients who were suffering from critical disease, very serious disease, that were in need of critical medical care. Could you tell us about the ability of our health system to provide those people who were suffering from critical disease prior to the crisis? What was the ability? Was the system were able to provide them with the critical medical care that they're entitled to?
Well, Council Member, thank you so much for raising this issue. This is a huge problem in New York City and in other localities, where we believe that people have been staying home despite being ill for fear of contacting COVID. We have at all our hospitals, and I know the private hospitals as well, we have maintained areas that are non-COVID so that we can, you know, have happy moments like the delivery of a baby. Children can come and get immunized. People who are having strokes or heart attacks can feel comfortable coming, but people are frightened and they are staying home. And we do think that it's having negative health impacts. We are, as a city, preparing to do some more public service announcements about the fact that all of the hospitals do have safe areas, that people should not, you know, neglect themselves. And we're trying to do as much through phone visits as we can. As Dr. Long says, I see my patients by phone now. So we're trying to meet the need, but I'm so glad you raised this so that it's in public consciousness.
Thank you very much, Dr. Katz. But, you know, I've been always concerned about the ability of New York City to handle crisis, including contagious or infectious disease outbreak and contamination of people when there is a crisis. Because we remember Sandy, we remember previous crises. But my question is, my comment is probably if we create stand-alone hospital, we will be in the better position to handle the situation. Do you believe that we should create stand-alone hospital to prevent the infection, the contamination of other staff in the hospital and other patients in the hospital?
I think it's the right idea, but it proved at New York City had so much COVID at a point that it was extremely hard. I know the Javits Center opened with the idea of being COVID negative. The ship that came from Department of Defense opened with the idea of staying COVID negative, and they found that because of the testing issues that other people have pointed out, the fact that we have not had enough rapid testing, and there was so many people who were infected that it proved impossible. But I like to think, Council Member, your point is still correct, that once we get to a point where we have rapid testing and of sufficient capability, and if we had only had that in January, it all would have been different. But once we have it, we will be able to keep places standalone that are COVID negative.
Thank you. My time is up. Oh, my last question is that now we are seeing that there's manifestation of a rare inflammatory syndrome in children. Could you talk about that in order for the parents to have a better idea of the situation and they can be aware of the preventive measure to be taken?
Well, thank you for raising it. We have seen in the last few weeks the emergence of an inflammatory system disorder in children that affects multiple systems. It is not well understood. One possibility is that it's a post-infection manifestation because a number of the children were negative on the nasal swab but had antibodies for COVID. We know it occurs in the setting of COVID. The most important message, and thank you so much, Council Member, for raising it, is that parents know that if they have a child, especially with a high fever or rash, that they should not delay. They should call their pediatrician. If they don't have a pediatrician, they should go to their nearest hospital, or they should call 311 to speak to a physician. And that physicians need to know this is a reportable disease to the Department of Health and Mental Hygiene, and that these children do respond to treatment. And treatment matters, and it needs to be quick. So thank you again, Council Member, for raising it so that we can have parents and doctors know the right thing to do.
Thank you very much, Dr. Katz. And I want to thank all the first responders, all those wonderful people who put their life in danger to save life and to help us overcome this crisis. Thank you to all of you. Thank you.
Thank you very much, Council Member Eugene. We will next be hearing from Council Member Reynoso, followed by Council Member Maisel, and then Levin. Council Member Reynoso, you can begin as soon as Chair Levine and then the Sergeant cues you. Thank you.
Thank you.
Thank you, Sarah. And we now look forward to hearing from Council Member Reynoso.
Starting time. First, I want to just say you'll hear some noise in the background as my kid listening to his music. Again, I'm on babysitting duty while my wife does work. Mental health, video mental health conferencing from the home is something special. So I'm just not going to show my face, but Dr. Katz, I just want to say it's nice to hear from you. It's nice to see you. It's nice to see all the friendly faces of folks that I work with so much and haven't seen in quite some time. I wanted to ask some basic questions and then get to a statement at the end. But I just want to ask, would you consider yourself to be one of the top advisors to the mayor during this crisis or this pandemic related to health, any health concerns or any health advice that he's needed?
Yes, I think that there have been 5 physicians that he has relied on for advice, and I was one of the 5.
Does the mayor confide in all 5 advisors equally, or is it like a group setting, or is there a one do all end all?
Almost all our conversations were in group settings, on phone calls. Dr. Barbeau, Dr. Daskalakis, Dr. Henze Pere, and now that Jay Varma joined us. So a typical thing is a new fact, something that was in the literature, some question would come up, and the mayor would ask in what I think was a very positive, productive way, what do the doctors think? And I think about 85% of the time we agreed. I think sometimes we disagreed. And I think that facts have shown that sometimes each of us was right and sometimes each of us was wrong.
Right. So because you've already stated it before, but you talked about being humble, Dr. Katz, and it's just something that it seems to be far and away one of the virtues that our mayor seems to hold in this pandemic at this moment. Can't seem to take the time to recognize that, you know, infighting and whatever it is just needs to go to the wayside and we just need to get work done. But it seems like there are 5 advisors that all have some value and some level of advice that they give to the mayor. And it seems like almost we're foreshadowing the scapegoating of this whole pandemic to Dr. Barbeau. And I'm extremely concerned about that. And that your appointment to the head is more so just laying down the foundation for that action, as opposed to it have been a purely professional decision made by the mayor or a medical decision to make H&H in charge. And it's tough right now because we can't tell the difference between the professional work that the mayor is doing and the political work that he's doing at this time. So I just want you to know that any concerns or conversations that we're having about the capacity that H&H or you might have to handle this crisis is not what we're questioning. It's just the intentions or the foundation by which you and H&H being the leads on this is how we got here is what's at question. So I just want to say it seems like there have been 5 people that have been talking and some decisions, you said 15% you disagree, which means in some cases, some people were right, in some cases, some people were wrong. Across the board, we could say the blame was across the board, but, you know, being a woman of color in an administration is a difficult thing to be. And I just want to say that I'm being very conscious of the fact that I feel like there's a public display of discontent for Barbeau, so much so that the mayor during a pandemic is not communicating on a daily basis with his leading health expert. Just thinking about that really scares me about what he's doing, which again, I think is a non-professional thing to do. In a pandemic, he should be talking to Barbeau every day. But in the political terms, of course, it's something that he's not doing. And the last thing I wanted to, I guess that was my statement. I wanted to know who these 5 people in the room were. And was she the only woman in the room? Is she the only woman out of these folks talking?
Well, again, I don't want to say that all of the people advising the mayor were the doctors.
No, but these five, Dr. Katz.
5 of the doctor voices, but there are
5 they're all men except her.
4 men, yes,
okay.
That would be true.
All right, thank you. And then my big concern with the tracing, and by the way, Jackie Bray, the utmost confidence of the work that she can do, and I'm very happy to know that she's on and she's doing this work. I do not want to be in her shoes. I don't want to be in Dr. Ted Long's shoes. This seems like a logistical nightmare, and I don't wish it upon anyone. So I really want you to know that as an individual council member, anything I can do, I really want to be helpful. But I want to be careful about locating every single hotel room in neighborhoods of color exclusively. I'm very concerned about the fact that when you guys start renting out rooms for this contact tracing, they will be put in neighborhoods of color that have already been hit, and in turn can, you know, be dangerous for those neighborhoods. I want to make sure that, you know, some places in Manhattan, maybe the Ritz-Carlton has some rooms, I'm not sure, but I just want to make sure there's equity built in to where you're isolating people related to hotel rooms.
Understood. Thank you.
Thank
you. Most of our rooms are in Times Square.
Beautiful.
I hear you loud and clear.
I get a list of those hotels, Jackie. That would be great.
Understood.
All right. Thank you. Thank you so much. Cheers.
Thank you very much, Councilmember Reynoso. We will next hear from Councilmember Maisel, followed by Councilmember Levin, and then Menchaca. Councilmember Maisel, you can begin as soon as Chair Levine and the Sergeant cues you. Thank you.
Thanks, Sarah. And over to you now, Councilmember Maisel.
Thank you very much. Thank you very much, Chairman. When I got elected to public office about 15 years ago, nobody ever asked me if I was going to be an expert on pandemic or public health. And this has been a very enlightening situation. This committee hearing has been wonderful. So I thank you for that. I only have some logistical questions because most of the questions have been asked. I'm curious about how these hotel quarantine is going to work. For example, people are going to be assigned to hotels, motels. Who cleans the rooms? When food is served, who picks up the food? Are the hospital people, are they going to be trained? How do we prevent people from leaving their rooms so that they don't infect other hospital guests, hotel guests? It seems to me that there's a very easy way to contaminate a lot of other people if the people don't stay in their rooms. And if you've ever been to a hotel or a motel, they're small rooms. It's not like you can spend your entire life there. 2 weeks in the motel may sound like wonderful, but not so much. So I'm really concerned about the staff of the hotels. How do we maintain people, make sure that they stay there, make sure that life is not intolerable? And I'm not so sure that we shouldn't have these rooms closer to the communities where people live. After all, we're isolating them to begin with. Maybe they should be closer to the communities where they actually live. So those are my questions. Hopefully I'll get some good answers.
Council member, those are all good questions. Let's turn to Jackie to talk more about the program.
Yeah, absolutely. So we supply all the staff in hotels with appropriate personal protective equipment. People have gowns and gloves and masks and face shields as required by the work that they're assigned. In laundry and cleaning, so if someone's isolating, it's not like there's going to be someone coming into the room every day to clean the room, right? It's not like a regular hotel stay, but there's significant cleaning upon the turnover of that room, and laundry is placed outside the room and it's picked up and it's handled appropriately. Food as well, handled by folks who are wearing protective equipment and know what they're doing and know how to take all infection control protocols and processes, and we take that really seriously. In terms of where the hotels will be, as we scale this program up, what we're going to really do is listen to the folks that are going into those hotels, right? So if folks are more willing to isolate at a hotel closer to their neighborhood, we will absolutely be offering that. If folks want to isolate at the nicest hotel we can find for them, I've said to the team, we've got to find nice hotels, really nice hotels, because this has got to feel comfortable for everyone. And so we will cater. There will not be guests in the hotel when we're using it. We will rent out the full hotel so that we're operating the whole hotel and bring in our own staff.
Is the city paying for these hotels now, that the 1,000 rooms that we have? Are we paying for them now?
We are, yes.
Okay. So that's an expensive proposition just for that alone.
We do think that will be a FEMA reimbursable expense. That's our hope.
That's right.
And the last thing I wanted to mention is that the committee report does not indicate or indicates that the first contact with the virus came from China, but there's no mention that we have been infected by people coming from Europe. And I think the committee report should recognize that Europe is the point of contamination for the city, not necessarily China.
I think the epidemiology supports that.
Thank you.
Thank you very much, Councilmember Maisel. We'll next hear from Councilmember Levin, followed by Councilmembers Menchaca and Rosenthal. Councilmember Levin, you can begin after Chair Levine and the Sergeant cue you. Thank you.
Thanks, Sarah. And now over to you, Councilmember Levin.
Starting time. Thank you very much. Thank you, Chair. Hi, everybody. So the first question I want to ask is about technology. I've spoken with Google a couple of times on their Bluetooth technology proposal. I know that they're continuing to work on that. Dr. Varma, you made reference to that you guys are considering it, but are not putting too much stake into that technology. I do think that it's important to strongly consider it and see how it can be used as part of the constellation of efforts to support the actual physical traditional contact tracing efforts. I think not in any way to supplant that, but to bolster it. And so I just wanted to get a sense of where you guys are with that, because I think it can be very helpful in this effort.
Dr. Varma? Are you on mute?
Or anyone.
Jay, you're on mute. Can we get
there we
Dr.
go. No, they needed to unmute me as well. I'm sorry about that.
Okay.
Can you go ahead and sorry, can you, I lost the train of thought. Can you repeat the last part of that quickly?
Yeah, just where are we on the Bluetooth effort
exactly
by Google? Because I'll just point out, I have an iPhone. Everyone probably that's on this call has either a Apple operating system or a Google operating system. And so I realize that doesn't account for 8.5 million people in New York City, but it accounts for a lot. And anything that we could do that could help the situation, it won't hurt anything.
No, actually. So basically, I'll just give a little brief background about the way the technology works, which is that the way the Apple Google app is based is it's based on the principle of sensing proximity and duration. So how close you are to other people and how long you are in proximity within that distance. And the idea is that if I have a device and you have a device and we both have our Bluetooth on and we both have the software incorporated into it, that it would be able to register that we were close contacts of each other. The problems with it as it's currently designed are that it currently requires you to have two apps authenticated on your installed on your phone. One is this Apple Google app that that comes from them, and the second would be an app that comes from, say, a public health authority, so like New York City. And the reason you need that second app is you can't have a troll that would say, "I have this disease, let me," when they don't really have it. In the future, in a few months from now, Apple and Google are expecting the software, their component of it, to be incorporated into the operating system, either Android or iOS. But again, it still results from all of those challenges that we'll have. And our goal would be that if there is appear to be uptake, to allow us the ability to use that information as well.
Right, but we have to design, or we have to work with the state to design an app. And so my recommendation would be to outsource that. Spend whatever it costs, $750,000 million, to get a good app developer to build out an app for the public health agency that would probably be the state, because it's got to be that kind of the overall public health agency. But have the app built out. We don't have to. It's not something that we have to spend any time doing, other than just making sure that it's done correctly. But have an app built so that when Google and Apple are going to be, their integrating system for download should be in the next couple of weeks, should be by the end of this month. I think their next upgrades will be later in the summer that'll do it automatically. But, if done in a way that really encourages people and it's a public facing thing and everyone gets behind it, I think that it could be helpful. Certainly wouldn't be hurtful. And then before my time runs out, there's other technology that we can also use, and that is GIS technology that can do all types of other things to identify hotspots, to identify movements and other types of, chains of transmission. And I want to just make sure that we are really putting a lot of resources into coordinating.
Time expired.
Within our city agencies and with GIS systems and other GIS practitioners to really utilize GIS technology as much as possible. This city has been very well served by GIS technology for the last 25 years, mapping the entire city. It helped us rebuild after 9/11. It's helped us in every day in New York City is helped by GIS. And I just want to make sure that we are doing that on a large scale and that it's not, just like a small effort as part of this, that it gets the attention that it deserves.
Yeah, so just very briefly, you're absolutely correct about the importance of analytics. So just to get to for the Apple Google thing, you're absolutely correct about the way it can potentially be helpful. We just don't know the number of people. And I'm also quite hopeful that we wouldn't actually have to develop much ourselves, because Salesforce, which as Jackie described before, which is going to be our sort of overlay and master management system for this, is also being used by a number of other states and local jurisdictions. And so they are going to have to build those types of APIs, those interfaces for this as well. We're going to be okay in that sense. And then second, you're absolutely correct about data analytics and the DOHMH team that Dimitri and other people can describe. They have an incredible analytics team. Some of those star analytics people are going to be working on this team here. And I know that Jackie and Ted, if they want to add more, can also describe their plans to incorporate that.
I think you covered it. Nothing more to add.
Great. Okay. All right. Thank you all very much.
Thank you very much, Councilmember Levin. We'll next hear from Councilmember Menchaca, followed by Councilmember Rosenthal. Councilmember Menchaca, you can begin after Chair Levine and the Sergeant cue you. Thank you.
Thank you so much, Sarah. And Councilmember Menchaca, it's your turn to speak.
Starting time. Thank you. And buenas tardes, everyone. Thank you to the chair and everyone who's making this Zoom possible. Dr. Katz and team, I've kind of been listening and I have a couple questions from some of the neighborhood organizations that are also listening at home and really kind of thinking about their role. Mutual aid groups have sprouted all over the city, and they're trying to think about how they plug into this in any way. We are anticipating what we saw after Sandy and Red Hook, that mutual aid was strong and then one day just disappears. And as we anticipate the reopening of the city and the work that needs to happen there and the economy doing what it's going to do, which is implode, there's going to be a real cliff. How are you thinking about mutual aid groups and the infrastructure that they're building to support the work that you're doing now?
I'll let Ted talk about it because I know he's been working with a variety of community groups.
Yeah, I'll say a couple of words, but actually I think the most important thing is we'd love to work more together. Again, we've started to do a lot of community engagement over the last week. We're getting clients from community-based organizations to be tracers. We're getting people from our communities to be resource navigators. And we're putting together a community advisory council that's being headed up by Tori Easterling at the Department of Health. All of those are actually good mechanisms to think about collaboration, and would love to continue to be in that discussion with you.
Awesome, thank you for that. So let's follow up on that front, because I think there's a lot of folks that want to think about that as sustainability questions come up. The second thing is cost around the HHC hotline for telemedicine for people who do not have access to telemedicine already in their insured through their insurance. And I'm thinking about immigrants specifically. What has been the cost of that? And is that part of your sustainable model for access to virtual telemedicine?
So council member, I'll start and Ted will finish. We've been really happy with the success of it. And I think that it really shows the value. We were able to keep 90% of people from going unnecessarily to the emergency room just by providing them. And I know you, in your work, in your neighborhood and community, you're doing a lot of great stuff around this. Ted and I have just begun the discussions. As it stands now, it's not a reimbursable service. We're happy to do it. We do lots of services that are good, but are not reimbursable. I think that I'm hoping that through this crisis, healthcare agencies and insurances move more to a capitated system where we could just include that as, providing that service gets a certain capitation. And then we, of course, would provide it to everybody, regardless of whether they had insurance, but would be partially supported by insurance dollars. Ted?
The only thing I would add is that we're proud that we've fielded nearly 100,000 calls from New Yorkers that have been paired 100% of the time with clinicians in our system. It's a free service. You call through 311 or our number and you get through to a clinician. And we want to continue doing this as long as it's a value to New York. So we'd love to also follow up with you about that.
Awesome. Yeah, and I think to that point, that's what our infrastructure in Red Hook and expanding to Sunset Park has been utilizing that line. And I know we're in conversations right now about bringing in some more elements. So I'm excited to hear that that's part of your, while it's not a reimbursable piece, it's part of this longevity and sustainable component. And I think the last question is really about Medicaid. And I know some of our hospitals have been telling us a little bit about the support that they need for folks to get enrolled. And there are a lot of people who, and I don't know if this was already asked before, and I apologize, but what can the city do to really ramp up and remove barriers for folks to sign on to Medicaid, and so that people can get access through Medicaid?
Sure, Council Member. Well, I know our own Metro Plus has 20,000 new applicants. And I know they are working on making the whole system not required any visits. So you don't currently have to visit anyone or sign any forms in person. I know Health First is doing the same thing. So I think maybe what our joint efforts need to be about is making sure people know who to call and that they're now entitled to these benefits.
Expired.
Thank you.
Thank you.
Thank you, Councilmember Menchaca. We'll next turn to Councilmember Rosenthal to close out the first round of questions. You can begin after Chair Levine and the Sergeant cue you. Thank you very much.
Thank you, Sarah. And now I'm pleased to hear from Councilmember Rosenthal.
Starting time.
Thank you so much. My technology is also a little spotty, so apologies if things are goofy. Dr. Katz, I want you to know how much I appreciate the work of your management of H&H system, obviously, especially during this pandemic. I appreciated the kind words you had for Councilmember Moya, and I know how closely you worked with the council members as it has to do with Elmhurst Hospital. But I'm going to give you a quick second so you have a sense of where I'm coming from with the following question. I obviously, have very limited medical and administrative expertise, but I did study epidemiology for 2 years. I have a master's in public health, and I spent 7 years in the New York City Mayor's office overseeing both the Health and Hospitals Corporation, as well as the Department of Health and Department of Mental Health. At that time, they were two separate agencies. Over the 3 mayoralties that I served, I met many health commissioners as well as HHC presidents, and their qualifications and skill sets have always been different. They are two very different agencies. One is responsible for providing medical care and managing an 11 hospital system and the affiliate contracts, et cetera. And the other is responsible for public health. So while I was not around during the 1918 pandemic, I did work with Dr. Stephen Joseph and Dr. Hamburg when they led the efforts during the AIDS and then the TB crises. And let me just add that my observation during this hearing is that it is the epidemiologists who appropriately are being deferred to when questions about public health are being asked. And they always have the accurate information regarding public health. So, Dr. Katz, you have a lot on your plate. You are managing a hospital system. And in all likelihood, we are going to see a second wave. And frankly, I found the New York Times article very disturbing when the timing for this crisis was so critical and the epidemiologists in the room, for whatever reason, those voices were not really heard at the beginning. So, sir, with all humility, would you consider stepping back from playing a leadership role in what is a public health emergency? The contact and tracing program is just so critical, and the unique qualities that epidemiologists bring to the table, why wouldn't you let their voice be the leading voice when it comes to this process? Thank you.
Well, I hope that you've seen in this hearing, and I think you've referred to it, that I have deferred. I see it very differently than you in terms of organization. What I see is that we are taking three pillars that do not work well separately. So you could have the very best tracing possible, but if there's no testing, what are you going to trace? And if you're not going to have the pillar of putting people in hotels and providing them the medical services to keep them, then I think you're also not going to be successful.
Sure. Sir, those are all logistical items, right? Hotel management, maybe that's something H&H has a knack for. I have no idea that you're in the hotel management system, but the idea of the first part, the testing, are you utilizing all the Department of Health, public health stations to do testing? What I would want to see is the person leading this effort has the guiding philosophy of someone who has taken on the job to be the head of the Department of Health, who understands her epidemiologists. And I really do wish that you would find a way to step back and allow the Department of Health
Time expired.
to take the lead in what is an epidemiological public health crisis. It's a matter of perception, but also it's a matter of respecting that know-how that is epidemiology and public health.
Well, again, I think reasonable people can disagree. I was the public health director for 12 years in a city that chose to put the two together. The hospital system and the public health system in San Francisco are together. It's 1 million people.
This city is 8.5 million people. It is not comparable to San Francisco. And they are two you as much as anyone should know, they are very different skill sets. And again, it's a matter of what is the guiding philosophy. And what we learned in the New York Times article is that the guiding philosophy of the public health commissioner, who was hearing from her epidemiologist, was not the loudest voice in the room at a time when we desperately needed her to be the loudest voice in the room.
I don't agree with that.
We can agree to disagree, sir.
Understood.
Thank you very much, Councilmember Rosenthal. We'll now turn back to the speaker and then chairs Rivera and Levine for a second round of questions if they have any. Members are welcome to use the raise hand function in Zoom to sign up for any additional questions for a second round. So we'll now turn back to the speaker. Thank you.
Thank you, Zara. So I wanted to just go to Dr. Varma for a second, just to see, Dr. Varma, if you could give just an overview on how all these pieces sort of fit together. If you could kind of, for the public that's watching, and of course for the council members, if you could just talk about how the testing, the contact tracing, the isolation in hotels and other spaces, coupled with the surveillance that's been talked about and that you all are looking into, how does all of this fit together in our overall strategy of being able to keep infections down and to continue to flatten the curve and keep people safe? And then if you could just add on into that, what does mandatory mask wearing mean in that? What does social distancing still mean in that? As we start to think about reopening, if you could just sort of tie all of those things together, that would be really helpful.
Great. Thank you very much, Chairman Johnson. Or Speaker Johnson, I'm sorry. I think it's important to understand a couple of key points here, and I'll try to summarize as succinctly as I can, even though it's a very complex topic. The first is that respiratory viruses like this come in waves. Now, those waves are not like the weather. We actually have control over them. But we are in an epidemic wave or phase right now that we would consider widespread transmission. And we define that as being a stage in which when people get infected, we as public health people don't have a way to track them to an original source of infection. So we consider a chain of transmission. I infect you, you infect somebody else, you infect somebody else. When we get to widespread transmission, we have no way of really tracking or keeping track of that. And the number of cases is either increasing or it's not, or it's plateauing in some way. We are probably somewhere towards the downslope of all of that. And the next phase is something that we call low-level transmission. So the entire reason to implement these maximum social distancing measures was what people describe as flattening the curve, which is delaying and diminishing the peak of that outbreak, of that epidemic widespread transmission phase, so that we can buy time. Some of it helps reduce the number of people infected and the number of people die. But really what it does is it buys us time to build important components. One of those components is the one that Dr. Katz and his team and Dr. Long have been building, which is raising the bar of healthcare capacity, so that both during the middle of that epidemic and if there are future waves of this infection, that we can respond and make sure people get the care that they need. But the other critical part is this one that we're talking about right now, which is the ability to test and trace and isolate and quarantine people on a massive scale. Something that the health department already does for thousands of people every year with different diseases, but now has to be done for thousands of people every day. And what that can do is at this stage of widespread transmission is help us accelerate our decline. So we're somewhere probably in that decline phase, and it can help us accelerate our decline. And then once we get to this stage of low-level transmission, help us maintain ourselves there. Now, what low-level transmission means is that we're able to eventually get to the point where we can track people to a chain of transmission. And what we're going to need with this, this contact tracing and investigation system is a way to integrate all that data so that we know that we're chasing and controlling chains of transmission. Ultimately, we want to get to the next phase, which is essentially no transmission, and where the only cases that you see are those that might get imported into New York City. But we also have to be extremely realistic. You know, we live in a city that is connected to every other place. And unlike the large mega cities or city states in Asia that have controlled this, they were able to lift up their borders. And so they contained they have a low-level transmission strategy with contact tracing, but it's coupled with all these other, border controls. So the last thing I'll say, which I hope will, cover all of the topics, is, what does this mean for social distancing measures? Well, we should think of social distancing measures not like a flashlight that you turn off and off, but more like a dimmer switch, something that turns up, goes up, and comes down, and then you adjust it based on your need. And so in this situation, I think we have to accept the fact that until we have either a vaccine or a cure, we are going to have some measure of social distancing measures in place. Now, these could be very low level. They could be things like very aggressive hand hygiene and respiratory hygiene, like the wearing of face covers and environmental cleaning. But they could also have to deal with us keeping space apart from each other and maximizing the time we spend away from each other. So these are the types of work that's going on right now. There are a number of sector councils and consultations that are being held with all different parts of this. And that's what we're being used to inform all of this. I hope that answers all questions, but happy to answer others.
That was helpful. Dimitri, Mitch, is there anything that you wanted to add to that?
No.
I'm just going to echo it that, again, it's all one big package that requires, I think that Jay's analogy of a dimmer is really great. As I said earlier, like it's not always like an on-off. And I feel like it's really going to be about scaling up and scaling down and really responding until, again, we have a vaccine. And then that's going to be another really significant public health moment when we have to figure out how to get vaccine out, especially with sort of mythology around vaccine already flying around before there even is one.
Thank you. Mitch, or to all of the folks from the administration, I just want to reemphasize that, I think some of the, and I've said this, before, but I think some of the concerns that we've seen around how this has been rolled out, I think part of that is dovetailing on communities that have been especially hard hit and who, understandably, given the huge racial disparities that we've seen and the number of people that have died, the lack of testing, the problems in rolling out testing effectively, that there are a lot of communities that are rightfully mistrustful and concerned about being left out again. And, I think it's really incumbent upon all of us, especially the folks that are in charge of this effort, to get this right, to build trust, to build confidence, to ensure that these communities that right now have been the hardest hit, and with all of the total mess that has occurred at the federal level that people are witnessing every single day, and of course the mistakes that have been made locally, Mitch, which you acknowledged and talked about before in your testimony, that it's just really incumbent upon us to roll this out effectively, make sure that it's going to the communities that need it the most, to build that trust, to gain that confidence, to show these communities that they are not being left behind. And I just want to hear, Mitch or anyone else, your thoughts on that.
Speaker, I think you've said it perfectly. I think that should be what we now focus on. And I hope that you've seen in the team of people who've participated in this, which include, two people who've spent their whole lives in departments of health and one person who's been straddled both worlds, that we are committed to this vision, as you stated, and we're committed to doing a good job. And we are committed to making sure that those communities that most need our services get it.
Anyone else want to add anything on that?
No, well said.
Okay.
My only comment again is that I think one of the most sort of important parts of the collaboration with H&H and DOHMH is the sort of very clear endeavor to make this public service. And so again, though a public health intervention, I think that even wherever it's housed, the New York City way for this is to make it a public service, to make sure that provisions are given to people to make sure that we can optimize their health. So I have faith in that New York City way. And I think that your voice is really important in that, and the voice of all the community that are being integrated into this emerging strategy, those voices are critical. Thank you.
And again, a question for any of you, Jay, Dimitri, Mitch, anyone else who's testifying. It would be helpful because I think there has been just a trove and an overwhelming amount of information that's put out. I'm not talking about from the city or from anyone on this at this committee hearing. I'm talking about generally information related to antibody testing, PCR testing, serology testing, how much immunity does one have? If you have antibodies, can you then go see and hang out with friends? I feel like that there has been so much put out there that it's confusing for the public in many ways. So we're seeing this information on Twitter and on Facebook and on one-off articles. And I think it's going to be really, really important for us as we are going through all the things that we've talked about in this hearing, from the testing, the contact tracing, the quarantining, the surveillance, the continuing to socially distance, the mandatory mask wearing, all of those things that we are communicating with New Yorkers, the hardest hit place in our country, about what these different tests mean. And if you get a positive test result, what does that mean? You know, if you have antibodies, what does that mean? And some of the answers may be, we don't know yet because the science is too early and we're trying to figure that out. But part of me feels like what is being communicated to the public on a daily basis through press conferences and through guidance and information that goes out from our public health authorities, that there should constantly be a reminder on this, almost on a daily basis. Here is what the facts tell us right now. Here is what we don't have enough information on right now. Here is where we're trying to get more information. And I think that is going to be a crucial thing moving forward so that New Yorkers are not feeling confused. I already see people posting that they have antibodies, they got their antibody test. Well, what do people think that means? So I would love to hear from whoever how you think we should be communicating around this, and the best information that you have right now. How would you use that information to guide New Yorkers in the decision making they're going to make, not just in the days right now, but as we attempt to slowly, smartly, and strategically reopen?
Well, I'll start, and other people will be interested in what they have to say. First, again, Speaker, I think it's a perfect statement of the problem, and it's the right answer is that we should provide as much information as we possibly can, as honestly as we can, making it clear that the information changes. Even I'll just use the antibody example, that one of the challenges about communicating about antibody testing is that some of the antibody tests are not very good, right? And so besides the question of what does it mean if you have antibodies, there's the question of, did the antibody test that you got, was that actually a good antibody test or a not good antibody test, right? If the test itself...
Mitch, just on that point, there's been studies and research that have come out that there could be as high as 15% false negatives that are showing up, and there could be a certain number of false positives. So some people may think, I don't have the antibodies or I do have the antibodies, and it may not be entirely accurate.
True. And I mean, what's interesting is it's not that different than everyday health, but this is such a monumental issue, right? I mean, most medical tests have a margin of error, but the problem here is we're dealing with something that is so cataclysmic that it's very hard to explain, why we don't have better tests, why we don't have the reagents that we want. I think that if the average person is confused, I really don't think we can blame them. Dimitri, were you going to say something?
Yeah, I'm just going to follow up and say that I feel pretty confident that the message in New York City has been internally consistent about the lack of knowledge about what antibody testing means. The problem is the message federally has not been consistent. And so I think that is one of the really big challenges that we have in terms of messaging. So from, I think really early on when antibody testing was being done, the Department of Health released a health alert that made it clear that the test was really better a public health test than a test of one's individual health use. It's hard when other officials, not New York City, on the federal level, start talking about sort of scientific assumptions of immunity when there really are none. So I think that, again, I agree that we need to keep enforcing science and keep reinforcing what we know and what we don't know as a critical piece of guidance to New Yorkers. And I would say it's fair to say that an antibody test is not a replacement for personal protective equipment or for social distancing. And I think that message is, I hope, a clear New York City one. And if not, we will amplify it even further, and we need your help to do that. I hope the science will show more in the future where we'll be able to eat our words like we've done before and say, yep, immunity is real and it's durable. But until we know that, I think the best message is that serology testing is good to know if you've been exposed, good potentially for public health to know how many people have been exposed, but not to make decisions about your mobility or how you interact with others.
And I just have a couple more questions and then I'll turn it back over to the chairs. One of my fears in the weeks and months ahead is that even if and when we get the system up that this hearing is about today on testing and tracing and quarantine and surveillance and how all these pieces fit together, that communication is so unbelievably crucial in all of this. And what do I mean by that? I mean that unless New Yorkers feel like we are making significant progress on a regular basis, I'm afraid that people are going to be so psychologically worn down by the last 2 months and by what's even ahead of us that I don't want to see the, I think, really great effort by the vast majority of New Yorkers to social distance, to help us collectively flatten the curve, to do that solidarity together. I'm afraid that that will start to fray, that it will start to deteriorate in some ways, because people will feel like we've done this for so long and we're still not understanding or seeing the progress in a meaningful way for us to be able to resume our lives, whatever that new normal looks like once we're coming out of this. And so I just sort of ask, you know, if you all share sort of a similar concern or fear that we've done, New Yorkers collectively have done so well thus far at collectively looking out for each other and doing the solidarity around social distancing. And the vast majority of people are wearing masks when you go outside. So I just want to hear what you all think about how long will New Yorkers be able to kind of deal with this for unless they are being communicated with information about the progress that we're making. And I don't know if Jay wants to take that or Dimitri or Mitch, but whoever wants to take that.
Well, I'll start and other people can join. Again, you're right. It's very difficult. And yet New Yorkers, I think most people knowing sort of the nature of New Yorkers might have been surprised that New Yorkers agreed to wear face masks and keep 6 feet apart. But New Yorkers understood why that was important. I think the mayor has been good about giving clear messages about that. I think that the city council has been great about it. I think having this hearing helps to reinforce the messages, but it is hard, and the challenge is for us to communicate well and to recognize the psychological challenges in our work. I don't know, Dr. Varma, do you want to add?
Yeah, I would just say that, you know, I've spent most of my career actually in other countries working on similar problems, and have to say that this is far and away one of the most vexing challenges, and it's not a problem that New York is going through alone. I would say that we can learn a lot from what's going on in how other countries are adapting and communicating and developing their resilience. And I think we need to learn how to do better. So we're certainly looking for other examples, but I think we would also, you know, ask all of you to help us figure out the ways in which we can communicate more effectively as well, at least as far as it relates to data and science, because it is incredibly confusing, and we as public health people are not always the perfect messengers. You know, we talk in vagueness and abstraction often when people want to hear certainty. So I think we would certainly want to learn from what other places are doing and see their best practices, but also to learn from what all of you have to offer us about what your communities are hearing and how we can communicate it better. And I would just say the last point about the resilience is, I think we all recognize, again, and to emphasize the point I made earlier about this sort of maximum stage of social distancing that we're in right now. This was not ever intended to be a strategy that goes on forever. There was no plan in the public health world for people to hunker down. I think we've even been surprised at how well, you know, people are suffering, but still committing every day and working so hard on this. So it's really incumbent upon all of us as a group together, not just the people testifying, but everybody as a group, to commit to these other tools to help us get out of it, because that's really the only approach that we have available to us.
Okay, a couple more questions, and then I'll pass it off. In an ideal world, and I ask this for a reason, again, not to not look at the reality that we're in right now, but in an ideal world, how many New Yorkers would we be testing per day? Again, not in a fantasy world, but if we could actually get the testing capability, get the number of tests, get the labs to be able to process them, set up the community testing centers, because this, of course, feeds into the whole conversation on contact tracing. What is the number that we should be testing? I've seen numbers that we're hoping to get up to 50,000 people in June at some point, but that is still a fraction of 8.6 million. So what is that ideal number, and how are we contemplating that on trying to increase that capacity?
Dr. Varma, do you want to give the first shot at it?
Yeah, I will. And so I'll try to give a short answer and then a little longer, unsatisfying explanation of it. The short answer is that we need as many tests as we possibly can. And it's probably ideally somewhere in the six figures, 100,000 or more.
A day.
Per day, I'm sorry, 100,000. And we're talking PCR tests, not antibody tests. Now, that number is not defined. And the reason it's not, I want to give you a couple of reasons why it's not defined. Number one, if you are in a state of this maximum social distancing right now, most people have very few contacts. You know, from the work that Dimitri and his team have been doing, the average person who in this current phase right now has about 3 contacts. Now, when you relax social distancing, that number of contacts grows probably 3 times that. And the average person may have 8 to 10. By contacts, I mean close contacts, people that you are in very close proximity for a long period of time. So during maximum social distancing, you don't have to test as many people because you won't have as many contacts to test. So the number of tests that you need to perform is more on the order of 50,000 or less. As you relax social distancing and people have more close contacts, you need to increase the number of tests. That's one issue. The second issue is the severity of your epidemic. You know, if you are, I've recently been talking to people in Washington State, and they've, gotten their epidemic under very dramatic control. They can perform somewhere on the order of around 20,000 tests per day in Seattle King County, which is a population, I think, only around at most maybe 2 million. So they can perform less because they can reduce the number of tests per person they need to perform because there isn't as much disease going on. So once you shift away from an epidemic where you have to focus all of your testing on really sick people, you can sort of, expand your testing because you can use other sort of creative methods.
Jay, what's
there? There's a lot more to it, but those are 2 of the big points.
What's our plan to increase testing capacity?
So I'll say a little bit, but I think Jackie can also can do this as well. I would put this basically into 3 big work streams. One is eking out every last bit that we can from every possible provider that we can. The problem with the supply is that the supply chain is completely messed up from start to finish, from the kits to the personnel to the commercial laboratories. But we're working with them. We're signing contracts. We're finding new labs that might be able to provide capacity. We're putting pressure on the commercial labs by expanding our test criteria, like you heard the mayor. So that's work stream number 1, eking out as much capacity with the system that we have. Number 2 is trying to, basically hack the system and try to look at different workarounds. And there's a number of jurisdictions, this comes from my experience in Africa and other places. You can use different swab types. You can use different collection methods. You can use different transport media. And you can find ways to, not just eke out what you can using standard approaches, but sort of hack and repurpose things to get a little bit more. And with that, we're getting more and more. The third is going to have to be some form of innovation. And we are, in constant discussions through the Economic Development Corporation. James Patchett's team has done an amazing job trying to pull together some of the top academics, and we're having regular discussions about this. Jackie, I don't know if you wanted to add any more.
Yeah, absolutely. Okay, I'm not on mute. Yes, absolutely. So we think about this in 3 sort of buckets. We have to get kit availability, we have to get lab availability, we have to get collection capacity availability. I'm going to go in the opposite direction. From collection capacity availability, the first thing we did was expand H&H's ability to collect from the community. So H&H has got 23 community sites set up. We've announced that we're opening 2 more next week, 10 the following week. We will continue to grow that collection capacity. The other thing we're doing, as Jay said, is we're working with every private provider. We want all the private providers to be able to collect diagnostic tests. That might mean for some F2HCs, they might say, listen, I've got brick and mortar, I've got staff, I don't have enough PPE, or I don't have enough kits. We're going to help provide them that material, the supplies they need to do it. So from a collection capacity standpoint, very quickly we'll be where we need to be. But then you need the kits. You need the supplies that help you take the specimen. And so Jay's right. The supply chain is totally broken. We're working the supply chains. We have supply chain experts who are every day attempting to source. But we started, as the mayor has said, producing in New York City. The very first kits that were produced, the swab and the VTM and the kit in New York City were delivered and were in use this past week. And that our ability to do that will continue to ramp up. Einstein College of Medicine is producing the VTM. Print Parts is producing the 3D printed swab. And so we'll keep driving on that front so that we can produce. And then finally, the lab capacity. And so the way we're building lab capacity, we are literally buying our own machines. No joke. We are contracting with the big reference labs. And then we're going out there and sort of shaking the trees on all the little reference labs to really max out.
And is this covered by the federal dollars, everything you're talking about?
Testing is covered by FEMA dollars.
Okay. Two very quick things. How many contact tracers do we need total at the end of the day? What's the total number we need at the end, Mitch?
Ted, you've been doing most of the operational numbers.
Yeah, we need between 5 and 10,000, and we need to hit the 2,500 threshold to be the 30 per 100,000, which is.
But that's a big range, 5 to 10,000. Is it closer to 10 or is it closer to 5?
It's hard to say until we really get up and going, but it's probably between 5 and 8.
Okay, and then a final thing before I hand it off. While I was sitting here, I got 2 messages, just so you all know this. One, I'll just read one of them. Someone sent me a message. Hi, Mr. Speaker. I am emailing you regarding my experience trying to apply to become a contract tracer. I went to the Bacharach Group website on Monday and navigated the apply page, but it won't let me upload my resume. I click on the upload button, it says uploading, and then it says parsing, and then it just stays there. I included a screen grab. I've tried multiple times every day this week, but it will not complete the process. Even on the tabs that I've left open, I've used different browsers, made sure all ad blocking extensions are off, tried to upload it in a PDF and a docx format, etc. On Monday, I emailed the company through their website. I still have not heard back, and it's Friday. I tracked down a phone number for them. There is none given on the website, and I called, but I got a recording saying their office was closed. I realize this is small potato stuff if it's just me for some reason that can't get through. But if everyone else is having the same issue, it's a bit of a problem. So I thought you should be aware of it. Thanks so much. I hope to get this resolved. I want to help our city get out of this. I've got 2 emails like this.
Can you send them to us? Obviously, 9,000 people, it worked, but that doesn't mean that there's not a problem at this moment. So if you want to send me, their contacts, we will get back to them.
But that's disturbing in some ways if a bunch of people are getting that.
Right. I can't. 9,000 applications got in successfully. But it could be that there is a bug today or a bug whenever this started. We have to track it down.
He's been trying since Monday. It's Friday. So
we'll track it down. We'll track it down.
I'm going to turn it over either back to Chair Levine or Rivera. Thank you.
Thank you.
Thank you, Mr. Speaker. And I don't know if SARA Committee Council wants to weigh in. I'm going to forego second round questions because I'm anxious to get to the public. I don't know if Chair Rivera wants to say a word right now or perhaps Chair Rivera after we have our 2 council members speak.
Probably.
Whatever you prefer.
Let's let the council members ask their question. There's only 2 minutes on the clock, so we appreciate your brevity.
Thank you,
Yes,
Chair.
Sarah?
Thank you very much, chairs. For the second round of questions, as Chair Rivera mentioned, we're using a 2-minute clock for both questions and answers. And we'll be hearing from Councilmember Torres, followed by Councilmember Barron and Levin. As the first round, Councilmember Torres, please wait until Chair Levine cues you, and then the sergeant tells you to begin. Thank you.
Thank you, Sarah, and pleased to hear again from Councilmember Torres.
Starting time.
Since I have 2 minutes, I will squeeze in a few questions. I noticed that the countries that have been the most effective at contact tracing rely on digital contact tracing. Is our program going to have a digital dimension given just the highly infectious nature of SARS-CoV-2? The second question, is there a precedent for contact tracing a virus as infectious as SARS-CoV-2 And 3, is our contact tracing going to capture close contacts in the context of public transit crowding? And those are my 3
Jay,
questions.
do you want to start? Dr. Varma, are you on mute? We're not going to do it until he comes in.
They unmuted me.
Okay,
Sorry, they unmuted me. Really quickly, I think for digital tools, I think as we mentioned before, we're going to try to incorporate those, but it would be something that's done voluntarily as an add-on to an existing system, so that we can plan for the worst case, which is people who are disconnected, difficult to reach for a number of reasons, some being natural suspicion and reluctance. That's number 1. Number 2 is for precedent for other infectious diseases. Dimitri can clarify, but measles is probably the single most infectious disease known to man. It can float in the air over long periods and infect basically 100% of a household or anybody in a room. And we have had to do contact tracing for measles as well.
And the third question was, yeah.
I agree with the comment about measles. I think that the scale of this is a lot different. But with that said, I think that's why the scale is being built to be a lot different.
And is our contact and tracing program going to capture close contacts within the context of public transit crowding?
Yeah, so that's I'll answer really quickly, but I know if Ted other one is to add. It's going to be challenging. I mean, right now we have a definition of a close contact. That means
time expired.
Time and certain amount of closeness. Whether we can catch people who are on public transit is going to depend on digital tools and other methods. Ted or Jackie, I don't know.
Nothing more to add. You covered it.
Thank you very much, Councilmember Torres. We'll next hear from Councilmember Barron, followed by Councilmember Levin. Councilmember Barron, you can begin after Chair Levine and the Sergeant cue you. Thank you.
Thanks, Sarah, and we'll pass it back to you, Councilmember Barron.
Starting time.
Thank you to the chairs. What is the validity percentage of the diagnostic test that you are presently using?
So I'll start with the antigen test, and other people can weigh in.
Because I only have 2 minutes.
We'll talk fast. So the swab test, the problem is that the swab test is its own gold standard. So we don't really know how to measure how many of them are wrong, because typically you measure against something. Okay. There are a group of patients who look like COVID who test negative on the swab, and we assume that they have COVID. Okay. With the antibody test, it's very variable depending on the maker of the test.
Okay. Are you coordinating with the state? The state is going door to door in my NYCHA development testing people. So will you have some kind of coordination with the state to be able to follow up? Or are you the state doing their own follow-up independent of yours? And is there any attempt to look at testing people who are in nursing facilities, which we know was an epicenter that we overlooked for many, many, many weeks?
Yes. So nursing home testing by new rules will occur for both staff and patients on a weekly basis, twice weekly for staff. The state efforts are coordinated with us. We're going back and forth, but to the extent that the state has been doing seroprevalence studies where they just draw blood in order to see how common it is, that has not yet had a tracing component with us or with them.
So those residents.
So they're getting their result. They're getting their result, but they're not being tested for active infection. They're being tested to see if they have evidence of having been infected in the past.
Okay. And can you briefly talk about
I'm expired.
What is, I've heard the term, and I just want to know, what is the definition of herd immunity? Is that something we're trying to get?
Herd immunity is when enough people in a population are immune to the disease that it doesn't get transmitted to others because it keeps hitting somebody who's immune and can't transmit.
How soon will we get there?
Well, that's a very hard question that I don't think anybody understands. We're not there yet.
Thank you. Thank you. Appreciate it.
Thank you very much, Councilmember Barron. Lastly, we'll hear from Councilmember Levin. Councilmember, you can begin after Chair Levine and the Sergeant cue you. Thank you.
Thank you, Sarah. And back to you, Councilmember Levin.
Starting time.
Thank you. I just had one other follow-up statement, really, but it could be a question. So one of the most important things that we need to do, in my opinion, as we're kind of starting up again, is make sure that people know when to get tested and where to get tested. And it's really clear to people, this is when you get tested. So when, like for instance, back in March, we were telling people, if you're symptomatic, stay home. Don't go out and get a test, stay home. We didn't have enough tests, so it was just stay home. But that's not what we're gonna be telling people. We're gonna be telling people, if you're symptomatic or if you think you've been exposed, go get a test, right? Is that what we're gonna be telling people?
Correct.
Okay, and so we need to make sure that there are enough, that the testing sites are close enough and that everybody knows where their testing site is or where they can go to get a test. If it's at CityMD or if it's at H&H or if it's at whatever else, however else we want to set that up. But it really needs to be really clear to people, okay, you get tested if you have any of these symptoms, you lose your sense of taste or smell, you've got a dry cough or a fever, you've got a sore throat, go get a test. You need to know where you will get tested. I mean, that's got to get drilled over. It's really a messaging thing more than anything else. Drilled into people's heads. They need to know when to get tested because we need to be able to then move off of that to the tracing. So
we totally agree, and we're going to do that.
Okay, over and over and over again. Drill into people's heads, like over and over and over again. This is where you get tested. This is where you get tested. This is when you get tested. This is why you get tested. Over and over and over again. Right? Okay.
Yes. Yes,
Okay.
yes.
Thank
And
you.
we should say that our testing criteria changed
Time
yesterday.
Okay.
Right? So our testing criteria changed yesterday, and you will see communications on that ramping up over the next several days. But we are now in a posture where if you are symptomatic, you should go get tested. Not just you can, you should. If you
Right.
are a close contact of someone that has a positive COVID test, you should go get tested. And if you are staff at a congregate facility, you should go get tested.
And that has to go out on every radio station and every TV station, like on Facebook, on Instagram, over and
Yes.
over and over again. Drill into people's.
Over and over and over again. Yes.
Thank you. Okay. Thanks.
And I would similarly say the same message needs to go out as we talked about before on antibody and serology and PCR and what all of that means for the average person who is trying to decipher all of this. We need to be talking about that constantly.
Agree.
Chair Levine?
Well, that wraps up our questions from council members. Thank you, Mr. Speaker, for all your excellent questions. And I want to thank the administration for spending 4+ hours with us on this critical topic. And I also want to offer my co-chair, Councilmember Rivera, a chance to say a final word to the administration as well.
I just want to say to Dr. Katz, all of you, Dr. Long, every single one of you, thank you for your patience, for being receptive to our comments and questions. You have been here for more than 4 hours. Thank you. We had every intention of finding out the rationale for this transition to H&H, and you answer these questions as honestly and best you can. So we want to work with our city's leadership in these efforts to try our best to organize, catch up, hopefully hire even more tracers and continue to learn lessons from cities across the globe. And we want to work with you so that we can see and comment on a public budget for these efforts and others in our public hospitals, and to get the job done quickly and equitably. Dr. Katz, I know you and I have had many long and sometimes difficult conversations during this crisis, but you're always willing to listen and respond to officials like myself, and I thank you for that and look forward to working with you on any initiatives the mayor ultimately decides to have you work on. So again, for all of your work and of course for your time leading the San Francisco Department of Health when the HIV/AIDS crisis was ravaging that city. Many people did not feel comfortable coming forward to seek medical attention because of the hateful rhetoric they were witnessing. You found a way to build trust with them. I hope we do the same here in our communities that were disproportionately affected. So thank you. Thank you so much for joining us today, for sharing your testimony and responding to our questions. Thank you.
Thank you.
I'll now turn it back to our committee counsel to go over some additional procedural items.
Thank you very much, Chair Rivera. We'll now begin with the public testimony. Before we do, I want to remind everyone that you will be on mute until you are called on to testify. After you are called on, you will be unmuted by the host. I also want to remind everyone that if you mute yourself at any time, you can only be unmuted by the host. I will be calling on panelists to testify. Please listen for your name to be called. I will be periodically announcing who the next panelists will be. I'd like to remind everyone that unlike our typical council hearings, we will be calling individuals one by one to testify in groups of 3. Council members who have questions for a particular panel should use the raise hand function in Zoom, and you will be called on after the panel. For panelists, once your name is called, the Sergeant at Arms will give you the go-ahead to begin after setting the timer. All public testimony will be limited to 3 minutes. Please wait for the Sergeant to announce that you can begin before delivering your testimony. Council members, you will be limited to 2 minutes for your questions for each panel, including answers. The first panel will include Henry Garrido, Charles King, and Jessica Orozco Gutline. Henry Garrido, you can begin as soon as you're ready, after the Sergeant at Arms tells you to begin.
Time begins now.
Good afternoon, everybody. I hope you can hear me. I want to thank you all for the opportunity today. I want to thank the speaker and the chairman, Levine, and for the great work that they've done over the years, and Chairman Rivera as well. I will dispense on my written testimony. I will submit that for the record, but I am here on behalf of the workers. And I have to say that I am completely baffled how this has become some form of referendum between whether it's the right thing to have H&H do this work or whether it is the Department of Health and Mental Hygiene to do it. Well, we have forgotten the very same people, the very same heroes that have saved this city in the first place. I have 143 people who have died due to COVID-19, frontline workers who not only have been doing this for decades, but are doing it right now. And somehow, this discussion about the Department of Health has forgotten who they are. Right now, the Department of Health, when this initial discussion started, took the position that they were going to outsource the work to an entity called the Fund for Public Health. And then, by extension, you've heard before, a headhunting firm called Bacart, who was going to do the recruitment of what it is already in existence, a position called Public Health Advisor, represented by my union, by my members. Now think about this. You are sacrificing your lives. You're working 15 hours a day, working 5 hours a week, 6 days a week. You're sleeping in a cot in the Department of Health because you want to provide services for the public. And now you're told you're not good enough for this position unless you go to a private entity to apply for something that's going to pay you more, right? The average public health advisor right now working on this contact traces, and let me remind folks, we have had hundreds of them. We have 284 contact tracers, public health advisors doing this right now. Somebody mentioned the epidemiologists. We have already 83 in the total city of New York. We have 83 epidemiologists doing this work. And somehow it became okay to outsource to this Bloomberg-created entity called the Fund for Public Health, pay them more, and not offer it to our workers who are doing the work, and not keep the functions within the realms of city service. This is why we support this decision. We support the decision to put the Health and Hospital Corporation in charge of this, partly because we've been doing the work, also because there's a recognition that there has to be this function within the scope of city government. Think about the issue of confidentiality for the public. Do we want this in the hands of a public entity that is not accountable for the people, not elected? Do we want to continue to contract out one of the most important functions in a lifetime? I think the answer is no. We are in support of this, and we're submitting testimony for the record, Mr. Chair, Madam Chair, and Mr. Speaker. Thank you.
Thank you very much. We'll next hear from Charles King. Please wait until the sergeant cues you and tells you you can begin. You may begin.
Time begins now.
Thank you, Chairpersons Levine and Rivera, and the members of the Committees on Health and Hospitals for the opportunity to present testimony on the urgent need for a strong, coordinated, and professionally led New York City COVID-19 response that includes widely available testing, contact tracing, and supported isolation to stop forward transmission of this disease. My name's Charles King. I'm here representing Housing Works as a member of the COVID-19 Working Group here in New York City, a coalition of doctors, healthcare professionals, scientists, social workers, community workers, activists, and epidemiologists committed to the rapid and community-oriented response to this pandemic. As set out in the May 7th, 2020 COVID-19 Working Group statement attached to my written testimony, we are alarmed and dismayed by Mayor de Blasio's catastrophic, ill-considered, and frankly perplexing announcement last Friday to transfer the critical public health role of COVID-19 contact tracing from the City Department of Health and Mental Hygiene, a world-class health department with a century of expertise and experience in contact tracing and infectious disease control, to health and hospitals, which has a critical role to play in the COVID-19 response, but zero experience and no infrastructure to conduct infectious disease contact tracing and monitoring. This attempt to transfer responsibility for a core public health function away from the Department of Health and Mental Hygiene in the midst of an unprecedented public health crisis will irrevocably hamper our city's response in a manner that mirrors the tragic dysfunction at the federal level, where the Centers for Disease Control and Prevention is being similarly shunned aside in an approach focused on optics rather than results. The mayor's decision is not only unwise, but also unlawful. On Wednesday, members of the COVID-19 Working Group joined Dean Linda Fried of Columbia Mailman School of Public Health and Dean Cheryl Hilton of the New York University School of Public Health to formally petition New York State Commissioner of Health, Dr. Howard Zucker, on behalf of all New York City residents to exercise his legal authority and supervisory responsibility to require that Mayor de Blasio immediately return all authority for COVID-19 surveillance and contact tracing to the Department of Health and Mental Hygiene as the legal public health entity for New York City. The petition attached to my written testimony sets out the state and city legal framework that prohibits the mayor's unwise and unlawful transfer of contact tracing responsibilities from the Department of Health to H&H and outlines just some of the concrete and irreversible injuries the mayor's move would cause to individual New Yorkers, to the public health, and to the essential duties of the Department of Health and Hospitals.
Time has expired.
I will submit the rest of my testimony in writing along with the two documents that I referenced.
Thank you. We'll next hear from Jessica Orozco Gutline. You may begin once the sergeant cues you. Thank you.
Time begins now.
Hello, thank you, Speaker and committee chairs and members for bringing us together today. My name is actually Betsy Morales-Reed, and I'm the Senior Director for Health Initiatives for Hispanic Federation. As we know, contact tracing coupled with testing is the most promising approach to identifying new infections and preventing further infection. However, this effort will be a failure if proper outreach, cultural competence, and language access is not guaranteed. Communities of color have been disproportionately affected by this pandemic. Indeed, when the worst of the crisis subsides, we will find that significant numbers of Latino New Yorkers, especially those whose immigration status was unsettled, avoided hospitals out of fear of incurring costs for care or falling victim to the anti-immigrant enforcement actions of the Trump administration. candid conversations with contact tracers who must be trusted by community members in order to have effective conversations and receive thorough and accurate information are going to be essential. Community members must have confidence that the information that they provide to contact tracers is truly confidential. For this reason, information collected through contact tracing must be strictly protected. When you ask a COVID-19 positive person who they have come in contact with, you're asking them to give up their undocumented tia who helps them raise their children, or their elderly mother who lives with them and may not be listed in their lease agreement. In order to truly gain the trust of the community, it is imperative that contact tracers come directly from the communities they are working in. I cannot reiterate enough the importance of trust in the community, especially at times like this and the political climate that we live in. Hispanic Federation's network of over 150 Latino CBOs are frontline service providers for our neighborhoods and communities. And the work that they're doing today and they will continue doing will be essential for us to get through public health crisis. Our community has historically counted on community-based organizations for information and resources. If we are to effectively address this unprecedented crisis in our neighborhoods in New York City, we must make sure that CBOs are working hand in hand with any institution or agency leading this effort. Moreover, a large-scale public education campaign about contact tracing will be crucial to the program's effectiveness. Community members must have basic knowledge of why contact tracing is important, why they should engage in conversations with contact tracers, and how to identify credible contact tracers. In order to have an effective, widespread public education campaign that will reach communities of color, ethnic media partners must be engaged. Particularly in the Latino community, Spanish media is highly trusted and reputable source of information, and its success is based on its deep connection to community. Spanish media must be activated to provide critical information to encourage community members to divulge necessary information to contact tracers. Ensuring that public education campaigns are created in cultural and linguistically competent manner will positively impact the success of testing and contact tracing. Through community involvement and prioritizing dissemination of information through culturally and linguistically competent mediums, contact tracing will be successful in stopping the spread of COVID-19 and save lives. Thank you for your time. Hispanic Federation is here to serve and is happy to work with the New York City Council and protect all New Yorkers.
Thank you very much. Do either of the chairs have questions for this panel? Okay, seeing no questions, we'll now move on to the next panel, which will include Albert Fox-Cahn, Hallie Yee, and Max Hadler. Just as before, when your name is called, please wait until the sergeant cues you to begin your testimony. Albert Fox-Cahn, please begin after the sergeant cues you. Thank you.
Time begins now.
Good afternoon. My name is Albert Fox-Cahn, and I serve as the Executive Director for the Surveillance Technology Oversight Project of the Urban Justice Center. I'm grateful for the opportunity to testify here today, and in addition to the written testimony that was submitted to the Council in advance of today's hearing, I wanted to address specifically the proposal that was brought up by several Council members that the city invest in electronic contact tracing. There have been a number of highly publicized contact tracing efforts, such as Google and Apple's Bluetooth API, that we believe are dangerous, a distraction from evidence-based methodologies, and will exacerbate existing health inequalities for communities of color, low-income communities, and those communities that have borne the brunt of COVID-19. In a recent white paper that STOP released, we highlighted the ways that these technologies will get it wrong, that they will lead to false positives, that they will exacerbate gender bias, that they will feed into some of the worst forms of artificial intelligence-based discrimination. But on top of this, these systems will drive many of those communities most at risk of COVID-19 complications into the shadows. Those who have the highest risk of fatalities from COVID-19, lower income communities, communities of color, will oftentimes be the least willing to participate in these apps. They will also be the ones who are least served by these applications because they will require access to relatively recent smartphones. For example, the majority of those over 65 don't have access to a smartphone. And those who do oftentimes don't have the newer models of smartphones that are needed to accommodate the Bluetooth API format. On top of this, We have to recognize that New York City has a long history of weaponizing the data collected on our residents for law enforcement and even indirectly for immigration enforcement. Despite the promise of being a sanctuary city, much too often the data we collect as a city, either directly or indirectly, is fed to federal agencies, including even ICE. And we simply do not have the protections in place today to assure New Yorkers that if we are to deploy a Bluetooth tracking API or any other sort of technology-assisted contact tracing program, that data, that invasive data on every part of our life will be kept safe from law enforcement and other individuals who would misuse it. We strongly recommend that the city focus on manual contact tracing using culturally competent contact tracers drawn from the communities who we're reaching out to. And I thank you again for the opportunity to testify here today. Thank you.
Thank you very much. Councilmember Rosenthal, I see that you have a question, which I assume is for the first panel. Please feel free to go ahead and be specific about who from the panel you are addressing. Thank you.
Thank you so much. I appreciate your noticing my hand up. Actually, is Henry Garrido still available? He may have already left, at which point, oh, there he is. Henry, I'm wondering what your thoughts are on the program. I understand and heard what you said about the Public Health Foundation, and I'm wondering what your thoughts are about the program as it is currently laid out.
Well, as I said, Councilwoman, thank you. We are in support of having the Health and Hospital be in charge of this program. And I think that, I think it's legitimate to say that we are departing with long-standing history, as you said, of the city. But I do think that this COVID-19 is an unprecedented case that necessitates for us to look at things different. And I have been making the case that rather than this philosophical view of the Department of Health or the Health and Hospital, why don't we have this discussion about whether this data belongs in the hands of government? Whether in fact we want to be retained that. And what the Department of Health proposed was not to retain that data, but actually to outsource it to another entity who then outsources it to somebody else. And I saw some serious issues with it. So for that reason, I support the idea of Health and Hospital keeping a cadre of folks. And some will say, well, that's because you represent them. Guess what? I represent them in both departments. Public health advisors are represented of both the Department of Health and the hospitals. So to me, it wouldn't have made any difference in terms of gaining or losing membership, whether you put them in DOHMH or Department of Health or the Health and Hospital. So it would have been a net gain. But I do think that the idea that some third-party entity not accountable to government, not elected, is a problematic proposition that I think has not been discussed enough. We saw this outsourcing galore, right, during the Bloomberg years.
Time expired.
We're seeing it now, and I don't think that that's something that should be done.
Thank you so much, and thank you for your service and the service of your members. Appreciate it. Thank you, Council, for recognizing me.
Thank you very much. We'll now resume with our second panel and hear from Hallie Yee, followed by Max Hadler. Hallie Yee, you may begin once the sergeant cues you. Thank you.
Time begins now.
Good afternoon. My name is Hallie Yee, and I'm a policy coordinator at the Coalition for Asian American Children and Families. I want to thank both Chair Levine and Chair Rivera and the members of both committees for holding this hearing. While what I say today has a huge focus on the Asian American community, as that is who our organization specifically serves, we have ensured that our demands align with other communities of color throughout this process. Because this pandemic has exacerbated longstanding and interconnected crises in socioeconomically disadvantaged communities such as ours. Unfortunate and heartbreaking, it wasn't entirely unexpected. For Asian Americans, our communities are historically overlooked and our needs misunderstood or entirely uncounted, meaning we often lacked resources to provide critical services for those in need in our communities. And this has never been more apparent than right now. We convened over 40 organizations, most of which are APA-led and serving, all of which are organizations of color, to create these initial calls to action. We demand specific and granular disaggregated data on infection rates, hospitalizations, and deaths in the APA community and in all communities of color. But specifically within the APA community, there are over 40 ethnicities, and we know that about 10% of deaths in New York City have been categorized as other. And from our historical perspective, we know that a lot of Asian Americans are included in that other. Additionally, all manners of testing in our communities, including the testing of essential workers, availability of rapid testing, and increasing the number of test sites and mobile test centers, especially in underserved neighborhoods, needs to be met. And that includes making sure that everyone knows the difference between viral and antibody testing. I think it's incredibly unclear, especially as those pieces of information are not included in language resources, which brings me to my final point, that additional resources in language for low English proficient communities with special attention to low incident APA languages need to be met. While we have a law on the book that requires up to 10 languages on intake forms, we have seen and heard from so many of our organizations that is not the case, and they're being leaned on heavily, just as they are constantly, to provide those resources and to act as interpreters and translators of resources. Because we ask that the investment must be made in community leaders, community-based organizations, and F2HCs for all areas of this crisis, including planning, the tracing curriculum, training, hiring, and contracting when it comes to contact tracing. And we hope that you guys understand that, and we look forward to continue working with the city to ensure that our vulnerable New Yorkers have equitable access to the resources and services necessary during this crisis and afterwards.
Thank you very much. We'll next hear from Max Tadler. As a reminder to council members, if you have questions for any panel, please use the raise hand function and you'll be called on after the panel is completed, and you'll be on a 2-minute clock. Max Hadler, you can begin after the sergeant cues you. Thank you.
Time begins now.
Great, thank you very much. My name is Max Hadler and I'm the Director of Health Policy at the New York Immigration Coalition. I want to thank the council for the opportunity to testify today and to cover some points that have already been covered and to highlight a few really important points from our more extensive written testimony. As we've heard today, immigrant New Yorkers have been disproportionately affected by COVID-19 in almost every imaginable way. Infection and death are highest in immigrant communities. Immigrants represent more than 1/2 of the city's essential workforce, and mixed status families have been excluded from federal relief programs. These same communities have to be at the forefront of the test and trace design as a protection for them, those most affected by the pandemic, as well as for the city's overall health and its social and economic well-being. On recruitment and tracing, an effective tracing plan requires linguistically and culturally responsive workforce, and some of this can come from training tracers on prominent concerns in immigrant communities like data security and quarantining without job protection or paid leave. But training alone can't create the linguistic and cultural responsiveness on the timeline we're operating under. The city has to hire a team of tracers who come from the communities they'll be serving. And one way to do this is to ease the formal professional and experiential requirements that are written into the existing job descriptions, and to more greatly value the linguistic and community experience of the people who know their neighbors the best. On governance and structure, for both recruiting and training, the city has a really important existing resource. There's a huge network of community-based organizations that already have the trusted relationships and knowledge that can help this effort succeed. CBOs have to be partners in test and trace throughout the entire effort and through existing initiatives like Access Health NYC, through the council, which should be restored in its entirety for the upcoming fiscal year. The NYC is one of the groups that's participating in the aforementioned community advisory board that DOHMH has been convening. We expect this to be one of the venues for ongoing input, but we do need greater public understanding of the test and trace governance structure and its accountability to the community advisory board as it's currently constituted. The mayor's incomprehensible decision to strip control of tracing from DOHMH complicates that effort. But at the NYC, we have a positive working relationship with both DOHMH and with Health and Hospitals, and we're prepared to work with whoever's involved as long as our communities come first and our voices are part of the process. On data security, and really importantly around the messaging around data security, this is a very big concern for immigrant communities. Call scripts need to be clear on confidentiality and that no information related to status will be collected or stored. Data that are collected should not be linked to any other source that may contain immigration status related information, including any records for existing patients at Health and Hospitals. We also need greater clarity on how Health and Hospitals' role as a healthcare provider will not be conflated with its role as a contact tracing entity in speaking with community members, and how the contact tracing effort will be conducted equitably and coherently for New Yorkers who are Health and Hospitals patients and for those who are not. A final point is around the exclusion of hundreds of thousands of immigrant New Yorkers from federal relief programs, and that this will inevitably inform decisions that people make. And so in asking people to quarantine and to skip work, we need to understand that immigrant families do not have the same protections as many others. One thing the city can do is to create a publicly funded emergency cash assistance programs for people left out of federal relief packages and explore paid leave protections and financial supports for anyone who's told to self-isolate as a result of contact tracing. Essential workers are immigrant New Yorkers. 53% of the workforce is immigrant New Yorkers. If we don't put these communities first, we will fail as a city in the fight against COVID-19. Thank you.
Thank you very much. We'll next turn to Councilmember Torres, who has some questions. As a reminder, council members will be on a 2-minute clock, and please be clear who you're asking questions to so that the host has time to unmute them. Thank you. Councilmember Torres, you can begin once the sergeant cues you.
Starting time.
Thank you. I have a question for Henry Garrido. Is he still present?
I am. Sorry, Councilman, I am.
So, Henry, do you know if the administration envisions the new contact tracing workforce as temporary or permanent, and what is your position on that?
So the nature of the job is an 18-month job, which we envision to be done under the temporary hiring under the civil service rules of the state of New York. So those positions will be done there, and then we will go from there. I think one of the problems that existed in having this outside entity do the hiring and the promotion is that we were basically cherry picking from our internal staff already hired. So if they would have gone and worked for this third party entity, they would have lost all seniority, all credits of pensions, everything. Even health insurance was even though they were going to get paid more. And that's what I meant, that it would have been an insult to the people already doing the work. Because they need the pension, they need the respect as frontline workers to maintain those benefits. So some of the things that we're exploring now is to having workers on loan, so to speak, take the leave from one department and go to another, because they've been doing this. Like, as I said, we have over 300 people already doing contact traces. It's not new. We've done this since SARS, Ebola, H1N1, swine flu. We've been doing it forever. We're doing it now. So like the proposal to have contact tracers to be on the call centers and contact tracers to be on the field, that's what our members are doing right now. So I think that the idea of a temporary assignment is fine. They will have jobs to come back to, we hope, right? But at this time, I think that we've already worked out all the kinks in the hiring process.
Can I quickly squeeze in a question to Albert, or? Albert, I know you're a skeptic about digital contact tracing. What is your opinion on voluntary opt-in, opt-out contact tracing? Is that something to which you would be amenable?
Councilmember, thank you so much for the question. We're quite concerned that while the technology may require you to check the box that I agree to the terms of service, that a lot of people will be coerced by their employer to take part in it, that they'll be coerced by schools to take part in it as the condition of attending class, that we'll see it becoming functionally coerced by all these other entities in our lives. And right now there aren't legal protections to prevent people, especially low-income employees, from being coerced in this way. So, and as we've seen from Singapore, where they only had 12% voluntary adoption rate, it was a disaster. They now have the highest rate of infection in Southeast Asia. And so we are quite concerned that you simply are not going to get enough voluntary participation with any Bluetooth model or any of these other technology-assisted contact tracing models that would enable them to actually be effective. It would require some sort of coercion to get that level of buy-in.
Thank you very much to this panel. We'll now hear from our next panel, which will include Chris Norwood and Kaushal Chawla. Chris Norwood, you may begin once the sergeant cues you. Thank you very much.
Time begins now.
Thank you very much, Chairs Levine and Rivera, council members and panelists. I'm Chris Norwood, Executive Director of Health People in the South Bronx, and I want to talk about communities and community group participation. We would like to thank the city for already launching a community advisory board. That is a major first step, but now we have the next step, which is to assure that communities, above all the stricken communities, are fully integrated in this mammoth effort. And the primary way to do that is subcontracting key responsibility to those groups that are already there and fully engaged in their communities. After contact tracing takes place, there is, of course, intensive follow-up and support, which will have to occur for the person contacted and for their families and households. This will be time-consuming, culturally sensitive, and require a real range of languages. 1,000 contact tracers, even with resource navigators, simply will not have the time. But more important, community groups already skilled and dedicated to helping people in distress from a range of cultures, and very important for this, a range of age groups are already there. This community role is very much in keeping with the public health core that Chair Levine has proposed and outlined. And yet I haven't really seen anything in this that shows me that there is now planning to start to look at this real kind of integration of community groups. But there's another key aspect of community follow-up that has received little attention. Virtually all COVID-infected people and many of their family members have what are called underlying conditions. Actually, they're very evident conditions, particularly diabetes, high blood pressure, heart disease, obesity, and kidney disease. The city has never had a comprehensive chronic disease prevention and control program. To the contrary, it has now for decades left Black and Hispanic communities and others completely gripped by uncontrolled chronic disease, which now with COVID has overwhelmed them. Even though the City Council ordered the Department of Health to make a plan for the control of diabetes, which is still the most widespread epidemic in this city, we still don't have one. Let us start now to lower the terrible risks in these neighborhoods, and as part of contact tracing follow-up, finally start to have evidence-based chronic disease self-care and preventive education. Here is another outstanding role for community groups and a health corps. If we go through all this, only to leave the same neighborhoods and the same people and the same horrific risks from ignored and unaddressed chronic disease, we might as well just all start crying right now. Thank you.
Thank you very much. We'll next hear from Kaushal Chawla. Please begin after the sergeant cues you. Thank you.
Time begins now.
Good afternoon. My name is Kaushal Chawla. I'm the CEO of the Charles B. Wong Community Health Center. We have health centers in Manhattan and Queens, primarily serving the city's Asian American community. And 88% of our patients are at or below the 200% federal poverty line. Our health centers have stayed open for the community through the pandemic, and we're caring for patients through in-person and virtual channels, and are very proud to be part of the response. Testing and tracing will play a really important role in our recovery, and I wanted to share perspectives about two drivers of success for the program. First, I want to highlight the importance of having testers and contact tracers with appropriate language skills and understanding for our diverse communities. This is pretty critical for building trust with our community and ensuring that there is actionable guidance given to patients. So for example, for the city's Chinese American community, appropriate dialect ability must be considered. For our community, for example, about half are Mandarin speakers and a quarter are Cantonese speakers. Second, I wanted to emphasize the need for protocols in place to provide guidance to patients about their results and making sure they understand the guidance. So for example, if a patient tests negative, is there anything they can do now that they could not do before? We feel providing results without translating them into a plan would limit the utility and purpose of testing. So thanks for the chance to share those perspectives, and thank you to the Council for their support, which often fills critical gaps in funding, especially for communities of color and undocumented. Thank you.
Thank you very much. Seeing no council member questions for this panel, we'll next turn to our next panel, which will include Theo Oshiro and Anthony Feliciano. Theo Oshiro, you may begin once the sergeant cues you. Thank you.
Time begins now.
Hi, my name is Arlene Cruz. I'm the Health Programs Manager at Make the Road New York. I'm testifying on behalf of Theo Oshiro, which is Make the Road New York's Deputy Director. I want to start by just thanking the Committee of Health and the Committee of Hospitals for the opportunity to comment today. The communities that we serve are among the hardest hit by the crisis. Our large base in Central Queens, the epicenter of the epicenter, where Elmhurst Hospital has been in the national spotlight, heroically trying, even with diminished resources, to have some of the most impactful community members. We applaud the city for putting science and healthcare at the forefront in order to address these pandemics. Testing and contact and tracing must be a part of how we make decisions on reopening our city. We need a responsible public health approach, and we must undergo these efforts with impacted community members at the forefront as a solution for the implementation as a city. As the city moves forward with hiring thousands of contract tracers, it's important that these individuals are from the communities most impacted by the crisis. We need contact tracers in every community, but they must be representative of the community in which we are based and culturally, linguistically competent. They must be part of and trusted by the community they will be charged with tracing and supporting. These individuals who are deeply connected to the community and have the language and interpersonal skills that are needed for these roles may not meet professional educational requirements, but would serve as excellent contact tracers due to their connection and knowledge of their communities. The city should reflect these needs and values when hiring contact tracers, and they should work directly with community-based organizations to find the right people and for advice on using the right strategies to eliminate this disease in the most impacted communities. There's an enormous risk at this moment that in our haste to contain the pandemic, will allow or enable terrible breaches in privacy connections. We applaud the city for so far skewing most tempted but unreliable technology, enabling tracking approaches. If technology-enabled methods are ever considered, it is crucial that the city implement clear and enforceable prohibitions against use of the individual or aggregated data for profit or for other purposes other than to protect the public health. Of course, all data collected must be managed to ensure anonymity. Enforceable requirements for data destruction is also imperative. Finally, no single misuse of contact tracking data would more effectively undermine public trust and participation than if that data were to fall into the hands of the NYPD and other law enforcement agencies, including ICE.
Time expired.
Thank you.
Thank you very much. We'll next hear from Anthony Feliciano. You may begin once the sergeant cues you. Thank you.
Time begins now.
Thank Councilwoman Carlina Rivera and Councilman Mark Levine and other council members and Speaker Corey Johnson. I'm Anthony Feliciano. I'm the Director of the Commission on the Public Health System. We know the virus does not discriminate. However, the impact is anything but equal. That's why we identified 3 major areas of concern that I won't go in full detail, but I hope you read those details from our coalition work. One is access to testing. The other one is behavioral dimensions to testing. and the other one is what we think is social determinants of testing. Some of it has been discussed back and forth. But I think there's important elements that we'd like the city council to look for. The launching of hiring and training of tracers from the city. There's a history of both major errors, but also phenomenally successful efforts of contact tracing in an exceedingly difficult situation, from TB to HIV/AIDS to hepatitis. Quick hiring should not be at the expense of in-depth training, including unbiased awareness, and making sure we have the right people who have the right skills does not always mean people with bachelor's or master's degrees. And most importantly, people that can demonstrate patience, empathy to listen, and including linguistically and racially and ethnically diverse. Locating patients and contacts who may be difficult to reach or reluctant to engage in conversation is another area. Strangers calling individuals, especially immigrants, who already fear government and accessing services due to federal government tax and public charge. No one should feel they cannot get tested or avoid tracing calls due because they fear that it will lead to deportation. The other thing is the rising eagerness for automated technology as a key for infection control. In the past, it has served as a vehicle for abuse and disinformation. They could potentially provide a false sense of security to justify reopening our economy. Will it be safe to do so? In addition, we have a digital divide and a digital denied. Also, policy of quarantine and congruency with those decisions. Quarantine measures have a history in our country to disproportionately harm communities of color and immigrant communities. And if we impose a very too heavy a hand or in too haphazard of a manner, they can be counterproductive. Therefore, there's things that we need to discuss. Demand all appointed committees and task forces are led by those impacted. Contact tracing and isolation are expanded. Public health personnel will need to counter stigma and fearfulness with positive messaging, affirming contribution to public health. Efforts to self-isolate in their home or location of their choosing will be more successful than restrictive or punitive measures. Local trust, peer engagement, community knowledge, and participation be a part of the planning and implementation. As enough tests to all New York City must be available, it will be critical for public health personnel, community-based organizations working in leadership in that, to employ a social determinants of health framework for testing, basing interventions on systems and contact exposure, and not profiling people of particular job types. Tests must be available during evening and on weekends. Compliance with city sick leave policy will need to be enforced. An individual with positive tests must receive documentation from the city validating they need to stay home, self-isolate. The other thing is to address the following types: language access and provide information, including emergency Medicaid, how to address chronic disease and disability, how to engage the community-based organization, and also anonymity, protect people from surprise medical bills, and also the data to be better disaggregated so resources can be targeted. Thank you.
Thank you very much to this panel. Seeing no council member questions, we'll cue our next panel, which will include Mark Harrington and Guillermo Chacon. Mark Harrington, you can begin after the sergeant cues you. Thank you.
Time begins now.
Good afternoon. I was trying to use the video. I don't know if you guys can see me, but this is Mark Harrington from the Treatment Action Group in New York, and I'm also a member of the COVID-19 working group that Charles mentioned before. I'd like to thank the chairs and particularly my local council member, Rivera, for co-chairing this session, and our speaker. I have a few thoughts based on today, and I'll submit the rest in my written testimony. The first is that we heard of a question that wasn't fully answered, which is how is health and hospitals going to manage the expected surge, which many public health experts from Dr. Fauci on down expect to happen with new COVID-19 cases with all these new responsibilities with test and isolate and trace. The second is that with 40 staffers going from DOHMH to H&H, how is DOHMH going to respond to the expected surge in new cases of HIV, tuberculosis, sexually transmitted infections, viral hepatitis, or overdose, when they'll be crippled because 40 of their 200 staff will be moved over to the H&H. Thirdly, it's clear that the city still lacks a clear testing policy or target, since we couldn't even get numbers from them that were coherent, consistent, and quantitative about how many tests we need a day for PCR and antibodies. The whole City Hall response has been marked by infighting, poor communication, and denigrating of DOHMH. And this really has delayed the response in being able to ramp out a coherent test and trace system. We're very concerned about the worst affected communities and how they're going to be poorly affected by an incompetent group of people carrying out contact tracing who are newly hired and may not have enough management oversight by DOHMH. And finally, we feel that this proposal has the potential to permanently damage DOHMH, and we're very disappointed in City Hall acting like a mini White House coronavirus task force on the Hudson, not ignoring public health and putting politics above saving lives. Thank you for the opportunity to testify.
Thank you very much. We'll next hear from Guillermo Chacon. You may begin after the sergeant cues you. Thank you.
Time begins now, sir.
Thank you. Thank you for the opportunity. Can you hear me? Yes.
Yes,
okay.
we can hear you.
Thank you. Thank you, New York City Speaker Corey Johnson, the chairpersons Rivera and Levine, and all the members of the Health and Hospital Committee and other council members that attended this hearing, and for this opportunity. The impact of COVID-19 has been overwhelming. We at the Latino Commission on AIDS and the Hispanic Health Network and community partners are extremely concerned, alarmed, and shaken by the impact of COVID in our city, and especially among people of color. We want to make sure that everyone is accurately informed, fear-free, safe, healthy, and stigma-free, particularly those most vulnerable, such as older adults, people with compromised immune systems, and the already socially and economically marginalized. As we face COVID-19, we inquire on the health status of Hispanic and Latinx communities. We are 29% of the city population, 80% of the state, and we are a vital part of the progress in our city. Despite that central role of Hispanics in our economy, we are deeply, deeply concerned of the status of our health as a community. We represent more than 2% of the total deaths. And the data showed only partially reflect the real impact of COVID-19 on Hispanics and all New Yorkers. And again, we truly believe that we have several barriers. Among others, I will say homophobia, transphobia, and xenophobia in our different services and institutions, discrimination in healthcare and delivery of public health policies, and of course, the poverty and lower socioeconomic status, the incarcerated, the homeless, and the employment instability impacted by their ability to enact social distancing measures is a reality in our communities. We strongly believe and request to address those barriers, and we truly believe that we want to partner with all our institutions, support the Palacio administration, the leadership of Dr. Barbeau, Dr. Cost, and the entire council to truly take the time to pause and redesign, readapt, reimagine, and tailor a more comprehensive multi-year public health strategy to learn from this horrible global pandemic. Again, we are concerned, and as a part of the coronavirus work group here in New York, we truly believe that the administration need to pause and assess the decision that they make, but truly also embrace the realities that my brother Garrido mentioned to date, and also embrace all the communities impacted and affected.
Time expired.
Thank you very much to that panel. Our next and final panel will include Kelly Grace Price and Kim Watkins. If we've inadvertently missed you and you intended to testify, please use the raise hand function on Zoom, and we'll be sure to add you afterward. In the meantime, Kelly Grace Price, you can begin after the sergeants cue you. Thank you.
Time begins now, Miss.
Hi, thank you so much. I'm Kelly Grace Price. I work at Close Rosie's. For many years before my false arrest, unlawful detention, and malicious prosecutions, I worked in top-tier international technology and business firms as a technology architect and as a project manager for complex financial and media systems. I worked for a corporation privately owned by Bill Gates, who sent me around the world to Hong Kong and Kuala Lumpur to open offices and architect his business systems. I worked for banks like JP Morgan Chase to move their entire infrastructure from New York to Delaware right before 9/11. I appeared today to submit comment on the broad outlines of the contract tracing program as it has been presented to date. I've been advocating for accountability and oversight by the NYPD and city DAs for the better part of a decade since my false arrests. And I don't see that this program that brings us anywhere closer to transparency in these systems. Despite my advocacy efforts there for over a decade, these systems are still oppressing us, and I fear the same potential ebbing within our civil rights currently tucked into the H&H programs to build a COVID contract tracing entity. Please warn me when I only have 1 minute left. I want to talk about 4 main points, and I'll try and get through them quickly. I want to talk about oversight of the technology. I heard Jessica Tisch's name offered by H&H over and over and over this morning. Why isn't she here to answer these questions? It seems like the buck stops with her. We know her family's ties to famous Wall Street and technology firms, to K2 Intelligence, to Palantir, to the Knoll family. All of these shadowy and murky institutions have still evaded full transparency and oversight by the city council into the systems that oppress us, such as Palantir and Cobalt. And that brings me to Salesforce. Who made the choice to use Salesforce as the technology that will be the primary platform? 1 minute, thank you. Quickly, Salesforce, the data is in a cloud. Is that really where the security that we need? Will the essays at Salesforce have the same access to this technology as the essays at Palantir have? Salesforce has a major political PAC that gives to New York City politicians that happen to have leadership positions in districts where H&H hospitals are. Has anybody investigated the financial ties between Mark Benioff and H&H? Quickly, I agree with Inez Barron. The data will be subpoenable. I'm really worried about this from a formerly incarcerated woman's perspective, because the lion's share of women going into Rosie's right now are going in on technical parole violations. So they're not going to share their contacts if they've associated with another known felon, because that will be a technical parole violation and they'll go back in. So oversight is key. We didn't get a correct answer from H&H as to whether or not this data will be subpoenable. I'm really worried about this. Also, everyone I know buys weed. No one's going to give you the weed dealers' contacts. Most of us don't even have their contacts. We just go to the corner. Quickly, who are the people being hired to be the disease detectives? I've heard that they're all auxiliary NYPD and that those people are getting priority to be hired, just like vets get priority to be hired at the post office. Thank you. I've submitted my written testimony. Please consider it. It's well written and it's better presented than my oral testimony. Thank you so much.
Thank you very much. We'll next hear from Kim Watkins. You may begin once the sergeant cues you. Thank you.
Time begins now.
Thank you so much. Hello, everyone. My name is Kim Watkins. I really appreciate the opportunity to speak today. I am a public school mom from Harlem. I'm an elected parent leader in District 3. I'm a member of Parents Supporting Parents, an advocacy group, and my remarks today are regarding school nurses. I prepared my remarks in conjunction with some amazing school nurses that have worked with me on some of the points today. I want to start by saying, I want to echo some of the other speakers in terms of their remarks about what the purpose of this sort of tit for tat between DOH and H&H sort of boils down to in terms of the things that are happening on the ground with school nurses. We have a piece of the puzzle that we're missing when it comes to the way that the school operation functions with regard to school nurses. It's an issue that's been festering for years, and it has to do with the fact that about 1/3 of our school nursing staff is hired out as private contract nurses. Those private contract nurses are nurses that do not have access to the ASHR system, the Automated Student Health Record System, which is a key part of the way that we are informing the city's syndromic surveillance, which works in conjunction with contract tracing to inform and synthesize action plans for our city. So as last week, the Panel for Educational Policy just approved 2 new contracts to hire more private agency nurses. what we are faced with is the idea that we're going to reopen schools in the fall with a hole of about 700 nurses working for our school system. We have to solve this problem and bring pay parity and the discussions around how we employ nurses full time if we want to activate and complete that or lock in that communications gap that has been going on for a long period of time. I also want to just point out that no nurses are on the task force, the mayor's task force to reopen schools. That is something that I hope this committee, these two committees can be sort of pressuring the mayor to reconsider. It would be really important for all of us to appreciate the wisdom that would come from that group. And lastly, I want to point out that as we think about the three pillars that Dr. Katz mentioned earlier as part of our overall communications plan and our contact tracing and testing plan, schools have to have reliable testing protocols and space for isolation, something that they have neither of right now. New York State Nurses Association put out an advisory just this week on more complete considerations, and I will include that link in my written testimony update when I submit it a little bit later today. Thank you so very much, and have a great day, everybody.
Thank you very much. Again, if we've inadvertently missed anyone that would like to testify, please use the Zoom raise hand function now, and we'll be sure to call you. Seeing no others sign up to testify, I'll turn back to Chair Rivera and then Chair Levine to close out the hearing and for closing statements. Thank you. Chair Rivera, you can begin first.
Sure. Thank you so much, everyone, for staying with us for 5.5 hours to hear from the health experts of our city, to hear from advocates, concerned citizens, and of course, all of my elected colleagues who are here today to ask honest and open questions. This is an unprecedented challenge during one of the most tragic moments in our history. And we tried our best to bring the reasoning and decision-making behind this decision and this transition to the people of New York City. I think what we want more than anything is to get the job done, is to make sure that we are doing it equitably and that we are taking care of some of our hardest hit communities as soon as possible. We support every effort to get us through this. There is a long way in front of us, and we're up to the challenge. So I just want to thank everyone for being here, for their patience, for waiting, for testifying, for being open to communicating with us going forward, to try to ramp up this initiative and make sure that we get through it together and in solidarity. Thank you so much, everyone. Chair Levine?
Well, thank you, Chair Rivera, for your great work throughout this hearing and for your remarks. I want to note how remarkable it is that we still have Dr. Katz with us, and I think Dr. Varma as well. That's not normal protocol, but it does mean a lot that you've stayed to hear members of the public, every one of whom had something important to add. And I want to thank the significant number of our colleagues who contributed to this hearing and are still with us. I see we still have council members Ampry, Samuel, Yeager, Barron, and Holden still with us. Thank you for your comments earlier and for staying with us. It is so critical that the public have understanding and trust in contact tracing. That requires total transparency. And I think what we did today has advanced that cause by surfacing many important details of the program and by identifying questions that still need to be answered. But this was an important step forward. So I'm proud of the work we did here today. I want to thank everyone who contributed. And now I get to gavel out. And that concludes our hearing. Thanks, everyone. Be safe.
Staff, thank you so much.
Thank you.
Take care, everyone.